Hello, good morning, Dr. Manjunath. Sir, can you please unmute yourself?
ये क्या कर रहे हो? रिकॉर्डिंग कर रहे हो? आवाज रिपीट हो रही है।
Hello.
शेयर किया गया तुमने शेयर किया है
Hello, good morning, Dr. Manjunath. Hello.
हेलो 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 हेलो
Playing the record.
हेलो
अभी तो सर
हेलो
30-20
हेलो मैम
Hello, Dr. Manjunath. अब इनकी
आ रही है ना हाँ?
आवाज
बोलिए
हेलो डॉक्टर मंजुनाथ.
ठीक सही है जून बता रहा थी
Hello? Hello?
Hello.
Hello? Hello?
Hello.
रविंदर कहाँ है यार?
अभी निकला ही नहीं है सर कोई।
आ रही है ना तुम्हें?
आवाज नहीं आ रही?
लगाओ।
अरे क्यों नहीं आवाज आ रही भाई?
हेडफोन दो।
हाँ अभी तो फ्री पेपर का है ना 9 से
हेलो?
11।
हेलो, आवाज आ रही है?
आ रही है सर आप लोगों को आवाज?
या
यस,
आई एम
ओके सर।
गेटिंग योर वॉइस।
ओके सर,
Yeah.
नो प्रॉब्लम।
ओके।
Hello, good morning.
Good morning.
Sir, you are able to hear me?
Yeah.
Sir, today we are going to start this e-research paper session, and I would like to welcome the chairpersons and the participants to the session. And the flow of the session will be, sir, we'll start playing the video of the participant, and once the video is over, then we have 2 minutes time for the discussion, sir. After 2 minutes, then we'll start the next video. Okay, sir.
Yeah.
I'll just start playing the videos. Sir. So the next, the video is going to be of Dr. Namrata Kaushik.
Good morning, everyone. The title of my research is Comparison of Nalbuphine versus Clonidine as an adjuvant to intrathecal hyperbaric bupivacaine in orthopedic lower limb surgeries. Despite all the recent pharmacological advances, pain is still a major concern in orthopedic surgeries. Adjuvants are frequently used with local anesthetics during central electrical block to prolong the duration of analgesia and enhance the quality of block. Nalbuphine is a highly lipid-soluble synthetic opioid acting as kappa agonist and mu receptor antagonist. It causes activation of supraspinal and spinal kappa receptors, producing analgesia, limited sedation, and respiratory depression. Clonidine is a mixed alpha-1 and alpha-2 adrenoreceptor agonist with predominant alpha-2 action. It is also associated with hypotension and bradycardia. We found limited literature with inconsistent results comparing the two drugs. Therefore, this study was planned with the aim to compare the effects of nalbuphine and clonidine as an intrathecal adjuvant to hyperbaric bupivacaine in orthopedic lower limb surgeries, and its study effects on duration of spinal analgesia, characteristics of sensory or motor block, post-operative pain assessment and total analgesic requirement in 24 hours, and advanced events. The study was a prospective randomized controlled double-blind study conducted in the Department of Anesthesiology of UCMS and GTB Hospital. After clearance from the Institutional Ethical Committee, written informed consent, and clinical trial registry, ASA 1 or 2 patients between 18 to 60 years with height more than 150 centimeters and less than 180 centimeters were included in the study. Patients with contraindications to central neurological block, weighing more than 120 kg, with history of chronic pain or long-term opioid use, or with known allergy to the drugs involved in the study, and multiple fractures precluding the assessment of anesthesia were excluded from the study. After routine pre-anesthetic checkup, patients were introduced to visual analog scale, and 63 patients were randomly allocated to group N, receiving 1 milligrams of nalbuphine, group CL, receiving 30 micrograms of clonidine, or group C receiving 0.5 ml of normal saline, in addition to 15 milligrams of 0.5% hyperbaric bupivacaine. Spinal anesthesia was performed using standard protocol, and sensory and motor block characteristics, hemodynamic variables, and side effects were noted at regular intervals. In the postoperative period, pain assessment was done for 24 hours, and at VAS more than or equal to 3, injection diclofenac 75 mg was given intravenously. Sample size in statistical analysis, at alpha equals to 5% and power equal to 90%, at sample size of 10 patients were required in each group. Due to the availability of resources and time, we studied 21 cases in each group. Quantitative parameters were analyzed using student t-test or Mann-Whitney test. Comparison between the groups and repeatedly measured variables were analyzed using ANOVA, followed by Tukey's or Dunnett's test. Qualitative parameters were analyzed using chi-square or Fisher-Exact test, and a p-value of less than 0.05 was considered significant. 65 patients were assessed for eligibility, and 2 patients were excluded. 63 patients were then randomly allocated to group of 3 into 3 groups of 21 each. During analysis, 1 patient was excluded from control group due to failed intervention. Results: all the 3 groups were comparable in terms of demographic profile, except for age, which was significantly lower in group C. Onset of sensory block and time to achieve maximum level was significantly faster with nalbuphine as well as clonidine as compared to control. However, it was comparable between the two. Onset of motor block was significantly faster with nalbuphine as well as clonidine. However, between nalbuphine and clonidine, it was faster with clonidine. Time to 2-segment regression, duration of motor block, and duration of spinal analgesia was prolonged with nalbuphine as well as clonidine. However, it was longer with clonidine. Total number of rescue analgesic doses required was least with clonidine, and it was maximum with control. Comparison of VAS at different time intervals showed lower VAS scores in group CL as compared to the other 2 groups till 1.5 hours in the postoperative period. This is a figure showing comparison of intraoperative mean heart rate and blood pressure, which was comparable among the 3 groups. This is a figure showing comparison of postoperative mean heart rate and blood pressure, which was comparable among the 3 groups. Discussion. Onset of sensory block and the time to achieve maximum height sensory block was significantly faster with both nalbuphine as well as clonidine. However, it was comparable between the 2 groups. Similar results were reported by Shetty et al. And Kumar et al. Time to 2-segment regression was significantly prolonged with both nalbuphine as well as clonidine. However, in our study, it was more prolonged with clonidine as compared to nalbuphine. Similar results were reported by Bansal and Shetty et al. Despite using 0.8 milligrams of nalbuphine and 30 micrograms of clonidine, Kumar et al. Reported more prolongation of time to 2-segment regression with nalbuphine as compared to clonidine. Onset of motor block
Hello. I think it is hanged.
Was faster with both nalbuphine as well as clonidine. However, it was more prolonged. It was faster with clonidine when compared with nalbuphine. Shetty et al. Reported faster onset with nalbuphine and clonidine, but it was comparable between the two. Duration of motor block and duration of spinal analgesia was both prolonged with both clonidine as well as nalbuphine as compared to control. However, when clonidine was compared with nalbuphine, it was longer with clonidine. Similar results were reported by Shetty and Bansal et al. However, Kumar et al. Reported contrasting results. 24-hour rescue analgesic requirement was least with clonidine. It was lesser with nalbuphine than with the control. Similar results were reported by Shetty et al. However, Kumar et al., despite using lower dose of nalbuphine, reported lesser amount of analgesic requirement than nalbuphine. The three groups were comparable with each other in terms of side effects. Limitations. Further studies with larger sample size, different doses, and different study populations can be conducted. We conclude that the clonidine was superior to nalbuphine as an intrathecal adjuvant to hypereuric bupivacaine for orthopedic lower limb surgeries with no significant adverse events. These are my references. Thank you.
Hello. Hello.
Good morning, sir.
Good morning.
This is Dr. Hina Agarwal.
My question is here in this study, side effect of nalbuphine when we give intrathecally didn't mention.
Yes,
And
yes, sir. We reported sedation on 2 and 3 patients, but it was statistically insignificant. That's why I'm not.
okay. And second is when basically in the clonidine, when we give the clonidine, bradycardia and hypotension in some patients, I have also done study with clonidine intrathecally. Some patients show significant hypertension and bradycardia.
Yes.
Yeah, but these side effects also not mentioned in this study.
Yes, sir. We reported clinically there was hypotension. We didn't report any bradycardia, but there was hypotension in 4 patients, but it was statistically insignificant among the 3 groups.
Okay. And madam, what was the method of randomization in this study?
Sir, it was double-blind controlled randomized. Actually, I was the one who was doing the who was giving the spinal anesthesia, as well as looking for the observing the sensory and the motor parameters, and the test drug was prepared by somebody else.
Time's up. Thank you.
Thank you, sir.
Sir, the next paper is of Dr. Mrudula.
Good afternoon, everyone. This is Dr. Mrudula. Thank you, Isacon, for giving me this opportunity today to talk about my topic under research paper. Today, my topic is about comparison of various end-tidal MAC anesthetic concentrations to various entropy indices. Coming to the few introductory points before I go into the topic, minimum alveolar concentration is a common terminology which we use when we use inhalation anesthetic gas concentration. It is nothing but the target end concentration, which is needed in 50% of the patients to actually complete immobilization or stop the skeletal muscle activity for the surgical stimulus. But this MAC tells only about the effect on spinal cord, doesn't tell about the hypnotic effect on the brain, which is very important to know the awareness among the surgically anesthetized patients. For this monitoring, we need a depth of anesthetic monitor. So the long back ago BIS monitoring was started, which uses spectral edge frequency of 95%, and over a decade, new parameter which we have come across is entropy parameter. In our study, we use sevoflurane as an inhalational agent because this is most commonly used worldwide present. And one more parameter terminology is end-tidal anesthetic gas concentration. End-tidal anesthetic, to achieve equilibrium between the alveoli, brain, and the blood, we need a particular equilibrium time. The concentration of inhalation agent at the brain denotes the perfect hypnotic effect. So the end-tidal anesthetic gas concentration denotes the concentration of the inhalational agent in the brain. So we thought this could be a surrogate marker to that of the entropy marker, which both tell about the awareness during the surgery. So few points about the entropy monitoring. Entropy usually detects two parameters. One is EEG monitoring as well as frontal electromyography. Frontal electromyography is mainly due to the frontalis muscle contractility. And response entropy and state entropy are the two parameters which we look at in the entropy. Response entropy is a fast parameter which is seen in less than 2 Hertz, which ranges from 0 to 100. So it mainly detects the frontalis muscle activity as well as the electroencephalogram. The most specific marker would be the state entropy, which mainly detects the EEG pattern, which mainly depicts the hypnotic effect of the anesthetic agent. So it ranges from 0 to 91. So when we divide from 0 to 100, 40 to 60 is a desirable range of the entropy values which we needed for general anesthesia. So main aims and objectives of our study is to evaluate whether that end-tidal anesthetic gas concentration of a particular MAC value could be used as a surrogate value of similar to that of entropy, even when we don't have an entropy monitor. Our study is a prospective cohort study studied at Manipal Hospital, Bangalore from October 2019 to December 2020. We included 60 patients in our study. Inclusion criteria includes ASA1-2 category patients of age 20 to 70 years who underwent major elective surgeries lasting more than 2 hours under inhalational anesthesia. Exclusion criteria included cardiorespiratory abnormalities, liver dysfunction, renal dysfunction, COPD, pre-op neurological deficits, pregnant lactating women, morbidly obese, and who received intravenous anesthetic agents. The main parameters which we noted preoperatively were demographic data. Intraoperatively were of the prime importance in our study, where we considered 3 different end-tidal anesthetic concentration. That is, at 0.8, 1, and 1.3 MAC, we calculated what entropy values we achieved. That is both RE and SC values. Along with that, we included heart rate, mean arterial pressure, intraoperative CO2, temperature monitoring, incision time, extubation time. Post-operatively, hemodynamic parameters were also noted. In statistical analysis, mainly our study included mean plus or minus standard deviation for continuous variables, number and percentage for categorical variables. P-value less than 0.05 is considered significant. In our results, demographic data, when we included, each patient himself acted as a test as well as a control. So we didn't have any other groups to compare because in each patient we have taken 0.8, 1, 1.3 MAC to compare the RE and SC values. So coming to the demographic age, mean age was 44.6, mean height 164, mean weight 66.5, mean BMI 24.4. When we saw response entropy values at 0.8 and 1 MAC were more than enough to achieve a range of 40 to 60 entropy values both during the incision time as well as during washout time. state entropy, which depicts the exact needed hypnotic effect of the inhalational agent, we found the end-tidal MAC of 0.8 was more than enough to achieve the range of 40 to 60. The 1 and 1.3 MAC, the values decreased to less than 40. Studies have shown that when value decreased to less than 40 during the general anesthesia, when values of entropy decreased to less than 40, patients had long-term morbidity and mortality on long-term basis. And the other disadvantages were unnecessary use of inhalation agents, theater pollution, etc. So when hemodynamic parameters did not much affected in our study, only 2 patients of 1.3 MAC had bradycardia, which were treated with atropine. So coming to discussion part, target anesthesia to achieve for any anesthetist depends upon 2 things: to achieve perfect cortical components as well as subcortical components. Cortical components dealing with unconscious amnesia, subcortical antinociception, immobility, autonomic stability. We need to achieve all these 5 factors in our to achieve perfect anesthesia, which needs multiple monitoring. To decrease the multiple monitoring, so we thought whether one parameter or one monitor which could replace entropy, and we took it as end-tidal anesthetic gas concentration. Immobility was a different entity which couldn't be assessed by any other monitor other than the neuromuscular monitoring. So previously, one of the study where evidence has shown that this monitoring and end-tidal anesthetic gas concentration, he compared 2 things which could be a better parameter, whether there is a insignificant or significant, and he found that both were equally effective in detecting the hypnotic efficacy, and he found nothing difference in any of the surgery or any of the SA grade patients. So we finally conclude that end-tidal anesthetic gas concentration could be equally be used as the surrogate value when entropy monitoring is not available. And in our study, we found 0.8 MAC would be more than enough to achieve the desired entropy values. So these are my references. Thank you.
So any questions?
Dr. Mridula, can you hear me?
Yes, sir. Yes, sir. It's audible, sir.
Yeah, audible. Okay. My question is, when we talk about superior, is it base, or is it entropy or EEG?
Yes. Sir, it was not audible. Can you repeat it, sir?
Okay. My question is, which monitoring is superior when we talk about intraoperative awareness?
Okay, sir. Actually, there was
Okay.
compared BIS monitoring and entropy, sir. They found
and EEG monitoring. I am including one more, that is EEG.
Okay, sir. The sensitivity of EEG, I don't have idea, sir. But BIS and entropy, they have shown entropy is more sensitive to this thing. And when you use electrocautery, and also there is less chances of interference in entropy than.
Why? I know entropy is superior, but why? What is the reason entropy is superior when we compare to BIS monitoring?
The chances of interference of other, like during surgery, electrocautery things and all are less chance of interference is less with entropy. That is why.
Okay, thank you.
Oh, thank you.
So the next presentation is by Dr. Vishal Kamal.
Hello everyone, I'm going to present my study titled Suppression of Perioperative Stress Response in Elective Abdominal Surgery, a randomized comparison between dexmedetomidine and epidural block. Surgical stress result in neuroendocrine metabolic and immunological response, which delay in wound healing and increasing length of hospital stay. Therefore, it is necessary to curb this response. Epidural analgesia and intravenous dexmedetomidine infusion are effective means of suppressing this response. The lack of existing studies, there is only one study comparing these two techniques, that is only during intraoperative period. Aim of my study is to evaluate and compare the effect of IV dexmedetomidine infusion versus continuous epidural analgesia on stress response to surgical stimulus in terms of serum cortisol level, that is primary objective, blood glucose level, hemodynamic variables, and time to request for first analgesia, that is secondary objective. The study was a prospective randomized comparative study conducted in Department of Anesthesia, UCMH City Hospital, Delhi, and registered with CTRA. ASA 1 and 2, age 18 to 16 years, with plan for elective open abdominal surgery were included in my study, and exclusion criteria were obesity, contraindication to epidural block, on steroid or beta block, known case of endocrine abnormalities, or any malignancy. Randomization was done with computer-generated random number table in two groups, Group D and Group E. In Group D, dexmedetomidine loading dose as a 0.6 microgram per kg IV over 10 minutes, followed by a maintenance dose of 0.4 microgram per kg per hour. In Group E, epidural block was established between T9 to T10 or T10 to T11 intervertebral space, and 5 ml of bolus bupivacaine 0.5%, followed by bupivacaine 0.25% infusion at a rate of 5 ml per hour were given. Thorough routine PSC was done. Patient wheel into OR, and GA was induced as per standard institutional protocol with minimum mandatory ASA monitoring. After surgical wound closure, infusion of dexmed in Group D and infusion of bupivacaine in Group E was discontinued. Wound side infiltration was done with bupivacaine in Group D at the end of surgery. Estimation of serum cortisol and blood glucose level were done at 5 time points, that is baseline 30 minutes after surgical incision, at extubation 2 hours, post extubation 24 hours after surgery. According to the previous study by Isacon et al. In with dexmedetomidine and Satlic et al. With epidural analgesia, 25 cases were included in my study. Quantitative parameters were done with student test or man Whitney test, and qualitative parameters were done with chi-square and Fisher-Extreme test. In this consult flow diagram, we can see that in Group D, 25 cases were included, while in Group E, 24 out of 25 cases were included because of failure to insert the epidural catheter in one case. Now coming to results, the demographic parameters in both the groups were comparable. Now, the stress biomarkers, that is serum cortisol and blood glucose level, were compared in Group D and E through this table. We can see that the serum cortisol level were significantly low in Group E in comparison to Group D at 24-hour post-operative period. Well, blood glucose level is significantly low at 30 minutes after surgical incision, at extubation, and 24-hour post-operatively in Group E in comparison to Group D. Ancillary observation include total dose of propofol, fentanyl, and paracetamol were comparable in both the groups, while time to request of first dose of analgesia were comparatively significantly low in Group D in comparison to Group E. Now coming to hemodynamic variability, intraoperative heart rate and mean arterial pressure were compared by these two graphs. The intraoperative heart rate is significantly low in Group D in comparison to Group E, while mean arterial pressure were comparable. Similarly, in post-operative period, heart rate were significantly low in Group D in comparison to Group E, while mean arterial pressure were comparable. Coming to discussion, serum cortisol level increases intraoperatively due to surgical stimulation, owing to result in increasing ACTH level. Epidural analgesia produces extensive afferent block, suppresses this rise in serum cortisol level. We measured serum cortisol level at various time points and found that at 24-hour post-operative period, in epidural group, serum cortisol level is significantly low in epidural. The increase in blood glucose is due to hepatic glycogenolysis, gluconeogenesis, and insulin resistance. We compared to placebo. When compared to placebo, both dexmedetomidine and epidural analgesia reduces the surge of this blood glucose level. However, there is lack of comparative data between dexmedetomidine and epidural analgesia on perioperative glycemic response. We found that epidural analgesia was better for suppression of blood glucose in perioperative period. Dexmedetomidine has inhibitory effect on hypothalamus as a consequent reduction in central sympathetic outflow. This will explain why the intraoperative heart rate is comparatively significantly low in group D, that is dexmedetomidine group, in comparison to epidural group. Similarly, in post-operative period, we have seen previously that heart rate were significantly low in dexmedetomidine group in comparison to epidural group. That is maybe only because of context sensitivity half-life, which range between 4 minutes to 250 minutes. The strength of my study is there is only one study which compared intraoperative stress response, whereas we compared perioperative stress response by dexmedetomidine versus epidural analgesia. Limitations of our study. Our study was not blinded, as some epidural block in dexmedetomidine group was considered avoidable. We are unable to extend the epidural infusion for post-operative period. Our study include both upper and lower abdominal surgery in both groups. Conclusion: a perioperative epidural block appeared to suppress the surgical stress better than intraoperative dexmedetomidine for open abdominal surgery under general anesthesia. Dexmedetomidine, however, provides better hemodynamic stability in terms of heart rate and the time of noxus in intraoperative and postoperative period.
Hello. The next speaker is Dr. Rajiv Kaur.
Good morning, ma'am.
वीडियो भी ऑन करना है।
Hello everyone, my topic is comparison of pre-treatment with low-dose midazolam versus low-dose etomidate for prevention of etomidate-induced myoclonus and pain at intubation, a randomized controlled study presented by Dr. Aidib. Introduction: etomidate, an ultra-short-acting non-barbiturate imidazole derivative, has been widely used in clinical practice as a hypnotic intravenous anesthetic agent since 1972. It has been widely used in general anesthesia and rapid sequence intubation and has exhibited superior properties than propofol and thiopentol in terms of seizure duration potential. However, etomidate is also well known for some adverse effects like pain on injection, myoclonal superficial thrombophlebitis, nausea, vomiting, and adrenocortical suppression. Etomidate-induced myoclonus incidence in involuntary jerky movement has been observed in around 50 to 80% of unpremedicated patients in the past. Past literature emphasized midazolam to be effective drug of treatment in etomidate-induced myoclonus prevention. Additionally, change in etomidate injection regime itself can prove beneficial in reduction of etomidate-induced myoclonus as pre-treatment with its low dose. Aims and objective: to evaluate and compare the efficacies of midazolam and etomidate for prevention of etomidate-induced myoclonus and pain on injection. Material and methods. After obtaining approval from Institutional Ethical Committee and informed written consent, 90 patients of both gender of varying age, 18 to 90 years, ASA grade 1 or 2, having average build were enrolled. Patients having allergy to any of the study drug, history of seizure disorders, primary or secondary steroid deficiency, patient on steroid therapy, morbid obesity, MPG grade 3 and 4, pregnant and lactating patients, patients with cardiac conduction abnormalities and an antiarrhythmic drug, sedative or opioid therapy were excluded from the study. History and examination and relevant investigations were carried out. Pre-anesthetic preparation was done and patients was kept fasting for 8 hours and IV line with ringer lactate was started. Baseline parameters were recorded and patients were randomly divided into 3 groups. The first group patient received 0.015 milligram of midazolam IV diluted to 5 ml in normal saline. The second group received 0.03 milligram of etomidate IV diluted to 5 ml in normal saline. The third group received 5 ml normal saline intravenously as pre-medication. All drugs were prepared in 5 ml identical syringes by an independent anesthesiologist not involved further in the study. 5 minutes after receiving the study drugs, patient was pre-oxygenated with 100% oxygen for 3 minutes along with anesthesia induction with 0.3 milligram per kg etomidate injected intravenously over the period of 20 to 30 seconds. The severity of etomidate-induced injection pain was assessed using a 4-point scale. 0 is no pain, 1 is mild, that is pain reported only when asked. 2 is moderate pain and reported without being asked or reported when asked, and there was associated behavioral symptoms. 3 is severe pain on verbal response, grimacing, pulling the arm, tearing in the eyes. The etomidate-induced myoclonus was assessed over 5 minutes after etomidate injection, and its severity was graded a 4-point scale. 0 is no myoclonus, 1 is mild myoclonus. Patients having small movements in one body segment such as finger or wrist. 2 is moderate, slight movements in 2 or more muscle areas such as face or shoulder, and 3 is severe intense movements in 2 or more muscle areas, sudden adduction of an extremity. The patient and the anesthesiologist involved in assessment for etomidate-induced myoclonus and etomidate injection pain were unaware of the group allocation and followed the blinding protocol. 5 minutes after etomidate injection, muscle relaxation was achieved with 0.1 milligram per kg injection vicurinium, and endotracheal intubation with appropriate size ET tube was performed after 4 minutes. Anesthesia was maintained using 1 to 1.5% of isoflurane and 50% nitrous oxide and oxygen. Heart rate, systolic blood pressure, and diastolic blood pressure were evaluated during the time between injection of pre-medication till 10 minutes after etomidate injection at interval of 5 minutes. The primary outcome of the study was the severity of myoclonus, and the secondary outcome was the severity of pain due to etomidate injection. Statistical analysis. The data tabulation were done by using MS Excel 2010, and statistical analysis was done by using SPSS software 21.0 version and using ANOVA across the 3 groups for comparison continuous variable and Pearson chi-square in case of categorical variables. P-value of less than 0.05 was considered statistically significant in all the tests. Observation and results. The demographic characteristic of the patient such as age, gender, weight were comparable among these groups. Distribution of myoclonus in between the groups. In group 2, 46.67% of the patient has no myoclonus, whereas in group 1, 50% patients has myoclonus, and group 3, 46.67% of patients have myoclonus, grade 3, which is severe. This is the graphical representation. Group 1, group 2 showing no myoclonus, whereas group 1 and 3 showing the myoclonus. The comparison of pain score in between the groups. Group 2, the 46.67% of the patient has no pain, whereas in group 1 and 3, 46.67% and 43.3% patient respectively show the pain, and the difference was statistically significant. This is the graph showing the graphical representation. Group 2 has no pain, whereas group 1 and 3 showing the pain in the grade 3. The current study indicated better results among group 2, that is patient administered priming dose 0.03 milligram of etomidate IV diluted to 5 ml in normal saline as compared to group 1 with 0.015 milligram of midazolam IV diluted to 5 ml in normal saline, and group 3 with patients on placebo of normal saline solution. Around 46.67% of patients in group 2 had no myoclonus and no pain, and the severity was also minimal as compared to other groups. Even though other parameters were comparable among 3 groups and no adverse event occurred, it was observed that the patient in group 1 who received midazolam had significant decrease in heart rate and mean arterial pressure as compared to group 2 and 3. This is the normal effect of midazolam. Conclusion. The current study indicated pre-induction of etomidate in low dose is an effective strategy in prevention of etomidate-induced myoclonus as compared to midazolam. This study highlights low dose of etomidate induction prior to anesthesia during any surgery is a cost-effective treatment modality as it inhibits the unnecessary requirement of another drug introduction to the patient, further preventing any hemodynamic alterations. Even though this study has been useful with its conclusive evidence, the small sample size should be a limitation. This calls for similar study with large sample size for better evidence provision. These are the references. Thank you.
So any questions for Dr. Rajdeep?
Yeah. Hello. I am audible. Hello.
Yes, yes, sir. I'm
You
listening.
are audible.
You are audible.
Okay. Just my video is not working. Okay. Dr. Rajdeep.
Yes, sir.
My question is what drugs did you used in the pre-medication?
So we have used injection glycopyrrolate and these etomidate in 0.015.
No, in pre-medication. My point is you have used low dose midazolam to prevent the myoclonus pain, etomidate myoclonus and etomidate induced pain. But what was the drugs used in the pre-medication?
So in
What were
pre-medication, the day before surgery, in that case, we advise patient to tablet alprazolam he will take
Okay.
and tablet pantopna 40 milligram. So bus only that on that day. On the day of surgery, we have given the patient normally as
did you used
injection Voviron. So no, we have not
fentanyl?
used.
Fentanyl?
No, sir. So we are not used fentanyl. In fact, fentanyl is not provided in our setup now.
Okay, because these can be a confounding factor.
Yes, so these can be confounding. Fentanyl, dexmedetomidine, they can be confounding factors to relieve this myoclonus. Na? Yes,
And what are the incidents as a side effect of myoclonus of etomidate?
Sir, in our study, the incidence of myoclonus with etomidate itself is very less as compared to midazolam and normal saline. Sir, it is very less. It is seen in only in 3 patients with etomidate, and not in midazolam. There was 10 to 15 patients have shown this now, and whereas in that normal saline group there is 50% of the patient, most of the patient have shown. So they have shown some as grade 1, grade 3 is also severe. In that there are adduction of the arms and all this.
Just for a teaching point, my point is that myoclonus side effect of etomidate incidents are very less. Okay.
Okay.
Okay. But
Yes,
when
sir.
we use the side effects, okay, very rare side effects of any drugs, such as you use the midazolam to prevent the myoclonus,
Yes, sir.
etomidate myoclonus. But in this study, when a side effect is rare, you have to use the large number of population, large number of sample
So
size.
that could be the limitation of our study. That what I am saying in the last. Now we have taken only the 30
Otherwise,
patients in that.
it may be that in the sample size of 10,
Yes,
15
sir.
or 15, you will not notice the myoclonus. Okay.
Yes,
So
sir.
when the side effect of any drug is rare, then you have to use the large population so that you can give your data accurately. Basically.
So that's why we have written that it
What
could be
was
the
your
limitation
sample
of
size,
this
ma'am? What
study.
was your
So
sample
30,
size?
30, we have
30,
taken
30
90
is the-
patients, 30.
Okay, okay.
In each
Sample
group, 30
size-
patients.
90
Okay, okay.
Total 90 patients. In each
Okay,
group,
okay.
30. Yes, sir.
Each group in the 30. Thank you very much.
Thank you, sir.
Okay, thank you, ma'am.
Thank you.
Presentation is of Dr. Vandana Pakhare.
Video open.
Good day, everyone. I am Dr. Vandana Pakhare from ESIC Medical College, Hyderabad. I will be presenting my study, Optimal Utilization of Theatre Time and Audit. Operation theatre is one of the most important area for any hospital as it contributes to most of the expenditure, workload, as well as generating revenue. On an average, operation theatre caters to 50% of the healthcare needs. Maximum utilization of operation theatre time results in high cost benefit, fewer case cancellation, reduced waiting list, improved patient satisfaction, disciplined staff, and ultimately growth of the hospital. For a hospital, especially one in evolving phase, performing an audit of how OT time is utilized helps to identify areas of improvement and formulates protocols accordingly. After obtaining Institutional Ethical Committee permission, we carried out audit of operation theatre time utilization in stepwise manner. Starting from wheeling in of the patient to wheel out of the patients, all times were included, like induction time, position and preparation time, surgical time, emergence, cleaning, and turnover time were defined with certain time limits, and whenever these limits were exceeded, extra time was noted. We included 6 major operating rooms out of 10 functioning operating rooms. Routine working hours were from 9 a.m. to 4 p.m. OT start delay was defined as whenever patient was shifted inside the operation theater, any delay after 9:15 a.m. was noted. The OT was started delayed on 63.5% of the times. The average operating room start time was between 9:20 a.m. to 9:30 a.m. A total of 1661 minutes, approximately 4 working days were lost due to delayed starting of the operation theater. Most common reasons for delayed starting of operation theater were like surgeon reporting late to operating room, support staff not available. These were related to human resources, while administrative reasons like inadequate number of trolleys, patient not shifted from the wards, consent not taken, were also contributed significantly. The case cancellations were 32 out of 356 scheduled elective cases, giving a percentage of 9% approximately. The most common reasons for case cancellations were change of plan by surgeon, patient not optimized, OT time not available, emergency cases performed during elective hours, or post-operative bed not available, and sharing of the laparoscopic instrument. All these reasons were avoidable with prior planning. Induction time was defined as induction time from attachment of the first monitor to whenever the patient was handed to surgeons. This time was delayed more than 10 minutes on 5% of the occasions of total 324 cases. The most common reasons were difficult airway, as in maxillofacial surgeries, or difficult spine in orthopedic patients, or a student trainee performing the procedure, need of invasive lines, peripheral nerve blocks, or complications during the induction of anesthesia. The surgical time was defined as time between skin incision to dressing. The actual surgical time was 35,434 minutes, and it accounted to 66.96% of the available resource time. This time fell drastically short of estimated time given by surgeon, that is 24,534 minutes. The surgeons didn't give consideration for the time required for anesthesia services and support care. This led to cancellation of cases and overruns. Emergence time was delayed on 5 occasions of total 32% cases performed under general anesthesia. 2 of these had laryngospasm immediately after extubation, and 3 patients needed peripheral nerve block for analgesia before extubation. The cleaning time was on an average 8.67 minutes, which was within the acceptable limits. The turnover time was defined as time between shift out of one patient to shift in of next patient. On an average, this time was 13 minutes, which fall into high performance category. This time was utilized for cleaning and setting up of the operation theater for next patient. It depends on ASA status of patient, preceding surgery, succeeding surgery, order of the case. The total utilization time was calculated as each operating room under study function for 21 working days, and gave a total resource available time as 52,920 minutes, and the total time utilized was 37,740 minutes. This gave the raw utilization of 71.31% of the available resource time. Of this, only 7% time was utilized for anesthesia services, which are equally important to the actual surgical procedure, and the actual surgical time was 66.96% of the available resource time. Economic considerations suggest that it is desirable to keep the operation theaters fully utilized, but utilizing operation theaters fully comes at the cost of patient convenience. A utilization of 85 to 90% is the highest that can be achieved without delays or running late. Higher than this may lead to patient delays, cancellation, staff overtime, and overruns. We conclude that in our study, most of the reasons for operation theater start delays, case cancellation, and overruns were multifactorial but largely avoidable. Utilization of overtime can be maximized by considerate planning, realistic scheduling of the elective list, communication among the team members, and meticulous resource management. Audit of operation theatre utilization is an important tool to identify key problem areas and formulate protocols accordingly. Thank you.
Sir, any questions for Dr. Vandana? Sir, any questions for Dr. Vandana?
Hello, Dr. Vandana.
Yeah, good morning, sir. You're audible.
Audible. Okay. It is very different study and
It is kind of more of administrative study for the utilization.
yeah. My question is, is there any delay from the anesthesia sites? If you get any point where delay was from anesthesia side, you mentioned that
Yes, sir. In the
delays were from delays was because of OT staff, surgeons, or sportive staff, but you didn't mention anything about anesthesia side delay, I think.
Yes, sir. In the induction time, I have mentioned it was delayed on 6% occasions. Emergence time, I have mentioned as 5%. And in the case cancellation, one case was cancelled because it was a difficult spine and the patient was very high risk for general anesthesia. So that patient was scheduled another day after optimization. These were reasons from anesthesia side.
Okay. Thank you very much.
Yeah, thank you, sir.
The next talk is of Dr. Sarvesh B.
I am Dr. Sarvesh B. Today I am presenting efficacy of dexmedetomidine as an adjuvant to ropivacaine in the ultrasound-guided pectoral block for post-modified radical mastectomy analgesia, a prospective randomized double-blind study. Majority of patients undergoing modified radical mastectomy for the management of carcinoma breast complain of severe postoperative pain, nausea, and vomiting. And insufficient management of postoperative pain leads to various syndromes like persistent paresthesia, intercostobrachial neuralgia, phantom breast pain. Ultrasound-guided pectoral block bestows safe and effective analgesia in breast surgeries. Dexmedetomidine is a potent alpha-2 adrenergic receptor agonist, which demonstrates about 8 times more affinity towards alpha-2 adrenoreceptors when compared to clonidine. In our study, we evaluated the effect of dexmedetomidine as an adjuvant to ropivacaine in ultrasound-guided PEC block in terms of total duration of analgesia and postoperative morphine consumption after modified radical mastectomy surgery. In this prospective randomized double-blind study was conducted on 60 ASA 1 and 2 females who are aged above 25 years and scheduled to undergo modified radical mastectomy under general anesthesia. Group ropivacaine received ultrasound-guided PEC block with 20 ml of 0.5% ropivacaine, whereas group RD received ultrasound-guided PEC block with 20 ml of ropivacaine plus dexmedetomidine 0.5 microgram per kg body weight. And 10 ml was given at PEC 1 site and 10 ml was given at PEC 2 site. Patients who are having induction site infection, anticoagulant therapy, abnormal coagulation profile, and who are hypersensitive to local anesthesia and morphine, and due to technical difficulty, obese patients with BMI more than 35 kg per meter square were excluded from our study. All the required monitors were connected and patients were given general anesthesia. Ultrasound-guided PEC block was performed using high-frequency linear probe, and in our case, we used GE Volusinide. After surgery was done, and meticulous aseptic precautions were followed throughout the procedure. After reversing the neuromuscular block with IV neostigmine 0.05 milligram per kg and atropine, patients were extubated. Primary outcome in our study was total duration of analgesia, and total morphine consumption. And pain intensity were measured using visual analog scale in PSU at 1, 3, 6, 9, 12, 18, and 24 hours. And vast more than 4 patients were injected with morphine 4 mg intravenously. Blood pressure and heart rate were recorded hourly for the first 6 hours postoperatively, and they were considered as secondary outcome measures. And we analyzed the statistics using SPSS version 20. Demographic data, total duration of analgesia, total morphine consumption, visual analog scale, hemodynamic parameters were analyzed using independent t-test. Sex ASA grades were analyzed using chi-square test. P-value less than 0.05 was considered as statistically significant. There were no statistical difference between the two groups in terms of demographic data. Duration of analgesia was significantly longer in group RD as compared to group R. In group RD, it was 465.2, whereas in group R, it was 311.3. Total consumption of morphine was significantly more in group R as compared to group RD. This is the table depicting duration of analgesia in minutes and total morphine consumption in milligrams. This is a visual analog scale comparison. Group RD recorded persistently lower VAS as compared to group R. Mean arterial pressure and heart rate, there were no statistically significant difference between group R and group RD. Modified radical mastectomy is associated with severe postoperative pain. People have used several techniques like thoracic epidural, paravertebral block, but both of these techniques pose serious complications like pneumothorax, total spinal anesthesia, and intravascular injection. In 2011, Blanco et al. Came up with a novel technique of blocks, PEC block, PEC1 and PEC2, which revolutionized the postoperative management of modified radical mastectomy. These were my supporting studies. Arampreet Paul et al. Concluded that dexmedetomidine 1 microgram per kg added to 0.25% ropivacaine for PEX block increases the duration of analgesia and decreases postoperative morphine consumption, which supports my study. In the same way, Bakr et al. And El Sayed Muhammad et al. They also did studies which supports our studies. We didn't assess the effect of PEX block and chronic postoperative pain and metastasis or recurrence of breast carcinoma, which is a limitation of our study. And we concluded that the addition of dexmedetomidine as an adjuvant to ropivacaine in ultrasound-guided pectoral nerve block after modified radical mastectomy increases the duration of analgesia and reduces total morphine consumption postoperatively. These were my references. I have quoted total 15 references. Thank you very much.
Any questions for Dr. Sarvesh? Sir? Hello, chairpersons.
Hello, Dr. Sarvesh.
Yes, sir. Yes, sir.
Yeah. Okay. This study was USG guided PEC 1, 2, and PEC 1
Yes,
and
sir.
PEC
PEC 1 and
2,
PEC 2 block. Yeah.
block. But you didn't include in this PPT any USG guided image, basically.
Okay, sir.
You should
I would,
at least
not include.
yeah. Second thing is that it is a good study, and you mentioned that dexmedetomidine prolong the analgesia effect of PAC blocks, no?
Yes, sir. Yes.
But these block can be given intraoperatively also by surgeon. Okay.
Yes, sir. Actually, we gave before extubation.
Before extubation, you give before extubation, na?
Yes, sir. Yes.
During intraoperatively? Yeah, after
You
closure.
mean before incision?
Yeah, no. My meaning is you give PEC block before incision or before closure intraoperatively. What was the
After closure, sir.
After closure
and before extubation. Yeah.
Okay, after closure and before
After
extubation.
closure of the
But my point is, these block can be given intraoperatively when the field is open. Okay, intraoperative field is open and pectoral nerve in front of you. You don't need USG or anything.
Correct.
Okay.
Yes,
So this is the just learning point, na?
Yes, sir.
Okay, by these we are used to give these blocks for post-operative analgesia intraoperatively. We ask the surgeon to give this block, or sometime we also, I also myself give this block. No?
Okay. Okay, sir.
USG guided pack block is a good thing. Okay. Thank you.
Yes, sir.
Thank you.
Thank you. Thank you.
Okay, sir. So thank you, Dr. Savresh. Our next presentation is of Dr. Derlin Thomas.
Thromboprophylaxis and central neuraxial blockade. As an anesthesiologist, why are we so much concerned about this problem? It is because the incidence of spinal hematoma is around 1 in 1,50,000 with epidural and 1 in 2,20,000 with spinal. It is even higher in patients on anticoagulants. It is around 1 in 1 lakh for spinal and 33 in 1 lakh for epidural. Even the literature shows evidence of extensive retroperitoneal hematoma, spinal as well as epidural hematoma in patients on anticoagulants after regional anesthesia technique. So we knew that spinal or an epidural hematoma is a threat for our anesthesiology practice. So can we avoid thromboprophylaxis in these patients? The answer is a big no. Why? Because statistics have shown the incidence of venous thromboembolism around 1 crore cases worldwide every year. And the scene is not so different from India as well, because analysis of patients with venous thromboembolism in a multi-speciality tertiary hospital shows the incidence of VTE around 19.9 per 10,000 cases. Also, ARRIVE, which is a retrospective registry of Indian patients with venous thromboembolism, shows the incidence of acute DVT without pulmonary embolism around 64%, acute DVT with pulmonary embolism around 23%, and PE alone around 13%. Anticoagulation therapy is also a must for the prevention of stroke in patients with atrial fibrillation, acute coronary syndrome, as well as for the prevention of venous thrombosis after orthopedic surgeries. Now, as a general rule, when should we stop this anticoagulation therapy? For high-risk individuals for VTE or stroke, we have to wait at least for 2 to 3 half-life intervals of the anticoagulant agent. But for low-risk individuals, we can wait even 4 to 6 half-life intervals of the anticoagulant agent. But for patients with renal disease, the time interval has to be determined according to the creatinine clearance of the patient. And after a neuraxial procedure or removal of an epidural catheter, we can restart anticoagulants within 24 to 48 hours. But for high-risk individual, we can even start it sooner, that is within 24 hours. Within 24 hours minus the time to peak effect of the drug. Now let's see some individual drugs in detail. First, warfarin, which is a vitamin K antagonist. It has to be stopped at least 5 days prior to the procedure. And periodic testing of INR is a must. INR should be normal at the time of a neuraxial function. After cessation of warfarin, especially in a high-risk individual, we can bridge anticoagulation therapy with the administration of a low molecular weight heparin or an unfractionated heparin. But preoperatively, low molecular weight heparin has to be stopped at least 24 hours prior to surgery, and IV unfractionated heparin has to be stopped up to 4 to 6 hours prior to surgery. For low-risk individual, bridging therapy is not necessary. And postoperatively, we can restart low molecular weight heparin in high-risk individual after a minor surgery 24 hours after surgery. But after a major surgery, we have to wait at least 48 to 72 hours after surgery for the restarting of a low molecular weight heparin therapy. With the problems with this oral warfarin agents, now novel oral anticoagulants, NOACs, has been superseded the use of warfarin. The key points include it has got a predictable pharmacokinetic and pharmacodynamic profile. It does not require regular monitoring. There is no specific antidote to reverse bleeding, but it has demonstrated equivalence to warfarin in preventing systemic embolism and stroke. Rivaroxaban and apixaban, as you can see, they are factor 10A inhibitors, while dabigatran is a direct thrombin inhibitor. Time before puncture, catheter manipulation or removal for rivaroxaban is around 22 to 26 hours. For apixaban, it is around 26 to 30 hours. For dabigatran, fourth edition of ESRA guidelines say it is contraindicated according to the manufacturer. The third edition has told that it can be stopped at least 5 days prior to the surgery. Time after puncture, catheter manipulation or removal is almost same for all these drugs. Antiplatelet agents, especially thienopyridine derivatives such as clopidogrel and ticagrelor, and glycoprotein 2B3 antagonists such as apixaban, etifibatide, and pyrofiban show diverse effects on coagulation as well as platelet function. Time before puncture, catheter manipulation or removal for clopidogrel is around 7 days, but for ticlopidine, it is around 10 days. Prasugrel 7 to 10 days, while ticagrelor it is around 5 days. After catheter removal, we can restart clopidogrel as well as ticlopidine, but we have to wait for at least 6 hours for the restarting of prasugrel as well as ticagrelor. Aspirin and NSAIDs is not a contraindication for neuraxial blockade, but we should be cautious with the concurrent use of other anticoagulant agents. So in summary, we should always be beware of the new anticoagulant drugs. We should know the pharmacology of these drugs. We should be very familiar with the guidelines, and time periods recommended are usually minimum for these guidelines. And individual risk-benefit assessment is a must. These are my references. With our eyes open to thrombosis, embolism, and hematoma, I'm concluding my topic. Thank you for your patient listening.
Sir, any questions for Dr. Derlin Thomas?
Hello, Dr. Darlene. Hello. Dr. Darlene. Hello.
Dr. Derlin?
Hello.
Not present here, so we'll start with the next presentation, and the next presentation is of Dr. Rahul Agarwal.
Good evening, all. My topic is lumbar epidural depth using transverse ultrasound scan and its correlations with loss of resistance technique, an observational study in a tertiary care hospital. Myself, Dr. Rahul Agarwal, doing primary DNB in Department of Anesthesiology, Ispat General Hospital, Raulkela, Odisha. My guide is Dr. Manoyan Samantray, MD Anesthesiology, Senior Consultant in Department of Anesthesia, Ispat General Hospital, Raulkela. So we'll discuss the main topics in introductions, methods, results, conclusions, and reference. So come to the introductions part. The objective of the present study was to compare the skin to epidural space distance as assessed by transverse ultrasonography with conventional loss of resistance technique in the same group of patients and establish any correlationship if present. As you all know, present day ultrasound having a great picture, having a great role in giving different blocks, in giving different regional ultrasound scans, in different intensive care units, and in different giving regional anesthesia also. But now we are using ultrasounds in giving neuraxial blockade. I have registered my thesis or my paper in the CTRI, that is dated 21/9/2021, and my CTRI registration number is 036673. So methods. I have chosen 64 patients of either sex, both male and female, having American Society of Anesthesiology grade 1 or grade 2. BMI less than 30 kg per meter squared, requiring lumbar epidural for surgeries and post-op anesthesia were enrolled as per my inclusion and exclusion criteria. Inclusions criteria includes age is less than 60 years, American Society of Anesthesiology grade 1 and grade 2, BMI less than 30, patient of either sex. These are all my inclusion criteria. Exclusion criteria mainly include the patient having will not give consent. Consent patients who are pregnant or pregnant females, patients having hemolytic diseases. These are all my exclusion criteria. I always or my guide perform a pre-procedure ultrasonography in the wards to identify the epidural space using a curvilinear ultrasound probe that is 2 to 5 millihertz in the transverse plane at the L3 L4 intervertebral space. Therefore, the epidural depth from the skin was assessed with conventional loss operational technique methods while performing the procedures. The needle depth was measured using a sterile linear scale, and any change in the scale or needle direction or intervertebral space was noted. Actually, the pre-procedural ultrasonography was performed in the wards itself, and after that, the patient is taken to the OT in the next day. And in the next day, we perform a epidural block by using our loss of resistance technique. And whatever depth noted from the loss of resistance technique was noted, and the ultrasound depth is also noted. And finally, we compare the ultrasound depth with the needle depth, and we give it data, and we start statistics to compare whether ultrasound is a good picture, ultrasound is a conventional tool or a useful tool for giving universal blockade or not. So come to the result part. I mainly in my personal experience, I gave a result, or I found out a result that it is very similar. There is a definitely good picture of the ultrasound. The ultrasound depth and the needle depth were nearly same in the sense that the R value or the P value is less than 0.01. That means it is significant. I have also done multiple analysis revealed the 95% limit of the agreement. Maximum depth or the maximum needle depth and ultrasound depth are near in the normal range. That means the ultrasound depth and the needle depth are nearly same. So ultrasound definitely is a good feature or definitely a good tool for neurological blockade. So coming to the conclusion part, the present studies demonstrate a good relationship or correlation between ultrasound depth and needle depth, and so that the pre-procedural ultrasound scan in the transverse plane provide accurate needle entry site with high success rate in a single attempt from lumbar epidurals. Also, the chances of complications like accidental epidural punctures also decreases in the patient with the BMI less than 30 kg per meter square. Actually, the patients, I have done these cases in very ASA grade 1 and grade 2 patients, BMI less than 30. But this ultrasound can be used in the patients having a higher BMI, the patient who are obese, patients who have different spinal problems, or patients who have developed kyphoscoliosis or lordosis. In this patient also, the ultrasound can be done, and ultrasound depth can be measured easily. By doing this, we can decrease the complications of the epidural block, like accidental epidural punctures, traumatic punctures, difficult epidurals, maximum attempts of epidurals. Like this type of complications can be easily prevented, and ultrasound can be definitely used as a good tool for practicing epidural blocks. So these are my reference. I have taken the reference from the recent advances or the recent journals of the different PubMeds and Google Scholars journals. Thank you.
Any questions for Dr. Rahul?
Dr. Rahul?
Yes, sir. Good morning, sir.
Good morning. Okay. My question is that USG guided epidural. Okay.
Yes, sir. Yes, sir.
Okay. Is it helpful in old age patient where we face the osteophytes during epidural?
Sir, actually, it is mainly we assess the skin to epidural space distance, sir. In old age, sir, the main problem is the ligamentum flavum is calcified.
I am abrupting you that you mentioned that this is helpful in high BMI patients, na?
Yes, sir.
But my question is it helpful in the old age patients?
Yes, sir. It is all. Yes, sir.
Most difficulty during the epidural insertions.
Yes, sir. It is, sir, not much more effective in elderly patients, sir, because in that ligamentum flavum is calcified, and the patient is also developing osteophytes. So ultrasounds, the hampers, sir, it hampers the picture. So ultrasound picture is not so much clear, hence it is not that much effective in elderly patients, sir.
Okay. And what was the age group in your study,
Sir,
basically?
age group I have included, sir, 18 years to 60 years, sir.
18 to 60. Yeah. Have you faced any problem in the nearby 60 age group during insertion in the epidural through the USG guided approach?
No, sir. Actually, sir, we are already doing the pre-procedure ultrasonography. On the previous day of the OT, we are doing ultrasonography and we are just measuring the skin to epidural space distance. In the OT itself, we are performing loss of resistance technique.
Okay. Thank you very much.
Thank you. Thank you so much.
So the next presentation is Dr. Samra Fatima.
I'm Dr. Samra Fatima from Government Medical College and Hospital, Chandigarh, presenting a study on erector spinae plane block for post-operative analgesia in thoracolumbar spine surgeries, a randomized controlled trial. The pain in these surgeries may have scores ranging from 5 to 7, and the means of analgesia are opioids, but they're associated with significant adverse effects at high doses. Therefore, regional anesthesia technique like ESP block, which are safe and simple, can be used in these surgeries, but the description of their use in spine surgeries is sparse. Therefore, the aim of this study is to investigate the postoperative analgesic effectiveness of ultrasound-guided ESP block in patients undergoing thoracolumbar spine surgeries. The study was conducted in the Department of Anesthesia and Intensive Care in collaboration with the Department of Neurosurgery after clearance from the Institutional Ethics Committee and Clinical Trial Registry of India. The study undertaken was a prospective, randomized double-blind controlled trial. Sample size was calculated using 10 pilot cases who did not receive the block and had 90% power to detect mean monthly consumption with a 30% reduction. So after assuming 20% attrition rate, 35 participants were recruited. Group intervention, which received the block, and group control, which did not receive the block. Randomization was done using computer-generated random number table. The blinding was done using coded sealed opaque envelopes, which were opened on the day of surgery, and if allocated, the block was performed by the investigator. At the end of the study, decoding was done. Participants aged between 18 to 65 years undergoing thoracolumbar spine surgeries belonging to ASA grade 1 and 2 were undertaken. There was some exclusion like patient with drug allergy, substance abuse, chronic analgesic use, etc. After the pre-anesthetic evaluation, informed and written consent were taken from all the patients, and they were explained about the use of linear visual analog scale and intravenous patient control analgesia pump. After the induction with general anesthesia, patients were placed in prone position, and using ultrasound guidance, ESP block was given bilaterally in the intervention. The drug given was 20 ml of 0.25% of ibuprofen with adrenaline. After extubation, patients in both the groups were connected to IV PCA pump. With the concentration of morphine in 1 milligram is to 1 ml with the lockout interval of 5 minutes, and maximum dose being 0.2 milligram per kg body weight over 4 hours. With injection, paracetamol and diclofenac were used for routine analgesia post-operative. Here, the technique is being demonstrated where a linear ultrasound probe is being placed in the longitudinal parasagittal plane, 2 to 3 centimeter lateral to the vertebral column. 10 centimeter 22 gauge ultrasound needle is being inserted from cranial to caudal direction until it hits the transverse process. It is retracted a little, a negative aspirate is performed, and hydrodissection is done. Then the drug is given in the allocates of 5 ml, and the spread is being seen craniocaudally. The primary outcome of the study was cumulative morphine consumption over 24 hours period. The secondary outcomes were VASCO, time to first bolus of morphine, patient satisfaction scores, and any side effects. The patient's vitals were monitored at 1, 2, 4, 6, 8, 12, and 24 hours. The statistical analysis were performed at significance level of alpha of 0.05 after excluding 10% patients from patients who were assessed for eligibility. 35 patients were allocated to group intervention and group control with none lost to follow-up, and all were analyzed. The preoperative patient parameters, the preoperative investigations, and the patient characteristics as well as the duration of surgery were comparable in both the groups. However, the intraoperative fentanyl requirement were lower in the intervention group. The primary outcome of the study, which was the cumulative morphine consumption over 24 hours period, was significantly lower in the intervention group. The secondary outcome, which was the VAS scores both at rest as well as in movement, was lower in the intervention group. The time to first bolus of morphine was prolonged and patient satisfaction scores were higher in the intervention group. There were no adverse effects that were experienced by the patients. Rationale behind using this block in thoracolumbar spine surgery is that spine surgeries involve extensive tissue dissection, and these tissues are supplied by dorsal rami or spinal nerves. Therefore, deposition of local anesthetic due to this erector spinae muscle will act on both the dorsal as well as ventral rami and produce the analgesic effect. Our study was supported by studies conducted by Seelam et al. And Sharma et al. In where they showed the efficacy of ESP block in mastectomy patients. In spine surgeries, the RCT were conducted by Singh et al., who showed reduced intraoperatively as well as postoperatively opioid requirement in patients receiving erector spinal block. Further studies conducted by Ushima et al., Singh et al., Desai and et al. Also showed reduced VAS scores in patients receiving ESP block. The limitations of the study were higher drug volume or in situ catheter may be required to prolong the effect of block postoperatively. Since the block was given after the induction of general anesthesia, dermatomal block area could not be assessed, and in the control group, no sham block were given. I would like to conclude that the patient receiving ultrasound-guided erector spinae plain block showed reduced morphine consumption in 24 hours period, reduced pain scores, and better postoperative patient satisfaction. Therefore, the erector spinae block may be recommended for the in the thoracolumbar spine surgeries as a component of multimodal analgesia, and it reduces opioid requirements. These are my references. Thank you.
Dr. Gopal Krishna Jaliwal. Sir, any questions for Dr. Fatima?
Yeah, Dr. Fatima.
Good morning, sir.
Good morning. Okay, my question is what were the surgeries you used the ESP blocks? What were the surgeries basically?
So we used any surgeries which were involving laminectomy, laminotomy, and fusion. So common surgeries were, sir, any lumbar or thoracic spine fractures, or sir, PIVD surgeries. And so we excluded port spine surgeries because there was localized infections. So any surgeries which had local site infection were excluded, and any surgeries with abscess in the surgical area, like in erector spinae abscess, we had excluded those surgeries.
How you will compare the epidural versus ESP blocks? What will be your assessment? One patient will be given a epidural block, thoracic or lumbar block, and another one we will give the ESP blocks. What will be outcome? Outcome will be better in epidural or ESP blocks?
Sir, the problem limitation with using epidural block is the placement of catheters, because the surgical site and the placement of catheters can be similar. And sir, with the ESP block, the advantage is that we can give a block at a particular level, but it has craniocaudal spread. So we can give the block away from the surgical site in order to decrease the microbial contamination and to increase the spread of the drug. So the ESP block would be better as compared to epidural. But the disadvantage is that we have not used any catheters or prolongation.
But we use the sonography machine.
Yes, sir.
You should train in the sonography.
Yes, sir.
No?
Yes.
These are the limitations for when we
Yes.
compare this. Okay. Thank you.
Thank you, sir.
Thank you. So this presentation is of Dr. Nityashri Singh.
Hello everyone. Myself Dr. Nityashri Singh from Bangalore Medical College and Research Institute. My co-author is Dr. Sandhya K. My study topic is infraorbital and mandibular nerve blocks in adjunct to general anesthesia versus general anesthesia alone for fish maxillary surgeries, a randomized study. Introduction. Facial-maxillary surgeries are commonly associated with pain and swelling, leading to difficulty in chewing, mouth opening, deglutition, and sometimes may cause airway compromise. Regional anesthesia of head and face are less commonly practiced due to multiple reasons, including extensive bony hindrance, difficulty in locating the nerves, and bony distortion of the USD images. Nerve blocks help in intraoperative pain relief and also help in early postoperative rehabilitation. Advantages of using the regional nerve blocks with general anesthesia includes reduced dosage of opioids and the anesthetic agents and better intraoperative hemodynamics. Aims and objectives. Aim is to compare the intraoperative analgesic effect of regional nerve blocks versus general anesthesia alone. Objectives is to compare the duration of the analgesia in the postoperative period into the two groups and to compare the requirement of the rescue analgesia in both the groups. Materials and methodology. After institutional ethical committee approval and informed consent, a detailed pre-anesthetic checkup was done. A single-blinded prospective randomized control study of 40 patients between 60 to 80 years of age of either sex belonging to ASA grade 1 and 2 undergoing elective facial maxillary surgery under general anesthesia were divided into two groups of 20 patients each. Exclusion criteria included patients who refused to participate in the study, patients with ASA 3 and 4, patients with known allergy to study drugs, and patients with history of the operative sore throat or chronic obstructive pulmonary disease or upper respiratory tract infections. Group G received only the general anesthesia, while Group B received infraorbital or mandibular nerve block with 0.2% ropivacaine plus general anesthesia. Intraoperatively, after taking the patient to the operating room, the intravenous access was secured and monitors were connected. Vitals like heart rate, blood pressure, mean arterial pressure, and oxygen saturation were noted. Patients pre-medicated with injection fentanyl 2 microgram per kg, injection glycopyrrolate 0.004 mg per kg given IV. Pre-oxygenation was done for 3 minutes with 100% oxygen at 6 liters per minute. Patients were induced with injection propofol 2 mg per kg and sevoflurane 2%. Relaxant injection vecuronium 0.1 mg per kg given and unitracheal intubation was done. Patients were maintained with nitrous oxide oxygen and 1% of sevoflurane. Group B received infraorbital or mandibular nerve block with 0.2% ropivacaine 1.5 to 2 ml. While one person performed the block, the other person assessed the intraoperative parameters. During the surgical procedure, oxygen saturation, ECG, heart rate were monitored and the blood pressures were recorded. All the patients were extubated using standard criteria after reversal with neostigmine and glycopyrrolate. Analgesia was supplemented with injection fentanyl 1 microgram per kg when heart rate and blood pressure were raised 10% above the baseline. Patients were shifted to postoperative ward and assessed for pain at 0, 1, 2, 6, 12, and 24 hours after the surgery. Efficacy parameters like pain, postoperative nausea and vomiting, symptoms of numbness at the surgical site, and the hemodynamic changes were assessed. Pain assessed using visual analog scoring system. Postoperatively, patients received injection paracetamol 1 gram IV 8th hourly for the first 24 hours. Visual analog scoring was done accordingly. 0 to 3 was graded as no pain to mild pain, 4 to 6 moderate to severe pain, 7 to 10 with very severe to worst pain. In my study, 82.5% were male patients and 17.5% included females. Most of the patients underwent open reduction and internal fixation of the fractures of mandibular and the maxillary. 7.5% patients underwent implant removal, whereas 2.5% each in closed reduction and orbital floor reconstruction. The study sample of 40 patients was evaluated. Patients in Group B had significantly less VAS value than the Group G at all postoperative time intervals and better hemodynamics intraoperatively. Rescue analgesia was given in 10 patients in Group G as compared to none in Group B. The time and the number of rescue analgesia intake were noted. It was noted that of all the 10 patients who received rescue analgesia, 6 patients required it within the first hour postoperatively, and 4 patients required it within the second hour postoperatively. No patients in either group had nausea, urinary retention, discomfort due to numbness, whereas 4 patients receiving fentanyl complained of pruritus. Mean VAS score between the two groups is statistically significant. That implies Group B receiving infraorbital or mandibular nerve blocks plus general anesthesia is superior to Group G, who received only the general anesthesia. My study was compared with a study done by Radhika Krishnan et al. Titled Preemptive Analgesia for Elective Facial Maxillary Surgeries using 0.25% bupivacaine, which is published in Indian Journal of Anesthesia in 2008, which showed The VAS score is significantly lower in the group receiving preemptive analgesia for up to 40 hours post-operatively. My study findings were, in the study group, the VAS score was lower and the need for rescue analgesia was reduced. The use of regional nerve blocks in facial maxillary surgeries has never been explored. Reduction in opioid requirement prevents sedation in post-operative period. Results suggested post-operative pain relief with pre-incisional regional nerve block was better. The study group showed lesser VAS score and reduction in rescue analgesics with better intraoperative vitals. Therefore, we conclude that simple peripheral nerve blocks for facial maxillary surgeries are safe and effective method to reduce the postoperative pain. These are my references. Thank you.
So any questions for Dr. Nityashri?
Dr. Nityashri, I'm audible.
Good morning, sir.
Okay, my question is, which technique you used for mandibular nerve block?
So there are two techniques, intraoral and extraoral approach, but most of the procedures I did was intraoral approach, so which went through the line of the canine, through the mid-pupillary line, and 1 to 2 ml of 0.2% ropivacaine was injected, and the block was performed before the pre-incisional block was performed, sir.
Okay. And for intraorbital orbital nerve block?
Sir?
Hello?
Yes, sir.
Okay. Can you hear me?
Yes, sir, you're audible, sir.
Okay, okay. Okay, and in the VAS score, how much difference was there in a VAS score with the without mandibular nerve block and with mandibular nerve block?
Without the block, patients complained of pain post-operatively, sir. Even intraoperatively.
What was the difference in the VAS score? My question is.
Yes, sir. They without the block, the group complained of pain from moderate to severe pain, ranging from 4 to 7, sir.
Okay, thank you.
Thank you, sir.
Okay, so the next presentation is of Dr. Shrutika Ved.
Hello everyone, I am Dr. Shrutika Ved and I am going to present my paper on the topic Role of Electrically Driven CPAP Machine with Oxygen Enrichment for Oxygen Conservation in COVID ICU. Oxygen conservation poses a huge challenge in COVID ICUs, the HFNO being a major cause of oxygen consumption as conventional ventilators use large amounts of oxygen and air to generate pressures in a patient's airway. Electrically driven CPAP machines, on the other hand, use air to maintain continuous positive airway pressure, decrease atelectasis, increase surface area of alveolus, improves ventilation perfusion matching, thus improving oxygenation and saving oxygen used with the use of electrically driven CPAP with oxygen supplement. CPAP has mostly been studied in relation to OSA and a lot is yet to be explored regarding its potential in COVID ICU. 20 patients with antigen-confirmed COVID-19 disease admitted in COVID ICU requiring HFNO were selected, informed consent was obtained about the procedure and proper counseling was done. Patients' vitals were noted before shifting to electrically driven CPAP machine and monitored throughout. Properly fitted BiPAP mask was attached with the electrically driven CPAP machine and the oxygen was supplemented with the help of tubing connecting the BiPAP mask vent to the flow meter. The flow of oxygen was titrated according to patient's requirements, ranging from 8 to 12 liters per minute. The pressure was set as per the patient's need and titrated as per the condition of the patient. During meal times, the patients were shifted to HFNO. The below photographs show the vented BiPAP mask used, the tubing connecting the vent of the BiPAP mask to the flow meter and the entire assembly on the patient. The patients who were desaturating, non-compliant, drowsy, having severe nausea or vomiting, or having disease progression were shifted to other modes of oxygen therapy. The arterial blood gas analysis ABGA was done with patient's consent as and when required. For the rest of the time, pulse, respiratory rate, SpO2 were continuously monitored. Gradual titration of oxygen flow and continuous positive airway pressure was done to achieve a stable oxygen saturation of 92 to 95% and a respiratory rate of 18 to 20 per minute while aiming to conserve maximum amount of oxygen. Out of total 20 patients, 15 were successfully treated with the electrically driven CPAP machine with O2 enrichment and did not require stepping up to further modalities of oxygen therapy. We were also able to save about 29 to 80% of oxygen by the use of CPAP machine, as all the patients were different in characteristics of age, sex, comorbidities, and compliance to the protocols. The patients treated with this method had increased comfort level as well for the therapy as compared to HFNO. This graph shows O2 saved in liter per hour versus the case number. This next graph shows oxygen utilization comparison between HFNO and CPAP, the blue bars being the oxygen consumed by the use of HFNO and the red bars being the oxygen consumed by the use of CPAP. This slide shows the statistical analysis, the case-wise distribution of O2 used in liter per hour on HFNC, O2 used in liter per hour on CPAP, total O2 saved in liter per hour, and total time for which the CPAP machine was kept with oxygen enrichment, along with the savings of oxygen that was done in percentage. Continuous positive airway pressure is a type of positive airway pressure that is used to deliver a set pressure to the airways that is maintained throughout the respiratory cycle during both inspiration and expiration. Positive and expiratory pressure is the pressure in the alveoli above atmospheric pressure at the end of the expiration. CPAP is a way of delivering PEEP but also maintains the set pressure throughout the respiratory cycle during both the inspiration and expiration. It is measured in centimeters of water pressure, cmH2. In CPAP, no additional pressure above the set level is provided. Patients are required to initiate all their breaths, and the forced air delivered by CPAP helps to keep the airways patent and prevents collapse. In the single center observational study, 75% of patients improved with electrically driven CPAP, though they were very hypoxemic who required 30 to 40 liters per minute of oxygen flow on HFNO. Existing evidence for CPAP in severe acute respiratory distress is conflicting, and much of it was initially based on non-COVID-19 pathology. A study examining CPAP use in SARS found that CPAP avoided invasive mechanical ventilation in 70% of patients. Conversely, a study of non-invasive ventilation in critically ill patients with MERS found that over 90% of patients initially treated with non-invasive ventilation required intubation. Electrically driven CPAP was used for an average of 10 to 12 hours per day, along with oxygen supplementation of 8 to 12 liters per minute. From our limited study, we can only conclude that CPAP, when used with oxygen enrichment in COVID ICUs, can help in conserving of oxygen by improving the respiratory mechanics of the COVID-affected lung, which becomes an essential aim in a pandemic to serve maximum patients with limited resources. This can be of immense help in peripheral centers as well if the staff is adequately trained for the same. These are my references. Thank you.
So any questions for Dr. Shrutika?
Hello, sir.
Hello.
Yes, sir. You're audible.
Dr. Shrutika. So you have do a comparison between HFNO and CPAP. Basically, CPAP consume less oxygen, obviously. But is there any indication where we will choose HFNO over CPAP?
So, in my study, whenever the patients were deteriorating or they were not at all compliant with the BiPAP mask, which due to the other reasons like nasal abrasions or injury to the face or injury to straps, then they were shifted to HFNO. And even those patients who required higher liters of oxygen, who were deteriorating, were eventually then shifted to HFNO. This basically guided us that CPAP could be a bridge therapy as well, while conserving oxygen, so that a lot of oxygen can be saved in the 30 to 40 liters when HFNC was used irrationally.
Okay, yeah. So there is a different indication for different machines such as CPAP or HFNO. No? So if a patient has indication for both, we can use both HFNO and CPAP, then we will use the CPAP over HFNO.
Yes, sir. Yes.
Okay. Otherwise, some patient doesn't tolerate CPAP mask, then we have to go for the HFNO.
Yes. Okay.
Yeah. Okay. Thank you.
Thank you, sir.
Thank you, sir. The next presentation is of Dr. Ramesh.
Good morning, respected judges and chairperson. The title is Ratio of Height to Segmental Distance for Assessing Difficulty Laryngoscopy and Tracheal Intubation, a Prospective Observational Comparative Study. Introduction: difficulty with airway management in adult patients are major reason for hypoxia, cardiac arrest, brain injury, and death. An intubation is called difficulty if a normally trained anesthesiologist needs more than 3 attempts and more than 10 minutes for successful intubation. The aim of the study to assess the difficulty laryngoscopy by the ratio of height to sternum-mental distance and compare with modified Mallampati test. Objectives of the study: to assess the difficulty laryngoscopy by ratio of height to sternum-mental distance, to compare ability of RHSMD in predicting difficulty laryngoscopy with the modified Mallampati test. Sample size estimation. Prevalence of difficulty intubation obtained from our hospital registry is 20%. Based on this estimated sample size for our study, 186 patients with alpha 0.05 and beta 0.20. Approval obtained from all regulatory approval committees. Inclusion criteria for our study: American Society of Anesthesiologists physical status 1 and 2, aged 18 to 60 years, gender male, either female, patients posted for surgery and needing elective orotracheal intubation. Exclusion criteria: American Society of Anesthesiologists physical status 3 and 4, distorted anatomy of head and neck, unable to sit and stand, midline neck swelling, succinyl choline contraindication, patient unwilling to participate in the study. All patients were visited in the pre-anesthetic checkup room and were explained about the study protocol in detail. The airway was assessed one day before surgery using modified Mallampati test, sternum-mental distance, ratio of height to sternum-mental distance by the principal investigator. The modified Mallampati test was assessed with the patient in sitting position, mouth wide open and tongue maximally protruding without phonation. The sternum-mental distance was measured from suprasternal notch to the mentum and is measured with the head fully extended on the neck and the mouth closed. RHSMD was calculated by the formula height in centimeter, SMD in centimeters. Intraoperatively, an emergency difficulty airway cart was kept ready in the operating theater. A standard general anesthesia protocol was followed for all cases. All patients were received injection midazolam 0.02 mg per kg and injection fentanyl 2 mics per kg intravenously after attaching standard monitors. After pre-oxygenation with 100% oxygen, induction was done with 5 mg per kg of thiopental sodium and 1.5 mg per kg of succinyl choline intravenously to facilitate endotracheal intubation after ensuring mask ventilation. Direct laryngoscopy was performed using a Macintosh size 3 or 4 laryngoscopic blade with the patient in sniffing position, and the glottic view was graded using Carmack-Lehane classification and intubation difficulty score. The anesthesiologist who documented the Carmack and Lehane grading was blinded to the pre-operative airway indices to minimize the observer bias. The Carmack and Lehane grading 3 and 4 was considered as a difficulty laryngoscopy. Statistical analysis of data was done to evaluate the predictive value of each test for difficulty laryngoscopy. The sensitivity, specificity, positive predictive value, negative predictive value, and accuracy of each test was calculated. Statistical significance of each test was calculated and compared using Open API version 3.03. The area under curve was calculated, which is a measure of the prognostic accuracy of the test. An optimal cutoff value for each quantitative variable was obtained. The table showing demographic parameters, except height, all parameters are clinically significant. According to ROC curve, RHSMD greater than or equal to 9.85 predicted difficulty laryngoscopy with a sensitivity and specificity of 75% and 75.1%. The laryngoscopic grading of MMT and RHSMD. RHSMD had more true positive value than MMT. MMT had more true negative value than RHSMD. RHSMD had more false positive value than MMT. MMT had more false negative value than RHSMD. The table showing RHSMD had more sensitivity but lesser specificity compared to MMT. RHSMD had lightly lower positive predictive value and lightly higher negative predictive value compared to MMT. RHSMD was less accurate when compared to MMT. The intubation difficulty score of MMT and RHSMD, the table showing RHSMD is over predicting difficulty intubation compared to MMT. Discussion of our study result revealed RHSMD sensitivity more than sensitivity of MMT and MMT specificity more than specificity of RHSMD. From our study ROC curve analysis, the cutoff value of RHSMD was 9.85. RHSMD greater than or equal to 9.85 predicted difficulty laryngoscopy with a sensitivity of 75% and sensitivity of 75% and specificity of 75.1%. Conclusion, ratio of height to segmental distance appeared to be a more balanced predictor of difficulty intubation with a higher sensitivity index compared to MMT. RHSMD is over predicting difficulty intubation compared to MMT. Thank you.
Hello.
Good morning, sir.
Okay. Good morning, Dr. Ramesh. Okay. My question is that have you excluded?
So any questions for Dr. Ramesh?
Okay. Dr. Ramesh, my question is, have you excluded other etiology or other factors for difficult intubation in this study? Basically, you compared two factor for the difficult intubation, but there are so many, sometimes there are more than one difficult intubation factors. Those can be a bias in the study.
Yes, sir. Yes, sir. We are commonly taking difficulty intubation assessing, sir, with Mallam party, sir. Regularly we are used them, but other are biased, sir. They like thyromental distance or upper lip bite test.
Okay.
Like others are will excluded in the study, sir.
Okay. 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 Fine. Such as, just for example, such as long beard. A
Yes,
long beard can be a factor for the difficult ventilation or even sometime a difficult intubation also.
Yes, sir.
So,
we excluded that, sir.
Did you excluded this type of?
Yes, sir. Yes, sir.
Yeah. Thank you.
Thank you.
Dear chairpersons, thank you, sir. Thank you very much.
Thank you.
And we end the session here. Thank you, everyone.
Thank you, ma'am.
Stop ಆಯ್ತು ಇದು ಕ್ಲೋಸ್ ಆಗ್ತಿಲ್ಲಲ್ಲ ಕ್ಲೋಸ್ ಮಾಡು ಬಾ ಇದು ಒಂದು ಫಿಕ್ಸ್ ನಾನು ಬರ್ತೇನೆ ಚಾ ಮಾಡ್ತಿದ್ಯಾ ಎಂತದ್ದು
to identify the strengths, weaknesses, and areas for improvement. Students are reassessed after
Hello.
Good morning, madam. Good morning, everyone.
Good morning. Good morning, Swati.
Morning, ma'am.
Where are our speakers? Good
Is
morning,
everyone?
Ms. Kamath.
Good morning, ma'am.
Morning.
Good morning, ma'am.
Good morning.
Morning, Dr. Tina. Good
Hello,
morning, Dr.
hello, Dr. Swati. How are you?
I'm fine. Good morning, everyone. So the IT team, are we ready?
Yes, ma'am, we are ready, ma'am. So, ma'am,
We start?
yeah, sure, ma'am. So before starting, I would like to introduce the judges, Dr. Rekha Das. Professor Rekha Das, she is professor and head of Department of Anesthesia and Critical Care Pain at Acharya Harihar PGI of Cancer, Cuttack.
There are some background sounds, I think.
Yes,
coming from Shalu, I think, the administration.
And next judge is Dr. Swati Chabra. She is associate professor at All India Institute of Medical Sciences, Jodhpur. So, ma'am, we are going to start the session. We are going to start play the video. Our first video is of Dr. Tina Bansal.
Can you ask Shalu to please unmute
Novel
them?
sacral erector spiny block for post-operative analgesia in pediatric patients for hypospadias repair. Erector spiny block has ushered a new era in pediatric post-operative analgesia. First described by Tulgar et al., modified by Aksu et al. Erector spiny muscle extends from base of skull to sacrum. Patient is put in right lateral position, probe over sacrum in midline longitudinally. Medial sacral crests are identified. Needle is introduced from cephalic to caudal end. After needle tip touches the median sacral crest, local anesthetic is injected after negative aspiration. Our experience shows post-operative analgesia in hypospadias repair up to 18 hours. This is video of the block. Thank you.
Are we going to ask questions now?
Yes, ma'am. Yes, ma'am. We have 2 minutes for discussion. You can ask.
So in what position you gave the child? The speaker.
Child was positioned in right lateral position.
What is the volume you gave and what monitoring you did for the child?
Ma'am, we gave in the doses of 1 ml per kg was given, 0.25% bupivacaine was given. And monitoring was given, done regarding hypertension, tachycardia, hemodynamic variables were monitored.
Any untoward effect you experienced?
No, ma'am, till now, no adverse effect.
And how many cases you have done the study? No, only one.
Till now, I have done 5 cases.
Okay. Dr. Swati?
What are the known side effects? You did not experience any complications, but what are the known side effects of this particular block in the literature?
Actually, there is very little literature regarding a particular this sacral erector spiny block. There are only 2 or 3. That too only latter to a deter. And they say that there is no side effect because we go just below the erector spiny muscle. And if we do carefully, there are no side effects mentioned.
Are there any specific precautions to be taken if the child or the patient is on anticoagulants for this block?
There are no recommendations till now regarding this. We can put the block carefully.
What is the sedation? How did you manage to do this in a position in a child?
Ma'am, after general anesthesia, we induced the child. General anesthesia was given and it was given for post-operative analgesia. After anesthesia was given.
So how did you test the positivity of the block?
Ma'am, after the
By
block, yes,
USG.
ma'am, by USG, it was confirmed. We saw the spread of the block, and then hemodynamics variable after incision, there was no increase in heart rate. And after that, when the patient woke up, the duration of surgery was up to 1 hour. And after the patient woke up, he was calm, he was child, he was absolutely calm. And we, by VAS score, we monitored him up to 24 hours.
Did no failures?
No, ma'am, till now, no failure.
Okay, ma'am.
Any more questions, Swati?
No, ma'am, I think we can go to the next presentation.
Thank
you. Thank you.
Thank you, ma'am. The next presentation is of Dr. Neelam Parmar.
Good morning. I am presenting a case of 3 months old female child with 57 centimeter size big, that is almost double the size of head, occipital meningocele posted for VP shunt surgery. Main challenge in this case was to secure the airway with constant fear of rupture of meningocele. So we plan to intubate the child in left semilateral position using pediatric ATRAC blade. ATRAC provides us direct view of glottis without any deviation of normal oropharyngeal laryngeal axis. With this quality of ATRAC, we successfully intubated the child in first attempt without any episode of desaturation. The surgery went uneventful. Thus, ATRAC proved to be the real boon in airway management of such cases. Thank you.
Ma'am, questions?
Yes. In which way the air tract is superior to other forms like video laryngoscope?
Ma'am, actually, ATRAC provides us the direct view without any changing in the normal oropharyngeal and tracheal axis. Same way, the screen is also there so that other students, other anesthesiologists can also see the procedure. So, as we are practicing in teaching institute in medical college, so it is good for residents also to learn the way of intubation with the use of ATRAC.
Please explain the procedure.
Ma'am, first we gave, after taking high-risk consent and all, we secure IV line in the hand, and we have given pre-medication injection glycopyrrolate, and we gave injection fentanyl 5 microgram, and child's weight was 2.8 kg. So we, after adequate pre-oxygenation with 5 minutes with 100% oxygen, we induced the child under sevoflurane inhalation, and once the reflexes was respiration was shallow, we attempted intubation in left semilateral position, and we gave position by putting a pillow under the child on the left side, and with the help of ATRAC, we were able to intubate the child in first attempt itself.
Describe the ATRAC mechanism of work. Describe the ATRAC intubation. That's what I wanted.
Ma'am, ATRAC, because with Macintosh bed, we need to do morning sleeping position, but with the help of ATRAC, we need not to change the position of child. We did not need to do extension or flexion of head or neck. So, along with the normal curvature of airway, we can go and under direct vision, we can intubate the child.
Okay. So is it, you feel it is superior to the video laryngoscope, conventional video laryngoscope?
Yes, ma'am.
Okay, Swati, please.
So what is your plan B if ATRAC or your initial attempt fails? What is your plan B in pediatric patients?
Ma'am, as such, child did not have any other abnormality related to airway, and child was comfortable in this lateral position itself. So our plan A was doing in the same position. But if it fails, then we have kept ready the pillows and donut ring to make the child supine, and carefully we can intubate the child in supine position by putting over the pillows and donut.
What other specific airway equipment you had ready to rescue the airway?
Ma'am, we were very much sure that we will be successful to intubate the child with the help of air track, because we have good experience with the air track. So,
but you must have a backup plan, no? That's what. So what backup plan would you propose here in case if it failed?
ma'am, intubation using air track itself in supine position. That was our plan B.
So anything about supraglottic devices? Were they
Yes,
kept?
ma'am. Yes, ma'am. LMA we have kept ready in emergency situation.
And just last, a small comment on what residents, what type of training do they undergo before they can take these cases? Is
Ma'am,
there
we allow them to do class 1. No, ma'am. Actually, pediatric simulation dummies are not there in our institute. So, in first we allow them to do in adult patient with the help of air track. Then, in when they come near the term, then we allow them to handle the pediatric cases, definitely under the guidance of staff.
Okay, thank you so much. That's it from my side.
Thank you, ma'am. Yeah, thank you, ma'am.
Thank you. The next video is of Dr. Harsha Patel.
Morning, everyone. As we all know, pandemics are unpredictable by their nature. And as the pandemic evolves, priorities for public health action, case definition, and treatment strategies change with the emerging information. As the nodal officer of triage area at our COVID-19 hospital, to develop and follow a triage protocol was a real challenge. We adopted a flexible approach to maximize benefit to the largest number of patients presenting to our resource-limited critical care system. Initially, we screened the patients by clinical condition and SpO2. But as the pandemic progressed, we started receiving a large number of patients. So we scrutinized them mainly into two groups, one who require urgent ventilatory care, another who can wait. When there was a big surge of patients in our already overwhelmed hospital, in order to provide immediate treatment, we started triaging patients in the ambulance itself. Thank you.
So what are the limitations in triaging in ambulance?
Sir, in ambulance, sorry, madam, good morning. In ambulance, we have certain difficulties like the anxious relatives with the patients. So we have to deal with them also. And in the presence of their anxious relatives, we have to triage or give primary treatment to the patients. And it was so much of surge that we cannot handle patients and the relatives but at a time both. So this was the utmost difficulty. And the second one, why we are triaging in the ambulance, we are also communicating for the available space in the ICU or a ventilatory bed. So whenever we receive the message of no, then it was in the presence of patients only. So we have to phone again in the other ward or other facility. So that two are the main obstacles while triaging the patients in the ambulance.
What monitors you used for triaging? Since you're doing it in an ambulance, all your ambulances are high-end ambulance, or you must be having a mix of ambulances?
No, ambulance are usually 108 and for the private hospitals.
So what monitoring you did? What monitoring? Only saturation or anything else you did?
We are monitoring SpO2 and only SpO2. And by clinical conditions, we are triaging the patients.
Did it change once you got the patients admitted? What was the changes you faced? Any different discrepancy between your assessment in the ambulance and in the emergency ward?
No. Usually, in the initial stage, there is no discrepancy, but after half an hour or hour and two, some patients get settled, and other may require more shift to the more critical stages. But usually, we are admitting the patients who require a ventilator. So usually it doesn't make any difference within a day.
What happens when a patient crashes inside the ambulance? How you manage that?
I have not witnessed any patients I have lost in the ambulance, but I think it may occur. But at that point of time, the patient's relatives are also watching us, and they are watching us. Okay, we are trying our best, level best, to save their relatives. So usually they become cooperative, or they are usually helping us rather than obstacles. Even though they are very anxious, they are a little bit cooperative and helping in mood to help us, because they are showing we are running for their life.
Swati, please.
Yes, madam. Did you conduct any data analysis to know that your triad system, the algorithm really worked, or you put in some suggestions for change in the algorithm?
So our data analysis is going on. At the time of that search, the data collected, we have collected the data, or the medical records are in a haphazard manner. At now they are in a medical record system, so we are not receiving very smoothly that record. So we have a hurdle to collect the data and data. We have started data analysis, but at present we are only collecting the data. And we are having very much hurdles in collecting the data itself, because so much of records and so much of privacy and confidentiality. So we have some obstacles, but it will take time to done data analysis done.
Okay. So those were the really difficult times with everyone running for their lives, as you said. So all this triaging system, did you face any, violence from the patient relative side to take not follow this triage mechanism you had put in place? And what was your safety mechanisms put in place for that?
Now, initially, when there was a starting of a pandemic, at that time the relatives were very hostile, and they are a little bit in a mood to angry, and they may. But at that time we have a bouncers at our triaging area gate, and we are allowing only one relative at the door. But at the time of higher surge, automatically the patient's relative become cooperative. They are seeing us, and usually they do not, they become sad and anxious and scared. Usually they don't become violent. When there was a big surge, they didn't become.
The common notion is the patient will be taken inside the hospital or will get a bed once their turn comes. But triaging would mean that they won't be taken by turn, but by the clinical condition. So that's very difficult for the society to learn that it's my turn, be it a very elderly patient, but if turn is there, he has to be taken on a bed. And triaging would mean that we have to skip 4 or 5 patients and take the 6th patient. So,
but actually what I have observed, we are on a constant, we have a constant rate of violence. But we have observed that at the time of crisis, usually the relatives become cooperative. They know the relatives with a stable patients can understand the other patients suffering, because they are seeing it. So usually we don't face any big problem. Some relatives may require counseling.
Pandemic, definitely people were cooperative, but there were some instances of untoward behavior from the attendant, and you never know. It is unprecedented.
Yes.
When it happens, you never know.
Sir, our hospital have appointed bouncers, but we have a very good team of counselors. They usually counsel the relatives from the very beginning.
Thank you, madam, for doing all this very
wonderful work. Yes.
Yeah.
Thank you, madam.
Ma'am, our next presenter is Dr. Kamath, Chaitanya Kamath.
Respected judges and delegates, my topic is effectiveness of a new assessment tool, direct observation of procedural skills, DOPS, among anesthesiology postgraduate students. With a global shift towards competency-based medical education, there is a movement from traditional to newer workplace-based assessments like DOPS. This prospective interventional study was conducted to determine the effectiveness of DOPS as an assessment tool to improve the procedural skills of anesthesiology postgraduate students. They were directly observed by the faculty while performing the 3 core skills of anesthesiology: endotracheal intubation, spinal and epidural anesthesiology. Observations were documented on DOPS rating scale that was noted as pre-DOPS score. Immediate verbal feedback was given. Students were made to identify their strengths, weaknesses, and areas for improvement. Students were reassessed after 3 months, which was post-DOPS score. Analysis was done using SPSS version 20. We found that there was statistically significant improvement in the procedural skill performance after DOPS. Students and faculty gave positive feedback about DOPS. We conclude that DOPS is an effective, efficient assessment tool in improving the procedural skills of anesthesiology postgraduate students. We also recommend that it should be implemented as a formative workplace-based assessment tool as a part of CBME curriculum. Thank you.
Okay, you are saying that direct observation, normally this is a normal procedure. Normally the students always see, it is not always simulation. In majority of the cases, we always teach our student by direct observation. So since you have made it as a study, did you compare it with any other method? Then only you can show the significance of this. Unmute yourself, please. Dr. Kamath, unmute yourself.
Yes, ma'am. Good morning, respected judges. Yes, ma'am. We did this. It was a new assessment tool introduced in our college. So we wanted to know the initial improvement in the procedural skills of anesthesiology postgraduate students after introduction, introducing this newer workplace-based assessment tool, and we wanted to see how effective it is. So we did this initial assessment, and we scored the students on the various aspects like their technical abilities, their pre-procedure preparation, and their communication skills, their professionalism, and post-procedure management. On all these points, we scored them, and the total score was noted down. After that, we gave them feedback on what they can go improve, and we made them to realize the self-realization, what they could have done better, and what are the scope for improvement, and what were their strengths. After 3 months, we did a reassessment. Again, the scores were given. We found that there was significant improvement in the overall mean score of the students. So in this way, we felt that there is, with this way of assessment, there is improvement in the procedure skills of the students, madam.
So you did a crossover study. Initially you did without, and then the same group of people again you subjected to direct observation.
Yes, ma'am.
So you mean to say that all the students were made to do some intubation procedure without understanding it, without observing their seniors doing it?
Yes, madam. There was a definite lack of.
What is the ethical? There are some ethical issues involved in this. If they do not see procedures and they directly do.
Yes,
students, they are students.
Yes,
so you cannot put a first-year student and newcomer student directly to
yes, ma'am.
intubation.
We had discussed in our department regarding this, and during the observation, if the student does any step which is injurious or harmful to the patient, we will stop it there and we'll exclude. Like we will intervene and take over, and that student was excluded from the study, madam.
The study was passed to your ethics committee.
No, ma'am. That student was not counted as a part of study, ma'am. He was not taken as a part of study because we intervened during the procedure itself, because it was turning harmful to the patient. Like during one intubation, I was just observing, and student was performing a intubation, madam. He was not able to intubate, and he was not calling for help. There is marks for that also. Call for help, whether they are doing it at right stage or no.
You mean to say without observing a procedure like a spinal or a intubation or any regional block, a student is made to do upfront without going through the procedure of observation or anything, observing the senior?
No, ma'am. No, ma'am. This study was done on second year and third year postgraduate students who had already completed 1 year of tenure in the department. It is not the
That-
first
that it
time.
needs, I think it needs some clarity. There is some clarification is required regarding your selection of students or select
Yes.
samples.
Yes, madam.
Okay. And there is some, it's not very clear. I don't get it actually.
Ma'am, this DOPS is a way
Over
of
to Swati.
workplace-based assessment.
I think we have limited time. Swati can speak.
So just a small question. How many observers were there, and were there any inter-observer differences while you are observing residents doing these skills, performing the skills? How many observers were appointed?
Three observers from our department, ma'am. All associate professors did the observation of all the students, and we assessed in the first stage.
So these were performed only on elective cases?
Only on elective cases. Only on elective cases, and during very core skills of anesthesiology, madam, like spinal, epidural, and endotracheal intubation only we included. Thank you, madam.
Next presentation, please. Tech team, can we have next presentation, please?
Who is the next speaker? We can skip some speakers. Whoever is available, we can go to them.
I'm sorry to interrupt, but we are out of time. So can we move to the next presentation?
Yes, we are telling you to start the next presentation.
The next presentation. It is by Dr. Surekha.
Namaste. Tidal volume challenge test to assess preload responsiveness. A novel test proposed to improve the reliability of pulse pressure variation in predicting fluid responsiveness during low tidal volume ventilation. It involves transiently increasing the tidal volume from 6 ml to 8 ml per kg predicted body weight for 1 minute in a paralyzed patient and observing the change in pulse pressure variation from baseline to that of 8 ml per kg predicted body weight. A change in pulse pressure variation of 3.5% reliably predicts fluid responsiveness. Advantages: it is a simple bedside test useful in resource limited settings and does not require a cardiac output monitor. However, it cannot be used during spontaneous breathing and in lungs with low compliance. To conclude, tidal volume challenge test increases the reliability of pulse pressure variation to predict fluid responsiveness during low tidal volume ventilation, which is now a common practice in ICU. Thank you.
So what are your confounding factors in tidal volume challenge test?
Ma'am,
In a patient who is paralyzed, anesthetized patient you are doing, no?
Ma'am,
During
yes,
operation.
ma'am. Basically, now we have started watching for this in ICU. The main thing is those patients whose compliance is low, that will be the main confounding factor, ma'am.
So what are your inclusion criteria on which you are doing the study?
Ma'am, as of now, we are not taking, actually, ma'am, basically we did this during COVID times. And now we are also observing this in operation theaters also, ma'am. So now, as of now, and basically patients who come for emergency surgeries only we are looking for, ma'am. Other than in ICU, we have observed this in on-table patients posted for emergency surgeries. So we have not taken any patients who are in ARDS. So on admission only we are observing this, ma'am, who are intubated, who require intubation.
So outcome parameters that you are observing with the
Ma'am, we have
tidal
only,
volume.
ma'am, as of now, we have only looked for fluid requirement only, ma'am.
But how do you know? Like, what are your outcome parameters? You are doing any
Ma'am,
observation?
after giving fluid, ma'am, on table, after giving fluid, if the patient is showing responsiveness in terms of improvement in blood pressure, heart, and settling in heart rate and hemodynamic parameters only we are observing, ma'am. Like
How
whether
are you
the patient
measuring?
is improving.
How are you measuring the pulse pressure variation? You have devices
Ma'am,
for
we
that?
have, ma'am, our monitor has an inbuilt software, ma'am. So that immediately displays the value when automatically we change the tidal volume. At baseline, we measure when we are ventilating at 8 ml per kg. And then when we change it to, 1 second. And then when we change it to, when we reduce the tidal volume, again the monitor displays the value, ma'am. It is an inbuilt software, ma'am. Actually, we need to ask the technician, most commercially available ventilator workstations have this software, ma'am. The only thing is we need to enable it, ma'am.
No, what monitor you are using? What brand of
regular, ma'am, Draeger
inbuilt monitor?
Draeger
Okay.
machine.
Which
Yeah, ma'am, it is inbuilt,
which model of Draeger you are using?
Ma'am, no, what normally in OT, I'm not specifically, I do not know, ma'am, but because of this study only we have got it enabled, ma'am.
Swati, please.
So what patients do you plan to exclude, did you exclude from your study?
Ma'am, as I said, as of now, only in emergency surgeries, we have not conducted a complete study, ma'am. We are only observing for. So as of now, patients who are posted for emergency surgeries only we are taking care of, unless.
Do you anticipate it will change the practice?
Ma'am, definitely, ma'am. Because as we all know that fluid management is one of the critical aspects in anesthesia management also. Many a times we end up problem whether to give fluid or not to give fluid, how to assess responsiveness. Only as we all know that now that static parameters like CVP and all is outdated, and even the surviving sepsis guidelines also recommends using dynamic indices. And this is one of the simple using this simple software, actually we can change the practice. Most of us are not aware that this can be enabled and practiced, ma'am.
Thank you.
You can go. Have you made a comparative study with any other method?
Ma'am, ma'am, we are planning to do this as a comparison with lethysmographic variability index, ma'am. That is our thing. Whether PVI is and this in comparison, what will be the result that we are looking forward to do, ma'am.
Okay, thank you. Next presentation is of Dr. Gulia.
Talking about palliative care as an added responsibility of the anesthesiologist. Only 2% patients in India have an access to palliative care. But why anesthesiologists? Because along with experience in pain management, they have an expertise in serving the critical need. Palliative care knowledge will trigger better communication about expectant management, risk discussion, along with surgical utility, and resuscitation discussion, along with a better end-of-life communication. The COVID-19 situation has led to limited family access to the ICU, leading to increased stress and need for more effective communication skills. The palliative care training will help us learn high-quality symptom management, counseling, along with end-of-life communication. Thank you.
Swati, you can take these questions first.
Yes, madam. So what is your personal experience with the palliative care? What challenges have you ever guided any patient through the palliative care as a first-hand performer?
Yes, ma'am.
Provider?
Good morning, ma'am. Ma'am, I have worked in the onco anesthesia department at AIIMS, New Delhi. Ma'am, it is a combined department with the palliative care. So, ma'am, we see patients in the OPD for pain and as well as for the palliative care needs, ma'am. So there I have understood that for patients with major surgery as well as for patients who come for chronic pain, there is a very important role of palliative care, ma'am. They need supportive counseling as well as, ma'am, there needs to be address. We need to address the various symptoms also, ma'am, apart from the.
So we'll make it short. So what are the two foremost challenges in your belief which are there in the Indian setup for palliative care towards the society?
Ma'am, the major challenges include that the term palliative care is very, the patients take it as a very detrimental thing. They think that when they have been referred to a palliative care physician, that means their treatment is not going to be continued. And they have this notion that they will only be on some supportive management and their primary physician has given up upon them. But ma'am, when we do it in a system that is integrated, so we intervene from the very starting, like ma'am, when we take the patient for
Can you take the challenge number 2? We'll have
Yes,
to
ma'am.
be short. What's the second challenge?
Ma'am, the second challenge includes that these patients, ma'am, they have a lot of pain, but along with that, they have a resource limitation, ma'am. So coming to the hospital is a very big issue, ma'am. So
Rekha Das, ma'am, take your question.
So what are the, you said in the OT, what are the areas where anesthesiologists can work
yes,
towards a palliative goal?
Yes, ma'am. Ma'am, when the patient comes to us in the OPD for a pre-operative evaluation, ma'am,
One.
there it's
just quickly areas.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Ma'am, then when the patient is admitted in the pre-operative area, there we need to discuss the pain management as well as the symptom management in the post-operative period. Ma'am, then in the post-operative period, ma'am, apart from the pain management that we do, ma'am, we also do the rehabilitation of the patient towards a normal life, ma'am. And then ma'am, we also tell the patients at discharge that they can follow up in the OPD for any pain or any symptom management that they might have because of such a big surgery or the disease.
Yes. Do you think anesthesiologists are equipped to do the counseling regarding palliation and other palliative guidance they can give, or they need to undergo training for this?
Ma'am, as far as I have seen, ma'am, we have to just be patient and ma'am, listen to the patients, because most of the times what lacks is the patient listening and the a good communication, ma'am. Most of the times for 80% of patients, we don't need psychiatrists, ma'am. We can manage them on our own.
No, but do you think training is necessary? Communication skill is necessary for
ma'am, communication skill training, yes, ma'am.
Or anybody, any anesthesiologist can give it.
Ma'am, palliative care training that is there for ma'am 2 days, it can also help ma'am learn the better communication skills. But ma'am, we can start on our own also, and then we can ma'am as like time permits, we can attend.
Yes. So when you did a study, did you yourself undertake a training before communication?
Yes, ma'am. Yes, ma'am. When I joined the department, ma'am, we have a 2 days training of Indian Academy of Palliative Care, ma'am. That we did, and then only we like approached the patients so that we could better, ma'am, handle the patients.
Is it enough?
Sorry to interrupt, ma'am.
Ma'am,
we can go.
Yeah.
Fine. Sorry. We can go over to the next.
The next presentation is of Dr. Smita.
Warm wishes to everyone. Let us look into pharmacokinetics and target controlled infusion in TIVA. For TIVA, thorough knowledge of pharmacokinetics of IV drugs is very essential. It mainly consists of two important aspects: volume of distribution of the drug in the body and its clearance out of the body, determining the effective plasma concentration and the effect site concentration or the pharmacological effect. Three-compartment model explains the volume of distribution and also that an ideal TIVA drug should have rapid onset and rapid offset. For the conduct of TIVA, the required effective plasma concentration has to be maintained. For this, complex mathematical equations are required. If it is to be done manually, then it requires a lot of effort and also prone for errors. If it is computer programmed, then we have target controlled infusion or the TCI, which is much more reliable and easier to use. There are various TCI models which are based upon the measurements of effective plasma concentration across various subjects. The prominent ones are for propofol, Marsh and Snidel in adults, Pete Fusel and Kataria in children, and Minto for remifentanil. Thank you.
Pati, you can go ahead.
Okay, are you using personally the TCI?
Ma'am, not. We are right to get the TCI pumps in our institution, but I have elsewhere observed because of the gases and then the inhalationals we are using. So because of the environmental hazards and the occupational hazards.
Okay, what monitoring is used in conjunct with TIVA and TCI? What additional?
The BIS monitoring can be used as we use it for inhalation anesthesia. The BIS monitoring can be used. So, but it is though not routinely used. And for learning purpose for residents, everyone, and for even for us also. So we can start with using TIVA for the regional anesthesia and then slowly go on to other surgery cases.
Okay, in your belief, what are the side effects? There are many advantages of using TIVA and TCI. What are the disadvantages?
Yeah, there are disadvantages. So mainly we will be using propofol, so which causes propofol infusion syndrome. So, but that will be in the ICU setting. So that will be more than 48 hours, not in the surgical settings.
So if you are not using this, in my belief, awareness is a more common problem. I hand over this to Rekha Das, madam.
Remifentanil is available in your center?
No, madam, remifentanil is not there. So propofol and that too, PCI model is not there, madam. We are yet to get it.
Okay.
However, the propofol with a manual infusion method only we have used.
Fine. That's it.
Thank you, ma'am.
Thank you.
Ma'am, our next presentation is of Dr. Gauri Chaudhary.
Good morning, everyone. Mucormycosis in COVID patients, a rare phenomenon in developing country India. Mucormycosis, commonly known as the black fungus, was and is still a major challenge to India, especially after the second wave of COVID. It was declared as an epidemic and a notifiable disease in various states. The etiology of mucormycosis in India is multifactorial and links it to severe COVID-19 patients who are immunocompromised or have comorbidities, especially uncontrolled diabetes mellitus. Then indiscriminate use of corticosteroids, which decrease the immunity and increase the blood sugar levels, increase the mucormycosis risk. Prolonged use of ventilators and humidifiers and unhygienic use of masks has an association with the increased risk. Another hypothesis being debated is the use of industrial oxygen for medical purposes as a potential link. Delta variant link is also yet to be established. Use of other unproven treatment for COVID like zinc and iron supplements provide a favorable environment to fungus to grow and is linked to the risk. Early diagnosis and prompt initiation of treatment is very important, and medical management includes amphotericin B, aggressive surgical debridement. Thank you.
How many cases of mucor you have witnessed yourself? How many cases of mucormycosis you have witnessed during COVID?
Good morning, ma'am. Ma'am, in our institute, there were approximately 400 mucormycosis patients that were operated for that. And otherwise, ma'am, there were around 100 to 150 patients that were on medical management.
So what you have cited so many causes of mucormycosis. What is the most predisposing factor?
Ma'am, diabetes was the most commonly found risk factor that were present in most of the mucormycosis patients. And apart from that, ma'am, steroid use that was found to be very prominent risk factor in mucormycosis patients that were attended in our hospital. Most of the patients who were COVID positive, they were subjected to steroid treatment during their COVID time, and later on they manifested with mucormycosis.
Okay, so how your team was strong, were many enough to handle such a huge number of cases of mucormycosis?
Yes, ma'am, there were approximately every day, 24 hours, we had 4 tables which were dedicated for mucormycosis patients, and they were taken, ma'am, almost after every, almost consecutively they were taken, ma'am. They were running continuously.
Swati?
Yes, in your experience, what was the age predominance, whether they are involved with the young patients, elderly, or a mix of them?
Honestly speaking, ma'am, there was no age predominance. Ma'am, in mucormycosis, what we have attended, ma'am, they were ranging from young patients also and old patients also. Ma'am, both the age groups were coming for mucormycosis, ma'am.
Okay, what complicated cases like dural extension, intracranial extension, what were the outcomes at the center?
Ma'am, the outcome was generally poor. Ma'am, out of the 350 cases, ma'am, we got done for mucormycosis. Ma'am, 150 patients, ma'am, they expired later on after a month of treatment or so.
Was conventional amphotericin B was used or some other form was used?
Yes, ma'am, liposomal amphotericin B was used, ma'am.
Okay. Can we go to the next presentation?
Yes.
Thank you.
Yes.
Okay.
How many more are there?
Thrive. Transnasal humidified rapid insufflation ventilatory exchange is a physiological mechanism of oxygenating and ventilating a patient with diminished or absent respiratory effort. It has a dual function of apneic oxygenation and ventilation. Transnasal inflow creates a supraglottic flow vortex, which reduces the dead space and enhances the nasopharyngeal carbon dioxide washout. Humidification makes high flow rates possible, aids in mucociliary clearance. Rapid insufflation reduces the upper airway resistance, replenishes the pharyngeal oxygen reserve, produces a CPAP, which prevents airway collapse, preventing atelectasis. Increase in FRC enhances the gases exchange. Ventilatory exchange is through the cardiogenic oscillation. It gained its recent importance in the management of COVID pneumonia. It is used in the management of difficult airway, shared airway in patients with reduced oxygen reserve and procedural sedation. Thank you.
Swati, you can go ahead.
Yes. In Thrive, what does the term ventilatory exchange mean?
Exchange of the gaseous exchange of oxygen and carbon dioxide. This was through the mask bulk flow and also through the cardiogenic oscillation, depending upon the patient's the stroke volume. Usually between the stroke volume of 6 to 15 ml, there's some amount of, it's by the respiratory movements, there's some amount of gaseous exchange. This is the ventilatory exchange.
Can you enumerate the other applications of this technique?
There can be Taylor's dispersion, ma'am, and maybe because of high frequency oscillation, bulk flow, or the other mechanism involved in ventilation.
I'm asking about the clinical applications of Thrive.
Where all it can be, it can be used in, especially where there is where you're in patients, especially in pregnancy, in obesity, patient coming with intestinal obstruction where the FRC is reduced. During difficult intubation, you can use as a aid for improving the oxygenation. And patient, if they come with difficulty, trismus, or in case of microlaryngeal surgery, if you have to do a rigid bronchoscopy or in ERCP, all those procedural sedation, it can be used, ma'am.
Thank you. Rekha, ma'am.
What is the advantage of Thrive over the conventional nasal flow oxygen of 15 liters?
Here it is humidified. It is humidified to a room temperature of 37 degrees. And there is also exchange of the, you can make the patient both apneic oxygenation and also apneic ventilation can be done with Thrive, ma'am. But it cannot be done with the nasal inflow of oxygen.
No, what's any other advantage you get in Thrive over the nasal flow oxygen, just of 15 liters? One is the ventilatory exchange that occurs.
Yes. Second is carbon dioxide wash also can also
that is the ventilatory exchange. What other advantage you get? Two differences between a major difference between a nasal flow oxygen and a Thrive.
Ma'am, here the airway collapse is prevented. Atelectasis is not in Thrive. There will be no atelectasis. CPAP is produced depending upon the flow. Usually
how much you generate?
Ma'am, for every 10 liters, it's about 0.7 centimeters of water of CPAP is produced. If it is 10 liters, you get 0.7. If it is 70 liters, you get a CPAP of 7 centimeters of water. So this prevents the airway collapse so that you can still maintain, oxygenation level can be maintained. They don't desaturate faster.
Fine.
Thank you, ma'am.
Good morning, ladies and gentlemen. LMA-Gastro is a novel airway device for endoscopic procedure, especially in the difficult airway scenario. It has got a wider lumen for insertion of the endoscope and a separate channel for the airway control. As we know that the gastroendoscopic procedures are the day care procedures, here we do not want to use the general anesthesia or insert the endotracheal tube. Here the LMA devices fit into the bill. These supraglottic devices are helpful in the difficult airway and restricted mouth opening cases also. We have done these cases with the help of gastro LMA with encouraging results. We found that it had ease of insertion, there were lesser adverse events, and the recovery was faster. These are the few cases done in our center with the help of the gastro LMA, and you can see that these are the difficult airway scenarios or the restrictive mouth opening. We can say that LMA gastro is a helpful device for endoscopic procedures in the high risk cases and the difficult airway scenarios. Thank you. Thank you very much.
You showed cases of trismus. How did you manage to negotiate your gastrointestinal endoscopes? Unmute yourself, please, Dr. Anurag. Please unmute yourself.
Yes, ma'am.
Yes. You showed cases of trismus. How did you manage to negotiate your gastrointestinal endoscopes through this?
Ma'am, as such, in the cases of trismus, in case initially we give propofol, that just loosen up is acts like a muscle relaxant also. However, we can give scoline in case if the ventilation is fine. And
but LMA has certain criteria of mouth opening. So, what did you do before you went into this study? What was your inclusion and exclusion criteria?
Ma'am, in the inference, my inferences were like it is easy to insert, even in the cases of difficult airway scenario, since we have to protect the airway, especially in the old and patients with comorbid conditions. Otherwise, these procedures.
But you showed mouth opening there was no mouth opening in many cases. So how did you manage to insert that?
Yes, ma'am. Ma'am, if you see, this is an inflatable device, ma'am. So once we deflate while inserting, even a mouth opening of 1 centimeter is feasible to insert. I do have videos of inserting the thing with minimal mouth opening of even 1 centimeter.
So what was your experience in the post-op period with post-operative sore throat and other complications, blood on the device or anything?
Ma'am, as such, as I said, there were very minimal complications or adverse events. As in the case of other LMAs, what has been noticed with iGel and other inflatable LMA devices. This device also meets the challenge and proves its mental.
How many patients had post-operative sore throat?
There were no, since ma'am, immediate post sore throat was not there, but since they were daycare procedures, the patient did report to us after 48 hours, not immediately the second day or something, but 48 hours, and they did not complain, not even a single person complained of sore throat. As such, we are not intervening the airway, and it is just a supraglottic device, so there was no sore throats.
Actually, post-op sore throat is more with supraglottic airway devices as compared to endotracheal. Thank you.
Ma'am, but in these cases, since number one, these were the daycare surgery procedures, we were able to meet our aim to avoid the complications of GA. That is insertion of the tube, use of muscle relaxants, and delayed recovery, which were not there at all. My patients, immediately I removed the supraglottic device. Within 5 minutes, they were awake, and I could send them to ward, post-op care ward after 15 minutes, and after 2 hours, I could discharge them, and almost all of them.
Thank you.
Thank you, sir. Thank you. Thank you very much.
Thank you, ma'am.
Pediatric anesthesia is a challenge to the anesthesiologist, and the challenge begins from the point of giving the first prick, especially to the older temperamental children. The parental anxiety adds to it. This method I have found to be effective and successful in almost 100% of cases. नाम क्या है तुम्हारा? तुमको बेटा एक छोटी सी इंजेक्शन मिलेगी, समझी क्या? वो मेरे को लगाने देंगे, तो फिर तुमको आराम से लगाने हैं। अगर तुम नहीं लगाने देंगी तो मैं तुमको 4 मोटी मोटी इंजेक्शन लगाऊंगी। अब मुझे तुम बताओ, एक छोटी इंजेक्शन चाहिए कि 4 मोटी मोटी इंजेक्शन चाहिए? कौन सी क्लास में हो? नहीं, आप कौन सी क्लास में हो? अच्छा, क्लास में नहीं जाते हो आप? सबसे बड़ा कौन है? आपके दिन बड़े हो आप? खोल दे बेटा, हो गया, हो गया, हाँ?
So you think this is
Ma'am,
more
the
preferable to
sorry,
this is
ma'am.
yes.
The presenter is not here.
Okay. Then let us move to the next one, please.
Ma'am, this was the last presentation, and thank you very much for chairing the session, ma'am. Thank you.
Are
Sorry.
we supposed to give them marks or give them
Yes.
some prize? No?
Yes, ma'am. I have sent the scoring sheets to your email addresses. You can just fill that back.
Okay. Thank you so much.
Rekha, ma'am.
Thank you.
Thank you, everyone, all the participants. Thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you all.
Thank
It was it's very nice presentation and very good, well organized.
Thank you, ma'am. Thank you, ma'am.
Thank you, Swati. Let's have a.
Yes, we will meet and yeah. Okay, ma'am.
Hello, good afternoon, everyone, and welcome to the Railway Forum. Our first speaker is Dr. Chandan Kumar Pal, and the topic of his presentation is anesthetic challenges in the cleft lip and cleft palate surgery under the Mission Smile in Railway Hospital.
Good morning, respected chairpersons and distinguished dignitaries. Today, my topic of presentation is anesthetic challenges in cleft lip and palate surgery under Mission Smile in our railway hospital. I am Dr. Chandan Kumar Pal, Divisional Medical Officer in our hospital, Central Hospital, Southeastern Railway Garden Dish, Kolkata. Cleft lip and palate together constitute third most common congenital anomaly that requires surgical correction at an early age. So we can say that the smile that really impact the life. Regarding Mission Smile, their compassionate, comprehensive cleft care process are consisting of following: creating awareness at the village level, followed by preliminary screening, patient transportation, medical screening, followed by putting and lodging of the patients and the guardian, nutritional support, surgery. After that, post-operation care, dental treatment, speech therapy, and they done everything free of cost to the patient. Regarding Mission Smile, so far 11 medical missions are organized at our hospital till date. Volunteers have participated from 18 different countries, and total surgeries done in India are 39,000 plus. Only in West Bengal, 7,000 plus. And our hospital, it is 1,000 plus. Most of the missions are consisting of more than 100 surgery, and few missions consisting of 60 surgeries. Regarding embryology, cleft lip is formed due to failure of the fusion of the maxillary process with the medial part of the frontonasal process. Here we can see. It may be unilateral or bilateral, or it may be complete or incomplete. And cleft palate, anterior portion of the palate is formed by the fusion of the frontonasal process, and posterior portion is formed by the fusion of the maxillary process. Cleft palate it is also maybe unilateral or bilateral, and maybe prepalatal involves anterior to the incisive foramen. It may involve anterior palate, alveolus, lip, nostril floor, and alinizar. And postpalatal, it is posterior to the incisive foramen. So here cleft may extend anywhere from soft and hard palate to incisive foramen. And submucosal hair cleft only in the bony defect without any mucosal defect. And incidence of the cleft lip palate, isolated cleft lip is 26% more common in the boys. Cleft lip associated with cleft palate is 35%. And cleft palate alone is more common in the girls. And it is also associated with other birth defects. Associated anomalies occur 30 times more common, and particularly with isolated cleft palate. Now I am showing few pictures. Here is a white bilateral cleft lip palate, white unilateral cleft lip palate, white bilateral cleft lip palate with variable protruding premaxilla, white bilateral cleft lip palate with variable protruding premaxilla. Here is an adult patient with unilateral cleft lip palate with large tongue. What are the problem faced by this patient? Problem in the suckling and swallowing. So difficulty in feeding leads to inadequate weight gain, nutritional deficiency, and also anemia is more common in this patient. Due to regurgitation of fluids and the foods, there is chronic upper respiratory tract infection, which gradually leads to lower respiratory tract infection also. There is difficulty in formation of the palatal consonants in this patient like T, P, R, and T. What are the associated anomalies? It may be non-syndrome related, like other birth defects, like umbilical hernia, club foot, limb, or ear deformity. And there are several syndromes may be associated, like Pierre-Robin syndrome, Teacher-Collins syndrome, ventricular septal defect, golden hand syndrome, Down syndrome, Klippel-Feil syndrome. So the approach to this patient should be a team approach for normal speech, normal hearing, and normal maxillofacial growth. Not only the operation, it also consists of speech therapy, dental treatment, nutritional care, and also child-like care. Now the indication and timing of closure of the cleft lip palate. An early two-stage repair of the palate involves closure of the soft palate at 3 to 6 months of age and closure of the residual hard palate at 15 to 18 months of age. But most surgeons repair cleft lip at 6 to 10 weeks of the age and palate 6 to 12 months of the age. Here, rule of 10 can be used with moderate license for lip repair. Where weight appropriate for the age, like 10 pounds, hemoglobin 10 gram per deciliter or more, WBC count less than 10,000, weight 10 weeks, and patient should be healthy, free from any respiratory tract infection. What are the information to be obtained during preoperative visit? History of birth apnea, respiratory distress syndrome, history of prematurity. All this leads to increased risk of postoperative apnea and perioperative bradycardia. And also, if the total duration less than 60 weeks of the post-conceptional age, this patient also can develop postoperative apnea. And most important clinical examination during preoperative visits is airway examination and cardiorespiratory status. But we should not also forget to take developmental milestone and immunization status of this patient. Now the laboratory investigation. Basic laboratory investigation is blood for complete hemoglobin. And if there is murmur then or any other associated anomaly, then we go for the echocardiography. Particularly in isolated cleft palate patient, we should detect for any murmur or any other associated anomaly. And if any other problem, then other investigations should be done. Now the preoperative preparation. Prolonged fasting does not help to reduce the risk of aspiration. Now the fasting guidelines are formula feed or the cow's milk and solid food 6 to 8 hours, breast milk 4 hours, clear fluid 2 hours. To reduce the emotional trauma, pre-medication with oral midazolam 0.25 to 0.5 milligram per kg can be given. If there is any doubt regarding difficulty in intubation or propensity towards airway obstruction, then pre-medication should be better avoided. Now the intraoperative monitoring, heart rate, blood pressure, respiration, temperature, and oxygen saturation. These are to be monitored. Apart from this, we use precordial stethoscope, ECG leads, and end-tidal carbon dioxide monitor. Hypothermia to be avoided at any cost, and blood loss to be calculated and should be replaced. What are the techniques for anticipated difficult intubation? Not only the difficult intubation, we follow inhalational anesthesia for most of the patient with keeping the patient in spontaneous respiration. We can use fiber optic bronchoscopy after inhalational anesthesia in anticipated difficult airway. Now the anesthesia management. Induction by the oxygen and sevoflurane followed by IV cannulation done and IV fluid started. Atropine and fentanyl IV given. Here no muscle relaxant are used. Propofol used to deepen the plane of anesthesia, followed by intubation with appropriate size of RAE tube, fixation of the tube in the midline without facial distortion. Symmetry is essential. Sometimes surgeons prefer not to cover the eye due to change in the facial symmetry. And moisten throat pack to be given in clefly prepared. In cleft pellets, usually surgeon will give the pack after insertion of the mouth gap. Now I am showing how the tube can be fixed in the midline. It is the left side view and it is the right side view. What are the problem we face during intubation? In cleft lip patient, we sometimes use tooth cut made of several layers of sticking plaster or soft plastic protects the gum. And cleft palate, a gauze pack can be given in the cleft. In cleft palate patient, head is extended, maximal extension of the head required. Here shoulder is raised with a thick foam mat, allowing head to drop back hyperextended into a stockinette head support. Here advantage of good exposure allows blood to flow away towards nasopharynx, so it can be removed by suction. But disadvantage, inadvertent extubation can happen. So what are the care to be taken during placement of the mouth gag? Breath sound to be monitored on both sides. SpO2 should be monitored closely, and both sides to be auscultated after final position. And anesthesia then maintained with oxygen and sevoflurane. Here we can see that the tube is severely compressed by the mouth gag. So here we should be adjusted and alert the surgeon. What are the intraoperative problem after mouth gag placement? So ET tube may be crossed again the mandible. So reassess for the ventilation. Actually here surgeon's tool and hands, anesthesiology, ET tube, all the things occupy the same very small space. So good communication and cooperation between the surgeon and anesthesiologist is very much necessary. Here the large tongue causing problem of the tube going to the one side. Tube and the tongue here ideally placed. Here tube is central, but tongue is displaced. Here tongue is under severe pressure because tongue is bluish. Here tube is eccentric, but tongue depressor is causing pressure on the tube. Here tube lateral, but tongue is protruding. Tube not central, but tongue centric. Here tube is also under pressure. Here totally out of plane. Tube and tongue here not ideally placed because tube is pressed by the mouth gag. Here tube is excessively protruding through the tongue bed. Here tube is under mild pressure. Here tube is under severe pressure. We should avoid it. So what are the precautions to be taken? Never forget to remove the throat pack before extubation. An ocular lubricant placed in the eye and upper eyelid are splinted with the tape. Auscultate after insertion of the tube and again after placement of the throat pack and after final position. What are the precautions to be followed in post-operative period? After operation, edema of the palate and congested uvula. So nasal airway sometimes can be established as the mouth breathing is not possible. Remember, nasal or oral airway may cause suture disruption. In the post-operative period, there may be respiratory distress because child does not learn the art of oral breathing in response to surgical closure of the cleft. If the tongue fall back, tongue suture can be given. Logan's bow are used to take the tension of the newly sutured lip. Post-operative period, the position should be prone or lateral, head dependent, turn to the side, and hyperextended. Post-operative analgesia and sedation to be used because if the child cries, excessive wheezing from the cooperative side, and if sedation is excessive, there is chance of aspiration. Post-operative analgesia, opioid like fentanyl 1 microgram per kg or paracetamol suppository or diclofenac suppository can be given. So what are the problems faced in the anesthesia in cleft lip palate surgery? During induction, respiratory obstruction due to falling back of the tongue, difficult intubation, sharing of the airway with the surgeon, increased bleeding and sometimes aspiration, and also laryngospasm and hypoxia may happen. And recovery, what are the problems in the recovery room? Airway obstruction, most important and grave complication, because combination of the closed palate, small mandible, large tongue, edema, blood and residual effect of anesthesia may cause airway obstruction. In post-operative, blood loss can happen. Hypothermia, may delay the emergence and produces metabolic acidosis and respiratory and myocardial disease. Now I must tell about laryngospasm and its management. It is defined as the glottic closure resulting from reflex constriction of the laryngeal muscle. Laryngospasm under anesthesia occur for two reasons. Firstly, due to lack of inhibition of the glottic reflex because of sinus depression, and secondly, increased number of stimuli during the operation. It can be partial or complete. Partial treatment is applying positive pressure to the airway, deepening anesthesia, administering muscle relaxant or bolus to the propofol. And for complete laryngospasm, application of the positive pressure ventilation may not be helpful. Here succinyl choline to be given because it is better to relax the cords before the hypoxia, and then intubation also to be done. So, thank you very much for kind attention.
Thank you, Dr. Chandan. So we can have the discussion at the end of this session. So the next speaker is Dr. Ashok Bansal. Dr. Bansal is Divisional Medical Officer in Central Hospital, Northern Railway, New Delhi.
Hello friends, I am Dr. Ashok Bansal and here to present emergency anesthesia in resources limited. The resource limited area is popular as non-operating room anesthesia, office-based anesthesia, or anesthesia in remote areas. Emergent and urgent medical conditions contribute to 90% of death and 84% of disability adjusted life years worldwide. And 90% of the population in low income and middle income countries lack access to emergency or essential surgical care. So in such conditions, anesthetic role is more important to survive the patient, and so anesthesia gap result in absent or delayed care and high mortality for many easily treatable conditions such as obstructed labor, appendicitis, fractures, and cancers. Now, in resource limited area, there are the following challenges which we need to know before the start of this anesthesia in remote areas, like unreliable access to power, water, drugs, and equipment, as well as limited options for post-operative care and pain management. In such conditions, anesthetics needs to be flexible, resilient, and have ability to adapt to changing circumstances. WHO and World Federation of Society of Anesthesiologists has given a standard for the safe practice of anesthesia in level 1 facility and level 2 facilities. Level 1 facilities are small hospital having small surgical procedure and emergency treatment of 90 to 95% of trauma and obstetric cases. Equipment include adequate tilting operating table, oropharyngeal airway, face mask, laryngoscope, endotracheal tube, suction devices, self-inflating bags, equipment for IV infusion, equipment for spinal anesthesia, access to defibrillator, stethoscope, pulse oximeter, carbon dioxide detector. Essential medication include ketamine, diazepam, morphine, local anesthetic, dextrose, oxygen, epinephrine. While in level 2 facilities, 100 to 300 beds, treatment capabilities include bellwether procedures and short-term treatment of 95 to 99% major life-threatening cases. Equipment include delivering inhalation anesthesia, automated ventilator, IV bracer, device for warming IV fluid, continuous waveform capnography, temperature monitoring, etc. While medication include thiopentine, appropriate inhalation agent, succinylcholine, non-depolarizing muscle relaxant, amiodarone, ephedrine, etc. patient consideration. In the patient in such conditions have presented with lack of any past medical history. This is because of low socioeconomic status, patient less commonly uh, seek for medical treatment facilities. So they, whenever they present, they are presented in very serious condition and also difficult to treat their condition. In other than this, there is also problem of language barrier is there. So ability to perform a preoperative assessment will be lack, and we require a voluntary peoples for communication with them, even for safety considerations such as verifying fasting status or drug allergies. Infrastructure and equipment and supply constraint, safe anesthesia for emergency and critically ill patients in low or middle income countries is made even more challenging by limited access to essential medication, support services, laboratory, blood bank, technologies such as advanced airway device and invasive monitoring. Disaster relief effort in resource limited. Disasters like landslide, earthquake, flood. In such condition, non-purpose built buildings such as schools, churches are often used as makeshift clinic and even operating theater. These posing a challenge for maintaining stability and infection control. Absence of trained professional and healthcare providers because of disaster, and there is a broken transport system which enable to transport the patient to other tertiary care center. Role of anesthesia provider outside the operating room. Here, anesthetic work as a triage or in pre-hospital care or to manage critically ill patients. Emergency care can involve airway management, intravenous line placement, bleeding control, cardiopulmonary resuscitation, and safe transportation. Anesthesia provider arguably play the most critical role in managing perioperative care. Anesthesia provider need to recognize and to treat perioperative complications. They are called to help manage critically ill medical patients and complications like ARS, decreased sepsis, etc. The anesthetic technique and perioperative care include monitoring only, sedation, regional anesthesia, topical, intravenous anesthesia, and intraoperative anesthesia. Intraoperative consideration include monitoring devices like oxygenation, ventilation, circulation, urine output, temperature, neuromuscular function, and depth of anesthesia. Equipment includes oxygen supply, oropharyngeal airway, face mask, appropriately sized laryngoscope, endotracheal tube, intubation aids such as pulsar ventilators, and suction equipment. Now, anesthetic safety procedure. Before induction of anesthesia, is an experienced and trained assistant available to help in early induction? Has the patient had no food poisoning for the appropriate time period? Is there intravenous access that is functional? Is the patient on table then can be rapidly put into head down position in case of sudden hypotension or vomiting? Equipment check, which include if compressed gas will be used, is there enough gas in the oxygen cylinder? Anesthetic vaporizer are connected, breathing system validate, securely and correctly assembled, breathing apparatus are clean, etc. Equipment checklist for anesthesia. Remember as a acronym SOAP may include suction, oxygen, airway, pharmacy, monitors, and equipment. Pharmacy include basic drugs needed for life supporting purpose. Monitors include pulse oximeter, NIBP, non-invasive blood pressure, and tidal CO2 temperature and ECG. Equipment includes defibrillator with pedal, gas scavenging system, adequate lighting, etc. Now, anesthetic plan. Anesthetic plan depend on patient preferences, physical procedure, and available resources. It may be spinal, regional, and intravenous anesthesia, mainly ketamine with or without benzodiazepine. An analysis of medicine sans frontier anesthesia suggest reveal significantly lower odds of perioperative death than spinal, regional, or general anesthesia without treatment. intubation was used than when general anesthesia with intubation was used. Our aim to bring the anesthesiologist to the heart of patient critical welfare, minimize physical discomfort, control anxiety, control movement to allow safe completion of the procedure, return the patient to a state in which safe discharge from medical surgical is possible. ASC guideline for NORA patient: reliable oxygen source including a backup support, adequate and reliable suction, adequate and reliable scavenging system, self-inflating resuscitation bag, adequate drugs, supplies and equipment for the planned activity, adequate monitoring equipment, sufficient electrical outlets, sufficient space for equipment, immediate suitability of emergency card with defibrillator, reliable two-way communication, observation of all applicable health and safety code and facility status. These are the necessary drugs which can be used with advantage and disadvantage. Ketamine, induction IV ketamine, IMT, infusion anesthesia, regional anesthesia includes spinal, intrathecal norepinephrine, intrathecal bupivacaine, and inhalation anesthesia with volatile air anesthetic. Post-operative consideration: monitoring with sedation and acute respiratory failure avoided. In pain management with local anesthetic via peripheral nerve block, opioid medication and multimodal anesthesia such as acetaminophen and ketamine. Summary: anesthesiologist needs to be flexible and step into setting with unreliable power supply, airway and equipment, medication and even staff. The guiding principle for providing safe and responsible anesthesia in resource-limiting area remain the same. First, do not harm. Second, international standards should be adhered to as closely as possible. Bare minimum standard include the use of informed consent, surgical safety checklists, and adequate post-operative monitoring and pain management. In absence of standard monitor, volunteers should practice extreme vigilance by using auscultation, pulse oximetry, and clinical sign to keep patients safe. The choice likely depend on provider and experience ability of consistent equipment and circumstances in which anesthesia is delivered. Thank you all. This is my end of the presentation.
Thank you, Dr. Bansal. Our next presentation is of Dr. Somnath Saha. Dr. Somnath Saha. I'm sorry, sir. The next presentation is of Dr. Chandrakant Patel. Dr. Patel is Additional Chief Medical Director and he is affiliated with Western Railway Attached Hospital, Jagjeevanram Hospital, Mumbai Central.
Good morning. Myself, Dr. Chandrakant Patel, Additional Chief Medical Director, Western Railway Churchgate, Mumbai. I'm thankful to organizing committee Isacon 2021 for giving me this opportunity. My topic of presentation is Railway Anesthesiologists Rising to Challenges Together. Is an effort to highlight the work done by the railway anesthesiologist along with the other medical fraternity of the hospitals at the difficult time of the COVID-19 pandemic. This is the hospital, Jagjeevanram Hospital, where I have worked and attached presently. This is my administrative headquarters, where I am looking after the administration of the medical services in Western Railway. My talk will cover under these headings. The healthcare setup in India, and it's in relation to the medical, the railway, the anesthesiologist available in the country is given here. There are around 12.6 lakhs registered allopathy doctors in the country and 5.65 lakhs Ayush doctors in the country. As per the data available in the ISA website, there are 20,000 active members of the ISA, and there are around 150 members of the Railway Association of ISA, and out of that 100 are in service. These against the Indian Railway Health Services cadre of 2005. The desired number of anesthetists per lakh population is 5, while as per the data available of active members in the ISA website, around it comes around 1.5 anesthetists per 1 lakh population. And in the railways, we have around 75 lakhs railway beneficiaries, and have 100 to 150 the anesthesiologists, which comes again around 1.5 to 2, again the desired number of the 5 anesthesiologists per 1 lakh population. Both have the presence. ISA as well as the Railway Association of ISA has its presence all over India. The members of the ISA provide their services in the central, state, corporate sectors and private practice and in the nursing homes, while the railway anesthesiologists provide their services primarily in the zonal and railway regional hospitals, where basic specialty and super specialty facilities are available. The distribution of anesthesiologists in metro, urban and rural areas are dependent on the infrastructure, facilities, support system available in these areas. While in same is the situation in railway setup. The zonal hospital, where the workload is more and facilities are available, workload facility, infrastructure facilities are available in sufficient quantity number. The number of anesthesiologists are more in the zonal hospitals in comparison to the regional hospitals, where the anesthesiologists are not available at all in some few places. These are the various services provided by our anesthesia fraternity. Same is true for the railway anesthesiologist. Apart from their routine administrative services, and these are the services they provide for the benefit of the patients. Railway beneficiaries are the railway anesthesiologists are responsible for providing anesthesia, critical care services, and medicine services primarily to the railway beneficiaries. But with the introduction of the Ayushman Bharat healthcare scheme, the railway hospitals, around 90 railway hospitals are also providing healthcare facilities to the eligible citizens of India. Otherwise, also the citizens can avail healthcare facilities in railway hospitals on CGHS rates. During the COVID-19 pandemic time, the Indian Railways never stopped its services to the the countries. And if you look at the medical part, the Indian Railway has left no stone unturned in the fight against COVID-19. They moved oxygen expresses with loaded oxygen to different parts of India. And at the same time, Railway has geared up its in-house medical facilities for providing the quality healthcare services to the COVID-19 patient. Constant efforts made to add critical care, critical medical equipment like BiPAP machines, oxygen concentrator, oxygen cylinders, and ventilators, etc. in the railway hospitals. The railway hospital received very positive and encouraging feedback from beneficiaries during COVID-19 surge because of quality healthcare provided by the railway doctors, healthcare professionals in the railway and COVID care facilities. Railway said to have 86 oxygen plants for its hospitals to meet any situation in the future. Oxygen generation plant at the photograph showing one recently the commissioned oxygen generation plant at Jagjivan Hospital. This is the situation almost all the major railway hospitals in the country. During the COVID-19 pandemic, around 86 railway hospitals opened up for the COVID care opened up as a COVID care facility in which around 6,800 beds were made available and around 600 ICU beds made available, and enough sufficient number of doctors and nurses from existing cadre as well as the on hiring basis engaged in the services. The railway anesthesiologist also played a very vital role in almost every single activity of the hospital to ensure optimal health care to COVID-19 patients during the COVID-19 pandemic. They involved in the administration and they involved in the planning, procurement, and execution of the policies, execution of the planning made by the hospital administrator. They looked after the arrangement of the oxygen cylinders, oxygen concentrator, and the proper functioning of the ventilators. They worked in the trials, did COVID ward duties. They took care of COVID-19 patients in ICU operating rooms. They provided respiratory support to the COVID-19 patients, both invasive and non-invasive. Even the senior anesthesiologist took the lead and wore PPE kit to enter the COVID-19 wards and ICUs when there was panic amongst the doctors and healthcare workers. The important training to the doctors and healthcare workers in the donning and docking of PPE kits, basically the respiratory management of the patients on ventilators, invasive and non-invasive both. We did some few shots of the training sessions for the staff doctors, some live demonstration of the hand wash and the donning doffing process. During the COVID-19 pandemic peak, the non-COVID services suffered significantly, but in the railways, the separate non-COVID clinics were run in the separate area which were away from the COVID care facilities. The effort done by the railway hospitals during the COVID pandemic time was appropriately highlighted in the print media and electronic media. And this is one of the paper clip of the work done by the Western Railway, Western Railway Hospital. And this is the same everywhere all over India, wherever the COVID care facilities were operated by the railway hospitals. The COVID warrior dashboard of Government of India also got the place of railway hospitals during the COVID-19 time. Now, this is a small video clip of the activities done by our doctors and support staff during the COVID-19 pandemic time. It reflects how the all medical fraternity and the support staff had risen to the challenges, rise to the challenges, and did the COVID-19 fight head on. So let us see. And this is only a prototype, and I know that the most of our railway hospital did the similar effort in their COVID care facility during the COVID-19 pandemic time. The song which is incorporated in this video clip is very apt and reflects the challenges taken up by the medical fraternity. So this was a small video clip. I have shown the part of that clip highlighting the efforts done by our medical fraternity as well as the paramedic staff. In the railways, the workshop did a great job, and they start preparing the PPE suits for the healthcare doctors and healthcare workers engaged in the COVID-19 and that care of the patient during the COVID-19 patients. So let's move ahead. If we see the academic part of in the railways, the railway hospitals are well equipped and manned with the specialist and super specialist, and they are the center for postgraduate as well as super specialty studies. DNB seats are available in railway hospitals, and some of the around 50% seats, DNB seats are available for the service railway doctors to pursue higher studies. Railway anesthesiologists are also involved in the teaching training of postgraduate trainee doctors in addition to their day-to-day clinical administrative work. Apart from regular teaching and training work, if I talk about the Railway Association of the ISA, we regularly conduct the annual conferences, and that trend has started in 1995. And this year we organized 27th annual conference of the Railway Association of the ISA on 23rd and 24th October 2021 in Mumbai. This conference was organized by Department of Anesthesiology and Pain Medicine, Jagdivanam Hospital. And more than 50% of the railway anesthesiologists connected to this online academic program to upgrade their knowledge. In this conference, learned faculty from national and international repute shared their knowledge and enlightened the attending railway anesthesiologists as well as the doctors of the hospital. During this, the inaugural function of this conference, our respected President, Dr. Muralidhar Joshi, National President, and Dr. Naveen Malhotra, ISA National Secretary, ISA National, addressed the railway anesthesiologist, and they appreciated the efforts taken by the Railway Association of ISA in the field of academic and organizational activities of the ISA. These are a few the screenshots of the address by our National President, National Secretary, and President of Railway Association of ISA. And this inauguration ceremony was organized in offline, and it was aired in YouTube live. Our chief guest was General Manager, Western Railway, Shri Alok Kansal, who was the chief guest. And Dr. C.S. Anand, PCM, Principal Chief Medical Director, Western Railway, was our guest of honor. Both highlighted the role of anesthesiologists in the day-to-day work as well as during the COVID-19 pandemic. Annual news bulletin was released on this occasion, which was released by our dignitaries, chief guest, and the guest of honor. Railway anesthesiologists are involved in the academic activity, as we have seen. They are writing papers, and they are publishing papers, writing articles, publishing papers in the index journals, like this one, which we wrote and was published in IJMA 2020 editions. So the other publications are also the other work. The research work is also done by the DNB students and our faculties. If you see the anesthesiologist in the headings of journals and print electronic media during the COVID-19 pandemic time, we find that the anesthesiologist role has been highlighted in a different manner, and the COVID-19 pandemic has brought the anesthesiology professions in the forefront of all the medical practices at that time. So these are some of the headings, like rise of anesthesiologists under shadow of the COVID-19. Some electronic online journals, offline journals have also published, highlighted the anesthesiologist work during the COVID-19 pandemic. The first time in the history of Time magazine, the anesthesiologist got opportunity to featured in the front page of the Time magazine, where one of the anesthesiologists from Italy has shared her experience during the COVID-19 pandemic. Print media, electronic media also, like newsprint media, also highlighted the role of the anesthesiologist during the COVID-19 pandemic, like this one in the Times of India, that anesthesiologists at forefront in the COVID-19 battle play key role in the ICUs. Then rising from anesthesia training to expert medical ninjas who can handle anything inside the in the critical situation. At the end, I would like to convey that relevant anesthesiologists rising to challenges together. This topic was chosen by me to dedicate the work done by the anesthesiologists to all anesthesiologists of the world, country, and Indian Railways. We know that the training of the anesthesiologist starts in ORs, where they learn airway management as one of their professional skills. This is in contrast to counterparts where intubation and airway management falls late in their list of professional skills. The anesthesiologists have risen to challenges during COVID-19 pandemic, and their work has been recognized as frontline workers in the country and the world. Railway anesthesiologists also have displayed their professional skills to efficiently handle the crisis during the COVID-19 pandemic, and they have been equally appreciated by the administration and the beneficiaries. So that was all. Thank you all. Jai Hind, Jai ISA, long live ISA, long live Raisa.
Thank you, sir. Thank you for the presentation. Now, the next presentation is of Dr. Somnath Saha. Dr. Saha is a Senior Division Medical Officer, Central Hospital, Malegaon, Northeast Frontier Railway, Guwahati, Assam.
Good afternoon, everybody. I am Dr. Somnath Saha, Chief Anesthesiologist from the Central Hospital, Northeast Frontier Railway, Guwahati, Assam. Today I shall be discussing a unique topic, which is role of meditation for an anesthesiologist. Anesthesiology is one of the most stressful medical disciplines. We are daily exposing to high responsibilities and stressful situations and managing life-threatening scenarios like unanticipated difficult airways, cardiac arrest, anaphylactic shock, etc., etc. The work pattern is also more stressful than others because of increased overnight shifts, working on weekends, and even missing on the festivities. Anesthesiologists have to cope with an imbalance of personal and professional time. They are actually multitaskers. While putting the patients under general anesthesia and keeping an eye on the monitor and another eye on the anesthesia workstation. While the case is going on, you are also watching the surgical side, assessing the time required, looking at the blood loss and urine output, etc. You are hard pushed in keeping a delicate balance between your tough workplace pressures and timings with spending some quality time at home with family and friends. But in the rush to accomplish all these necessary tasks, you may find yourself losing your connection with the present moment, missing out on what you are actually doing and what you are actually feeling. Anesthesiologists are critical care physicians, and that's why they have high risk of burnout. Numerous studies have proven this. More than 50% chances of burnout. It has been already documented. They routinely lead teams that care for patients across a wide variety of medical settings. This responsibility, though rewarding and impactful, but it also makes them more vulnerable to stress related to the job's intensity. And that got recently amplified during this COVID pandemic, with anesthesiologists often performing on the front line. So what are the stressors? Stresses for an anesthesiologist is a responsibility for the patient's life, long hours of on-call duties, perception of a low level of support in work life or at home, experiencing staff shortage, trying to manage 2 or more operation rooms at a time, the production or the management administrators' pressures, and then this electronic medical record keeping. That's another thing which has been added to the responsibilities of an anesthesiologist. Now, studies are showing that burnout syndrome is very common for anesthetists. It is a multidimensional occupational syndrome characterized by 3 dimensions of emotional exhaustion, feeling weak, tired, worn out, depersonalization, which is an increased feeling of distance towards the job and or towards the patients. And then the reduced personal accomplishment, this feeling, a sense of frustration and ineffectiveness as a clinician. Burnout negatively affects the healthcare system at different levels. And more importantly, it is associated with poor patient satisfaction and quality of care. It negatively influences individual work performances. It creates the high risk of errors, and it may lead to catastrophic outcomes, leading to many instances of malpractice claims. Now, what can be done to reduce this burnout? It can be done in 2 levels. One is at the organizational level and another at the individual level. At the organizational level, we can do many activities which can bring in suitable changes in the time schedules of the anesthetist. To modify organizational structure and workflow process, to reduce workload intensity by making working hours flexible, to increase a level of participation in the decision making, to improve teamwork and introduce mentorship. Seniors should take care of the juniors, to improve leadership skills, self-care and alignment in the working environment, to bring changes in approach to work evaluation, and to increase supervision and improve the support system. But at individual levels, we have to resort to healthy coping mechanisms. Basic idea is to make ourselves capable of coping these pressures. There are many methods. Few of them are like spending quality time with family and friends, pursuing a hobby which is not related to medicine, improved and longer sleep time with adequate rest, getting a massage, visiting a spa, eating right to get optimum nutrition, adequate exercise and physical activity, avoiding alcohol and smoking. But the most important aspect of individual level care is to resort to stress reduction training programs and to learn mindfulness meditation. Now, what is mindfulness meditation? It is a practice of purposefully focusing yourself, focusing your attention to the present moment and accepting each and every aspect of that present moment without any judgment. It is one of the best methods and is as good as any relaxation techniques or yoga therapy. It is a kind of self-awareness exercise giving meaningful clinical experience. Mindfulness meditation improves the well-being of a person. It makes it easier to experience the pleasures in life as they occur. It helps to become fully engaged in activities by improving communication, creates a greater capacity to deal with adverse events, reduces the likelihood of getting caught up in worries about the future or regret about the past. It helps in better ability to form a deep and stable interpersonal relationship. At a physical health level, by relieving stress, it improves heart disease, it lowers blood pressure, it improves the quality of sleep, and can alleviate stress-induced gastrointestinal disorders or chronic pain. At the mental level, it helps in the treatment of depression, anxiety disorders, substance abuse, obsessive-compulsive disorder, eating disorders, and similar such situations. It helps resolving in interpersonal conflicts. It helps in accepting the situations rather than reacting to them with aversion or even avoidance. And it improves emotional stability by self-observation and cognitive flexibility. It improves focus by reducing unnecessary distractions. Mindfulness meditation are of different varieties in different types. There are body scan meditations like yoga, yoga nidra, vipassana. There are movement meditations like hatha yoga, tai chi, qigong. There are breathing space meditations like different kinds of pranayama. Expanding awareness meditations like transcendental meditation. There are different varieties of these meditations, but the one type of meditation that I practice and that directly connects the mind, body, and soul to each other and to the supreme source of power and energy with a spiritual background is Raj Yoga meditation, as taught by the Brahma Kumaris Spiritual University. Raj Yoga meditation, as the word, the yoga, the word itself means connection. In Raj Yoga meditation, you, the soul, shall experience a direct connection or mental, emotional, and spiritual link with the Supreme Soul. The process of establishing this link begins in two steps. One, with a journey to one's own inner world to discover one's true spiritual identity, experiencing the deep connection with our own nature, that is peace, purity, and love. This is our natural way of living. Peace, purity, and love. This is me, this is us. This is the quality of the soul. And at the same time, knowing the Supreme Soul, the source of all energy. It is the ocean of peace, purity, joy, love, bliss, knowledge, and power. This is the connection. Raj Yoga means a connection between myself and the supreme source of energy. Raj Yoga is very easy to learn and practice and does neither require any money, specific space, any specific time, any complex posture, nor does it require any previous experience, shaving of heads or chanting of any mantras. It is by far the deepest and the most direct route of relaxation. It is the relaxation of the soul. We become aware of the energy that we, as a soul, radiate in the form of invisible spiritual light. The quality of that light is entirely dependent on the quality of our thoughts and the feelings. Raj Yoga meditation gives us 8 kinds of powers. It is the power to accommodate. Number 1 is the power to accommodate. Accommodate means this is our ability to accept the presence, ideas, nature, and desires of others. As water accommodates according to the shape of the container, and river accommodates as per the shape of the path it teaches us to fit in all situations and yet remain pure, remain original. Then comes the power to tolerate. This is our ability to manage difficult situations positively, yet not be affected by them. The power of tolerating the internal and external challenges that we face. This is one of the most and special and useful powers of the soul. The third is the power to face. This is our ability to confront and resolve external and internal obstacles, tests, and challenges. Power to face challenges and power to face people's negative behavior. Then comes the power to pack up. This is our ability to bring things to an end, to a full stop. Full stop to all wasteful thinking. It is the power to stop negative thoughts, negative words, actions immediately, instantly. Then comes the power to discriminate. It is this ability to separate what is true from what is false, what is right from what is wrong, to differentiate between things. This is the power to discriminate. And then comes the power to judge. This is the ability to assess our own choices, to assess the decisions and actions in not only ourselves, but in others also. Judge means to decide what is right and what is wrong. So this is where we get the power, not only to discriminate from truth and false, but also to judge what is right and what is wrong. Then comes the power to cooperate. This is our ability to give attention, time, experience, and our wisdom in the service of others and to work alongside them. It is helping others to go ahead and overcome their own weakness or the life challenges. When we are in a group working for a common purpose, we all need both this power to accommodate and the power to cooperate. These are very, very important powers for an anesthesiologist to amalgamate as a team leader or as a team member in each and every scenario. We need to have all these powers. Then comes the power to withdraw. This is our ability to step back and disengage from the whole world means be as a observant only from the world around us for a moment or so. Just for a moment or so, be observant, be detached. This is how we get this power to withdraw. Detachment means the awareness that I am separate from my body, my role, and from my responsibility. I, the soul, am separate and a completely different entity from what this is, what is seen. This is the body, this has its roles, this has its responsibility, but I, the soul, am separate from it. Just for a second, detach from these roles, these temporary ideas, and just see how easy it is to manage a scenario. Now, what we have understood, the stress, all these days, stress is equal to pressures. But science, our textbooks, give this definition that stress is not equal to pressure. Stress is equal to pressures divided by resilience. So that means the amount of stress is equal to not only the pressure, but how much is the capacity of that thing to tolerate that pressure. That means the capacity is the resilience. Same way, the stress is directly proportional to the pressure divided by resilience. That means the more we increase our capacity to cope up, the more we increase our resilience, we are able to reduce the amount of stress which we feel. So stress is not directly equal to the pressures, or not equal to the pressures created by the situations, the persons, the individuals. It is not life which creates pressures. It is the amount, the capacity, the knowledge, the basis of which we see these pressures, our perspective. Based on that, it is what we feel the amount of stress. So let us increase our resilience. Let us increase our capacity, our coping up. We can increase all these powers through meditation. So to conclude, despite the recent surge in research directed towards improving wellness, physicians still have much to learn. Understanding what makes one individual more susceptible to burnout versus another will help focus attention on these highest risks. Finding ways to address systemic drivers of burnout, which are unfortunately also the most difficult to change, will likely have the most significant impact on the current burnout epidemic in the global anesthesiology community. And finally, Raj Yoga meditation techniques is one of the most easy and effective way to face and tackle the burnout syndrome associated with the stress-affected anesthesiologists. Thank you. Have a very nice and peaceful day ahead. Om Shanti.
अच्छा नहर वाले तरफ नारायण में पानी छोड़ते हैं दूसरी तरफ नहर वाले तरफ
Please. Please start the next speaker.
So we are waiting for our next speaker. In the meanwhile, if you want to have, we have 5 minutes time for the discussion. After that, we'll be doing the recording of Dr. Selvam.
Okay. If you want, you can start the next topic by Dr. Selvam. Can you play the next video, next speaker video? Hello, Chaluji, can you play the next speaker video so as not to waste the time? Hello. 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 There is some problem there in this thing. Hello.
So we are starting the presentation of Dr. Selvam. Just give us 2 minutes.
Okay. What about Dr. Yatishas, madam?
No, sir, we are trying to get in touch with him, but like he's not responding. So we are going to play the presentation of Dr. Selvam.
Okay. Please go ahead. That's not, Okay, please go ahead. Yatish told that he has already shared, but I don't know. Has he joined? Yatish has joined, huh? Yatish has joined or not? But it is not coming. Not coming. I'm already in it, no?
Sir, the next presenter is Dr. Kamachi Selvam. He is Additional Chief Health Director, Consultant Anesthesiologist, and Cardiac, Vascular, and Multi-Specialist Anesthesia. And presently, he is at Southern Railway Headquarters Hospital, Perambur, Chennai.
Very good morning, respected chairpersons, dear colleagues, and postgraduate students of anesthesia. I express my sincere gratitude to the organizers of Isacon 21 for giving me this opportunity here today. Straight on to a topic, ketamine is an inexpensive anesthetic agent and has a very wide range of clinical applications. It has a wide spectrum of pharmacological effects. Ketamine is gaining popularity with its newly found effects, and the usefulness of low-dose ketamine regimens have widened the clinical scope of application of ketamine. Let me walk you through the expanding scope of clinical applications of ketamine amidst various myths, mysteries, and controversies surrounding this wonder drug. In the central nervous system, the ketamine produces an inhibitory effect, inducing a state known as dissociative anesthesia, which is characterized by loss of consciousness with profound analgesia, but with the appearance of being awake with eye movements, vocalization, and preserved reflexes. This is caused by a dissociation between thalamo-neocortical and limbic systems, which prevents sensory inputs from the cortical receiving areas to be observed in some of the sensory association areas. Ketamine administration causes a dissociative amnestic state in which patients are unconscious with eyes open, maintain spontaneous respiration, and do not react to painful or noxious stimuli, along with marked nystagmus and significant analgesia. Ketamine preferentially binds to the NMDA receptors on inhibitory interneurons in the cortex, amygdala, and hippocampus, and therefore the dissociative unconsciousness produced by ketamine actually results from an uncoordinated increase in neural activity. Another mechanism by which ketamine decreases arousal is by blocking NMDA glutamate-mediated nociceptive signals from the peripheral afferent neurons in the spinal dorsal horn. The NMDA receptors are present on nearly all CNS cells, and especially those cells involved in nociception, such as primary afferent nociceptors in the spinal dorsal horn. All NMDA receptors display a certain degree of voltage-dependent magnesium block and mark permeability to calcium after removal of the magnesium block. Ketamine binds to an intrachannel site of NMDA receptor called the phencyclidine binding site, and decreases the channel opening time. Ketamine actually decreases the amplification of repeated stimulation of the NMDA receptor, which causes normally the wind-up phenomena that is considered as an elementary form of CNS sensitization. Spinal NMDA receptors have an important role in central sensitization in the spinal cord in persistent pain states as well. The functional MRI has provided deeper insights into the analgesic pharmacodynamics of ketamine. Volunteers who were subjected to painful heat stimulation showed a typical pattern of pain activation from the thalamus to the insula to the cingulate and ultimately to the prefrontal cortex. There was a dose-dependent reduction in these cerebral activation pathways when volunteers were given ketamine. Ketamine has also been found to block the signals from spinoreticular pathway. Ketamine also interacts with opioid, noradrenergic, cholinergic, nicotinic, muscarinic receptors as well. It also has got local anesthetic effects. Ketamine increases cerebral metabolism and cerebral blood flow. In spite of that, a recent research has directly studied the effects of ketamine on intracranial pressure in patients with traumatic brain injuries and showed that ketamine is one of the best agents to facilitate airway management in patients with a head injury. A large systematic Cochrane review has recently provided grade C evidence that ketamine does not increase ICP in sedated and ventilated patients with severe TBI. Ketamine retains the patient's respiratory drive, does not decrease blood pressure, yields no increase in ICP, and allows added advantage of hemodynamic stability, anti-inflammatory mechanisms, and NMDA receptor-mediated neuroprotection. Therefore, consensus is published recently that ketamine can safely, though cautiously, be used in patients with traumatic brain injuries. Interestingly, the NMDA receptors have been found to play a key role in nociception. Low-dose ketamine has an opiate-sparing effect in the management of acute pain. Administration of both ketamine bolus prior to surgical incision as a preemptive measure and a ketamine infusion post-operatively has been found to be the most effective use of ketamine for acute pain. The analgesic effects of ketamine are achieved at sub-anesthetic doses and sub-anesthetic blood concentrations. The effects of ketamine related to pain can be best described as anti-hyperalgesic, anti-allodinic, or tolerance protective through prevention of hyperalgesia and decreasing the central nervous system sensitization to acute pain. But the exact mechanisms of analgesia provided by ketamine are very complex. Considering the role of NMDA receptors in preventing hyperalgesia, ketamine has also been investigated for management of chronic pain. But a word of caution is further studies are required to determine the most effective regimen for ketamine administration in patients with chronic pain because unfortunately the effects last for a limited duration only after ketamine administration. NMDA receptors are also expressed on the peripheral tissues like keratinocytes through and they play a role in nociception through action of L-glutamate on the nerve endings. So use of ketamine gargle before surgery has been shown to reduce post-operative sore throat, and it is suggested that ketamine gargles act via local peripheral action. Ketamine has been reported as a unique homeostatic regulator of the acute inflammatory reactions and the stress-induced immune disturbances. So it has got an anti-stress and immune modulatory anti-inflammatory effect as well, which is being exploited and investigated for the treatment of low-dose ketamine being used for the prevention of delirium following surgeries or even post-operative delirium. Recently, ketamine has gained interest. The slides have slipped. Okay, I'll go back to the slide. Yeah, recently, ketamine has gained interest in the treatment of major depression, bipolar disorders, and suicidal behaviors. Ketamine decreases depression symptoms and suicidal ideation within 1 hour of administration, which is very rapid. On March 2019, S-ketamine nasal spray was approved by US FDA for the treatment of major depression. However, the clinical effects are of short duration only, and therefore additional studies are needed on its mechanism of action and long-term adverse effects of ketamine. Coming to the cardiovascular system, ketamine leads to a centrally mediated increase in sympathetic tone and release of catecholamines from the adrenal medulla, thus causing increase in all the cardiac parameters. But a catecholamine depleted patient, ketamine may actually reduce the blood pressure and cardiac output because of a direct negative inotropic effect. And one more caution, in patients with coronary artery disease, the increased sympathetic stimulation due to ketamine may increase myocardial oxygen demand and lead to ischemia. In the respiratory system, ketamine has no effect on the ventilated drive in usual doses. However, it may cause respiratory depression when administered in large doses or in combination with other sedative agents. Ketamine causes relaxation of bronchial smooth muscle, and it is very useful in patients with bronchospasm or reactive airway disease. Ketamine acts on various receptors, inflammatory cascades, and bronchial smooth muscles to produce the bronchodilation. Ketamine allows for more secure induction of anesthesia in patients with life-threatening acute intense bronchoconstriction. But ketamine increases salivation and pharyngeal secretions and also increases the muscle tone, which makes it sort of uncomfortable for the anesthesiologist and the surgeon respectively. Ketamine can be conveniently administered via multiple routes, including oral, nasal, rectal, intravenous, intramuscular, subcutaneous, transdermal, sublingual, intraosseous routes at standard recommended doses. The dose given by the neuraxial route is highly variable. Ketamine has been well established for clinical use during the past 5 decades as a versatile and safe drug in the hands of experts with strong scientific evidence based on its pharmacodynamics and cardiovascular stability features, in spite of some side effects like emergence delirium, especially as an intravenous or intramuscular induction agent in the emergency settings in shocked and hypertensive patients. Here are some of the well-established indications where ketamine is preferred as anesthetic agent of choice for endotracheal intubation in critically ill patients with sepsis in the ICU, in patients with cardiac tamponade or restrictive pericarditis, in patients with reactive airways and status asthmaticus, and in patients with congenital heart disease with right to left shunt like tetralogy of Fallot. All of us are familiar with the role of ketamine in providing anesthesia for the burns patients like analgesia and sedation during emergency pain relief and resuscitation, dressing changes during excision of the SCHAR and grafting procedures. Also, ketamine can be used either IM or orally while facing difficulty in getting venous access in such patients. Pseudoanalgesia in such patients is commonly used given using ketamine along with either midazolam or dexmed. Ketamine is well established as an extremely useful anesthetic drug in the pre-hospital and battlefield situations as well. Especially in pediatric anesthesia practice, we are all familiar with ketamine being used for pre-medication and IM induction. Ketamine is also being currently employed by the practicing anesthesiologist in low doses, both IV bolus and low dose infusion, usually along with midazolam to supplement and to provide sedation and anesthesia during local and regional anesthesia procedures in adults. The pharmaco and hemodynamic characteristics of ketamine are being conveniently utilized during sedation and anesthesia in the ICU, during endotracheal intubations and endotracheal suctioning procedures. The role of ketamine in diminishing bronchospasm in patients with respiratory distress is also well documented. It is reported that ketamine doses of 0.1 to 0.2 mg per kg, followed by an infusion of 0.15 to 2.5 mg per kg per hour, can be used in patients with refractory bronchospasm when all other measures fail. Ketamine is being employed routinely by practicing anesthesiologists for procedural sedation as well. There are some recent clinical applications of ketamine with limited scientific evidence as on date based on a better understanding of the role of NMDA receptors in pain modulation. A low-dose intravenous ketamine of 0.5 mg per kg is devoid of any hemodynamic change and adverse effect and is an optimal dose for preemptive analgesia in laparoscopic cholecystectomy. Low-dose regimens in the range of 0.5 mg per kg IV ketamine as an initial bolus followed by 50 to 500 mics per kg per hour have been proposed as an adjunct for postoperative analgesia and for reduction of exogenous opioid-induced hyperalgesia. Similarly, ketamine has been reported to be of use in the form of ketamine spray and in the tonsillar fossa after post-tonsillectomy for post-operative pain control in children. And there are various other reports about emergency department usage of ketamine in very low doses, subanesthetic doses. One interesting report is that ketamine given as an alternative drug infusion as 0.3 mg per kg in 60 ml solution over 3 hours has been explored, has been reported to give complete remission of phantom limb pain. Ketamine may be effective in the treatment of peripheral and central neuropathic pain, ischemic limb pain, fibromyalgia, chronic regional pain syndromes, visceral pain, and migraine. But these clinical applications have only limited scientific evidence regarding efficacy and safety profile, and therefore the use of oral ketamine in chronic pain management may have only a limited place as an add-on therapy in complex chronic pain patients if other therapeutic options have failed. In palliative care practice, ketamine has been administered as a co-analgesic in addition to opioids and co-adjuvant drugs. Now, ketamine is considered to be an essential adjuvant analgesic for refractory cancer pain, and it is on the WHO's essential drugs list for patients who no longer respond to high doses of opioids and other conventional medicines, or those who have predictable breakthrough pains. There are some more off-label anecdotal case reports and verbal communications by senior practitioners of anesthesiology, like a single dose of 0.5 mg per kg of ketamine given upon induction associated with lower serum levels of CRP and lower incidence of delirium and cognitive dysfunction after cardiac surgery with CPB. Use of dexmed and ketamine infusions during scoliosis repair surgery with SEP and MEP monitoring, and also during bariatric surgery. Ketamine sedation during spinal anesthesia for arthroscopic surgery can reduce the ischemic deperfusion injury. There are very many anecdotal case reports, both published and unpublished, about the beneficial use of ketamine for restless leg syndrome, the whole body anesthesia and analgesia following intrathecal administration of preservative-free ketamine. But at the same time, ketamine has become popular nowadays as an agent of drug abuse and addiction. Several incidences of ulcerative cystitis, secondary renal damage, and hepatic damage, and long-term memory impairment have been reported to be associated with such drug abuse involving very high doses of ketamine. There are definitely some situations where ketamine should be avoided, like uncontrolled hypertension, stroke, severe ischemic heart disease, eclampsia, and acute porphyria. Ketamine is not recommended in neonates, patients with schizophrenia and raised intraocular pressure, and situations where airway compromise needing manipulation can occur, like excessive salivation leading to laryngospasm in children. Ketamine is unsuitable for operations where muscle relaxation is very much needed, and ketamine use has been avoided by practicing anesthesiologists due to the associated psychological manifestations like emergence reactions, dreams, hallucinations, etc. Benzodiazepines are the most effective group of drugs to prevent and treat these emergence phenomena. To summarize, ketamine is considered as a promising drug for many clinical applications, even after 5 decades since its discovery. Ketamine is a dissociative anesthetic agent with a variety of pharmacological effects, from anesthetic induction and maintenance to analgesic and sedative depending on the consuming dose. It can be used solely or in combination with other coadjuvant drugs, increasing their efficacy. Identifying new properties of ketamine such as neuroprotective, anti-inflammatory, anti-tumor effects on one hand, and taking advantage of the sub-anesthetic regimens of ketamine on the other hand, have resulted in widespread use of ketamine in various clinical applications. Ketamine is soluble in aqueous and lipid solutions, providing convenient administration via multiple routes. But one word of caution is recreational ketamine, popularly known as Special K among American drug addicts, has become a significant drug of abuse in China. Indeed, ketamine abuse in China has become a big enough problem to motivate its government to recommend that the United Nations place ketamine under international control as a Schedule 1 psychotropic substance in March 2014. Of course, many governments did not agree with that and weighed in against the recommendation. Perhaps the most compelling objection came from the United Kingdom. The United Kingdom reported, after acknowledging the risk posed to the public health by illicit use of ketamine, the United Kingdom delegation calculated that 5.5 billion people live with limited or non-existent access to controlled medicines, and that for them, ketamine is often the only anesthetic agent available. Ketamine is considered as a promising drug for many clinical applications, and rightfully so, it deserves to be that the United Nations Commission on Narcotic Drugs eventually decided not to place ketamine on any schedule. We can conclude that as on date, the future of ketamine in anesthesia practice will be balanced between the firm clinical establishment of newer mechanisms of actions and newer possibilities of its use based on its anesthetic, analgesic, antidepressant, anti-inflammatory, anti-tumor, and neuroprotective effects. Against its long-time stigma as a veterinary drug, the dose-dependent psychological manifestations like emergence reactions, and the long-term psychomimetic effects, and its significant abuse and addiction potentials. I thank you all for your patient listening. Thank you.
Being available on the spot, I want to add one more anecdotal report from my professor, who is a senior faculty, senior teacher for all the professors of Tamil Nadu, Professor Nagasamy. He personally communicated to me that one patient was a doctor himself. He had multiple fibromatosis all over the body.
So the presentations for the day have come to an end. So we have
many of the. I have got a small image.
Yeah, please, sir.
Yeah. So actually, I was narrating about a personal anecdote from Professor Nagasamy from Chennai. Actually, the patient himself was a doctor and he had multiple fibromatosis, painful all over his body. So he wanted to get them excised. So he went to many doctors, but many of the anesthetists and surgeons refused because he had a stent in his trachea. So nobody was able to plan a therapy anesthesia plan for removal of all multiple fibromatosis all over his body. He had 4-5 in the trunk, 4-5 in the upper limb, 4-5 in the lower limb. So ultimately, Dr. Nagasamy was underwent this case, and he tried 50 to 75 milligrams of preservative-free ketamine intrathecally, and he left the patient for 45 minutes. And after 45 minutes, the patient was conscious, but the operation went on well. All the painful lesions were removed from the upper limb, lower limb, trunk by 2-3 surgeons separately within another 45 minutes. And the patient himself was so happy that he got all his painful lesions removed with one shot of spinal intrathecal preservative-free ketamine. And the doctor did not come back again with any residual neurological effects. That means the spinal ketamine does not have that much of neurotoxicity. And being a busy practitioner, Professor Nagasamy communicated that he used this technique of preservative-free intrathecal ketamine in more than 10 patients, and none of them reported with any neurological deficits as a circulative ketamine intrathecally. Thank you. Any questions from the audience? Yeah, if you are using only ketamine sole without anything else, 50 to 75 milligrams. Sole ketamine preservative free. Yeah, the recent publications have clearly shown the actually convulsions are coming down with ketamine. It does not promote convulsion, seizures. I went through I was also really surprised because in the recent publications literature clearly says the seizure potential is actually not increased by ketamine. There are a lot of myths and mysteries surrounding ketamine ever since it was introduced in 1965. So the initial studies were done in 1970s. They were published, but most of those studies were not controlled and they were based on anecdotal reports. And because of that, the myths have sustained for over 50 years now. But recent publications and research controlled studies are coming up in a big way. So we need more research and studies based on ketamine. Randomized controlled studies are required. Yeah, the sublingual ketamine has been tried in palliative care for cancer patients, but the oral bioavailability is very less. So nowadays, palliative medicine people and cancer pain, they are not recommending. Oral ketamine for chronic cancer pain patients is not ideal because the bioavailability for oral route is very less. So intravenous or subcutaneous is effective, but it is not that effective in palliative care at home care centers. But if it is intranasal analgesic, yeah, that is being used as a preemptive analgesia even for chest surgeries. That it is given very good results after surgery. The post-operative pain relief is adequate, excellent. It has definitely reduced the opioid consumption and it gives very good clinical relief for the patient. I am personally using ketamine in very low doses, even for all hernia surgeries and cholecystectomy, abdominal surgeries, everywhere it is useful. I have been practicing ketamine low dose in cardiac surgery also, and delirium level is definitely reduced. Yeah, local spray is also effective. Yeah, yeah. Actually, the depression is taken care of by the hydroxymethyl norketamine derivative. Ketamine is metabolized in the liver by two processes. First, initial demethylation, and next is hydroxylation. Then converted into glucuronidase production. It is released in the urine. The hydroxymethyl norketamine part that depresses takes care of the depression. It works as an antidepressant. There is a very good published article since 2003 onwards. Dr. Berman is the authority on that, and he has published a lot of papers. And this intravenous solution of ketamine given over a period of 1 hour or 2 hours, that immediately relieves antidepressant depression symptoms and signs, and suicidal ideation is very much reduced within 1 hour. It is drastically in contrast with other antidepressant drugs, which take 2 weeks, 3 weeks to act. So immediate benefit is achieved with ketamine, but only disadvantage is we do not know the scientific basis how it really acts, And we do not know the long-term effects also. And the most important fact is the duration of action of ketamine is short-lived. It lasts for only 1 week. And we do not know how far we can continue with oral ketamine or IV ketamine repeated doses. So it needs further scientific studies. Yeah, it is available. It has been FDA approved in 2019 March onwards. But in India, it is available in one particular brand. But it is very costly. I checked from the internet. It is around 15,000 for 28 milligram, one single dose. Ketamine? Gargle. Gargle, you can use, sir, pardon? Yeah. Yeah, I actually, the ketamine is whatever we are solution using is preservative containing. That can be used in addition with any sweetened drinking for clinical use. Yeah, when the patient is not suitable for any other anesthetic or analgesic, and it involves actually the one single advantage my professor has told me is the moment you give ketamine, it gets absorbed in systemically also. The systemic absorption and entire CNS NMDA receptor modification gives whole body anesthesia. It's not like spinal blockade below that level. So with one shot of ketamine, after 45 minutes waiting time, they were able to operate on the upper limb, lower limb, head and neck, and trunk also. Pardon? First waiting time was around 40 minutes, and afterwards it lasted for 2 hours. 40 to 45 minutes. Pardon, sir? No. Respiratory depression at that dose was not there. Yeah, muscle relaxation was adequate. Actually, the mechanism is very complex, and the NMDA receptors are present in almost all the neuronal cells. And the NMDA receptors have glutamate in one side. If you see, I didn't have the time to explain the receptor. There are very well published articles in the internet. I went through that. And the one side there is glutamate binding site. The other side is the glycine side. And the glycine is also in that site also takes up D-serine, which is also one important chemical which is involved in the neuronal formation even in the embryo state. The neuron development during the embryo is led by the D-serine binding site, glycine binding site. And it is one more thing is it is sensitive to the frequency with which it is stimulated. They have studied that if they are using one less frequency stimulation for that, then the AMPA receptors are created on the other side of the junction. Okay, in the postsynaptic junction of the dorsal horn cells. If it is more frequently stimulated like 200 hertz, then the AMPA receptor actual new formation has come down. That is how the sensitization, primary sensitization occurs in the dorsal horn cell. With frequency sensitive mechanisms, the dorsal horn cells are able to go for neuroplasticity. And these are well controlled by the NMDA receptors. And ketamine has got a dose dependent action on all these NMDA receptors. And this modifies how we react to pain. And one beautiful report about this phantom limb pain was one 10-year-old fellow boy was suddenly had an accident and went for an amputation. And soon after amputation, he had been managed with a lot of opioids and other things. After 3 days, he developed severe phantom limb pain. It did not respond to any of the known analgesics. So finally, they tried ketamine intravenous. That was depicted in my slide. 0.3 milligram per kg body weight infused in 60 ml of saline over 3 hours. And for next within half an hour, his phantom limb pain disappeared. And for almost 1 week, he never had anything. And subsequently, the pain did not appear also. That was a very well published report. Pardon, sir? Spray. Nasal spray, sir. Yeah, nasal spray. But it's little bit expensive as present in India. Whenever the suicidal ideation is very high, the patient, especially in the antidepressant role. Yeah, it has been approved by FDA for antidepressant role as a nasal spray. 28 milligram single spray instrument. It is costing 15,000 in India on it. Yeah, no, yeah, no, after intrathecal, neurofibromatosis. Nothing, sir. No. Nothing. Midazolam we can give as a tablet or any other form, intravenous also, as to just counter the emergence phenomena. but it's even emergence phenomena is not universally happening in everybody. It is hardly 50 to 40 to 50% people get. Yes. Yeah, the low dose doesn't cause so much of emergence phenomena. Only the full IV anesthetic dose causes emergence phenomena. Thank you. Thank you, sir. Thank you. Thank you. Chaluji, thank you. You can take over.
Thank you, sir. Thank you very much.
Thank you.
Welcome back. Good afternoon, all of you. I would like to Dr. S.P. Singh, now Dr. K. Mohan, and Dr. William Paul, and Dr. Balwinder Singh for the topic of perioperative cardiac monitoring. Subodh Chaturvedi.
Our next speaker will be Dr. Subodh Chaturvedi. And the topic of his presentation is ECG monitoring and interpretation.
Hello and good afternoon. I am Dr. Subodh Chaturvedi. I have worked as a cardiac anesthesiologist for 10 years and lately I have been working as a bariatric anesthesiologist in Indore. I am thankful to the organizers to provide me with this opportunity to present in front of this national and international audience. So let's begin the talk about perioperative ECG monitoring. We all always want to have good, beautiful looking monitors with normal heart rates and good saturations, and most of the time that happens also. But then life is not always simple. 4% of all surgeries, 4% of all non-cardiac surgeries have significant cardiac events. That means if in your city there are 100 surgeries going on today, then believe me, at least 2 or 3 of them are having some kind of arrhythmia, some kind of a deadly rhythm, some kind of a ischemia, some kind of ST elevation, or a bad monitor. And believe me, one fine day, this is going to happen to your theater also. So, sooner or later, all of us are going to need how to diagnose and treat ischemia, how to diagnose and treat arrhythmias. It's not only about cardiac theaters now. With the advent of more and more technology, we are catching more arrhythmias, as well as with the advent of all these cardiac implants and everything, we are getting more and more patients who have cardiac diseases and who have been treated with them to our OTs. Now, what happens when such kind of a rhythm strikes? When a bad ECG comes to our monitor? Our brain works in loops. If I ask you that, see, this is your rhythm on your monitor, you have this rhythm, what will you think? The first thing that will come to your mind is, it is ventricular tachycardia. Fine. Second thing that will come to your mind is, it is xylocard. Let's give xylocard. Fine. If somebody is in a small setup and a private small nursing home, the next thing that will come to his mind is that this was a VIP patient. Maybe this surgeon won't give me a call again. Maybe I didn't do the PAC right. And instead of thinking about the diagnosis and treatment, our mind will go into loops about what we shouldn't be thinking. In this 15 minutes talk, I cannot teach you whole ECG, but I'll try to associate some words with some arrhythmias or ischemia, so that when we see a bad rhythm, we can think of those words instead of a VIP patient or a management ka rishtedar or whatever. So let's get on with the perioperative ECG monitoring. 3 things you look for in perioperative ECGs: arrhythmias, ischemias, and electrolyte and metabolic disturbances. Why do we even need an ECG? To diagnose these things. Most of the time it doesn't need to be used, but in aged patients, in 40 plus patients, in patients with previous histories, it becomes all the more important to diagnose and treat ECGs. So, which leads do we monitor if we have put on ECG? Most of the time, most of the OTs, most of the hospitals have a typical setup of monitor with a single lead, and that single lead is always the lead 2. Why lead 2? Because P wave is best seen in lead 2, because the axis of the P wave and the axis of lead 2 are exactly the same. So P wave is best seen in lead 2. If you want to diagnose an arrhythmia, if it is supraventricular or ventricular, the best lead to use is lead 2, obviously. And the problem with this lead 2 is that It sees rhythm, all good, no problem. But when it comes to ischemia, it is a big failure. They say that lead 2 can diagnose only 33% of ischemias. Just that. So even if you have put an ECG and you are monitoring lead 2, there is 70% chance that you won't be able to pick up an ischemia. Why so? Because the lead 2 is seeing the heart from above, like this. The heart is above the lead 2 and the area lead 2 is able to see is this only, the inferior wall. So it cannot diagnose anterior wall ischemias, and you and me both know that 70% of your heart, the 70% of actual proper myocardium lies in the anterior wall. So lead 2 is about to miss the whole anterior wall ischemias at any given point of time. 70% of ischemias are going to be missed. So what to do? If your monitor, if your OT has a proper 5 electrode 2 ECG lead monitoring system, then you can use that. This is the standard 5 leads, 5 electrodes and 2 lead monitoring system. And in your monitor, put up a setup like this. A primary ECG lead, that is the lead 2, and a secondary ECG lead, that is the lead V1 or a chest lead. If you can do that, then believe me, you are going to catch on 70 to 80% of ischemic events if they occur in your OT. But unfortunately, most of the monitors we have are like this. A single ECG lead, saturation, EtCO2 and pulse. And of course, an IBP. Now what to do? You don't have 2 ECG leads to take care of the anterior wall and the inferior wall both. What can we do? There is one thing which is called as Jugaad. This Jugaad ki lead 5 is designed in a typical way. We put our routine 3 lead ECG, we put our routine 3 electrodes in a different fashion. This right-sided electrode, right arm electrode, stays where it is supposed to be. But this left deltoid fossa electrode goes from here to here in mid-clavicular line, just side of the nipple, and this electrode, instead of being here, goes just right to the manubrium. This we are making Jugaad ki lead 5, which will diagnose inferior as well as anterior wall ischemia for us. Now, once you have set up the electrodes like that, now if you turn on your monitor and put standard lead 2 for monitoring, then it will show standard lead 2 only. But the moment you change your dial to lead 1, it will start showing you anterior wall or lead V. So this one thing I want to stress in this talk, that even if you have a simple monitor with a single lead setup, you can make a Jugaad ki lead 5 by changing the position of electrodes. You can take a screenshot of this and monitoring lead 1 for anterior wall and monitoring lead 2 for inferior wall. You can just change them in between the surgery and you can see anterior and inferior wall both. So now we know where to look for, but what to look for? We will look for a lot of things including ectopics and broad QRSs and everything, but mainly in ischemia we look for ST elevations and ST depressions. Again, I'll explain in a very short 2-minute thing. This is your normal PQRST. This point where P wave meets the QRS complex is called as the PQ junction. Where the P wave meets the QRS complex is the PQ junction, and the point where QRS complex ends, this joint, is called as the J point. Ideally, this J point should be within a millimeter of PQ junction. This J point should not be more than 1 millimeter above or below the PQ junction. Let's see an example. Now this is your PQ junction where P wave meets the QRS complex. This should have been the J point where the QRS complex should have ended. But this J point is like good 2 millimeters above So this patient is having ST elevation and therefore ischemia. Another example, this is your PQ junction. Your J point should ideally have been here, but again it is 2 millimeters down. So this is ST depression. In a ECG, this is again your PQ junction. Your J point should have been here, but it is 3 mm above. This is definitely ischemia. Same here. Now in this ECG, this is your PQ junction. Your J point is here. It should have been here. Again, it is 2 mm above. It is ischemia. Last ECG, PQ junction should have been here, J point, but it is down. This is ST depression. So now we know where to look for ischemia and what to look for ischemia. But what to think when you see ischemia, that's what I want to stress upon. Okay. These are the words that should come to your mind when you see ischemia. The moment you see ST elevation or depression, you should think about, is the patient having blood loss? Why does he have ischemia? He has either a demand increased or a supply decreased. Supply decreased means either he's having lack of oxygen in his coronaries, or he's having lack of blood, or he's having hypovolemia, hypotension. So think about, is he having blood loss? Maybe we should give fluid. Is he having hypoxia? We should switch over to 100% oxygen. Is he having pain? We should control his pain. Is he having tachycardia? Then again it is demand ischemia. You should control his heart rate. Is he having hypertension and increased demand? We should control the blood pressure. So the moment you see ischemia, you should think about control of heart rate. If it is like 120, 130, you should bring it down to 80s. If it is hypotension, especially diastolic hypotension, the BP is like 80/45, try to bring it to something more respectable. If it is hypoxia, give oxygen. If it is blood loss, give fluid. So when ischemia you see on monitor, think about these terms: blood loss, fluid, hypoxia, oxygen, pain, tachy, hypertension, hypotension. That's it. Similarly, about arrhythmia. Now again, you all know arrhythmias, you all know atrial fibrillations and SVTs and everything. Arrhythmias are very common in OTs, and they are because of so many things we do, like intubation, reflexes, reflex tachycardias, reflex bradycardias, intracranial hemorrhage, autonomic nervous system stimulation. So many things cause arrhythmias. Again, few salient features what I want you to take home is, whenever you see an ectopic on monitor, just make sure that it is corroborated with the respective SpO2 tracing or arterial tracing. Whenever you see an ectopic, just to make sure it is not an artifact and how much hemodynamic change it is doing, just corroborate it with your saturation tracing and your arterial tracing. If your ectopic is looking different with your saturation tracing, then it is a proper ectopic. Otherwise, it might be an artifact also. I have seen so many times rhythms like ventricular tachycardia, which were just an electrode misplaced. So we can have two sets of arrhythmias. We can have bradycardias and we can have tachycardias. And even in tachycardias, we can have all kind of ranges from atrial fibrillations, fast AFs, to supraventricular tachycardias, to ventricular tachycardias with pulse. But the moment you see a tachycardia, the moment you see a very fast rate on monitor, what you should be thinking about? You should be thinking about, the moment you see a tachycardia, think about whether the patient has pulse or not. First and foremost thing, check the carotid. If he has a good carotid, then you can maybe go to the next step, and then maybe you can take a blood pressure to see if he is hypotensive or not. But if he does not have a pulse, the next thing you have to think about is defibrillation, or what we lovingly call as DC shock. Whenever you see a tachycardia on monitor, be it atrial fibrillation, be it supraventricular tachycardia, what we do is cordron दें, कि beta blocker दें, कि xylocard दें. No. The moment you see a tachycardia, first thing you do is do a carotid pulse check, whether the patient is in GA or spinal, whatever. Then If it is pulseless, go for defibrillation. This is what we don't want to do in our OTs most, and this is one thing, if we change our practice about, will make a lot of difference, make a lot of real difference. Whenever you see a tachycardia, check for pulse. If it is missing, go for a defibrillation. If there is a pulse, if there is a good BP, then think about other things. What is the cause of this tachycardia? Is it pain? Maybe we should have some analgesia. Is it hypovolemia? Maybe we should give fluid. Is it something else? Is it electrolyte imbalance? Maybe we should think about giving some magnesium or potassium or whatever. But the first thing that should come to your mind when you see a tachycardia is nothing, but is it having pulse? If a tachycardia is unstable, by definition, unstable tachycardia means the tachycardia is causing the hemodynamic upheaval. The tachycardia is causing the hypotension. The tachycardia is causing the pulmonary edema or whatever. So if the tachycardia is unstable, first and foremost thing, think about defibrillation. Stop the surgery, ask the surgeon to stay away from the patient, give a defibrillation, and then move forward. On the contrary, if the tachycardia is stable, then you can think about drugs like Xylocard, Lignogen, Amiodarone, Cordaron, or beta blockers or other things, diltiazem and all. Unstable tachycardia, shock. Same is with your bradycardias. Again, you can have all kind of bradycardias ranging from sinus brady to junctional brady to second degree heart blocks and complete heart blocks and all. But then the moment you see a tachycardia, again, the word association we would like to think about is it stable or is it unstable? Is the bradycardia having a pulseless patient? Because many a times a tamponade or a pneumothorax or a pulmonary embolism presents as a bradycardia, but the patient is practically dead by then. So if the monitor is showing bradycardia and the patient is pulseless, then it is not bradycardia, it is pulseless electrical activity. Only two things you need to do in a PEA. One is epinephrine, adrenaline, and second is CPR. So if your patient is pulseless with a bradycardia, go for CPR, epinephrine. If the patient has pulse, and 99% of them will have pulse, then think about other things. But the first word that should come to your mind with tachycardia or bradycardia is there pulse or not? Second thing, in bradycardia, you should be thinking about defibrillation. DC machine kahan rakhi hai, leke aao. In bradycardia, you should be thinking about pacemaker. Do we have a TPI in the hospital? Should we call cath lab? Should we call a cardiologist? The moment you see a bradycardia, okay, you are going to treat it, but your mind should race in that direction. Think about pacemaker. Do we have transcutaneous pads on our defibrillator or not? So think about pacemaker. Maybe you could put a jugular, you could put a 7.5 French sheath in jugular and put a pacemaker through that. You don't need a C-arm for that. So whenever you see a bradycardia, think in those terms. You are thinking in those terms. At the same time, you are giving atropine 1 ampule. Don't give atropine diluted to 10 cc and 1 cc of that. No. Atropine, give good 0.6 mg. Think of the causes. Is it vagal? Is your bradycardia caused by a vagal stimulation? Is it because of your spinal? Is it because of something the surgeon is doing? But then back of your mind, the things that should keep coming, because why I'm stressing on these words is because these options come to our mind good 10 minutes later, and by then the patient is practically dead. So things I want to think you about is pacemaker, atropine full ampule, and cause. Is it mechanical? Many a times bradycardias of OT are mechanical. They are pneumothoraces. They are pulmonary embolisms. Think in terms of that. Is it hypoxia? Is it mechanical? Just that. So again, if your atropine is not working most of the time, if it is junctional brady or if it is first degree heart block or sinus brady, then your atropine is fine. But the moment it crosses your AV junction, as if it is a high block, then it won't respond to atropine because vagus doesn't supply there. then you will need something like a DOPA infusion and epi infusion. So moment you see a bradycardia, if it is having pulse, the patient is hypotensive or something, think about DOPA or epinephrine infusion. So in these 16 odd minutes, 19 odd minutes rather, I'm sorry to extend, I have tried to cover some salient features and I have tried to make you think differently whenever you see something bad on your ECG, whenever you see an ischemia, whenever you see a arrhythmia, whenever you see a bradycardia, just think in those terms and maybe we'll have a much safer patient and a much better patient in our hands. I hope you like this lecture. I'll be available for the question answers at the end of the session. Thank you very much.
Thank you, Dr. Subodh Chaturvedi. Due to some reasons, Dr. Rajesh Thosani, who was the next presenter, he is not able to make to this presentation. So we will be joining Dr. Neeti Dogra for her presentation. Dr. Neeti Dogra, she is Associate Professor, Department of Anesthesia and Intensive Care at TGIMER, Chandigarh.
A very good morning and warm greetings from PGI Chandigarh. At the outset, I would like to thank the organizing chairperson, the organizing secretary, members of organizing committee, Isacon 2021 for giving me an opportunity to be here in front of you at Ahmedabad, Gujarat. I am Dr. Neeti Dogra and today I will be talking on transesophageal echocardiography, its interpretations and implications. We'll see why do I need a TEE, interpretation of TEE images, whether it's a fact or an artifact, the diagnostic and therapeutic implications of TEE in cardiac, non-cardiac surgery and intensive care unit. The 2013 American Society of Echocardiography guidelines suggest transesophageal echocardiography as the first line imaging modality if there is a poor transthoracic echo window, in cases of aortic or left atrial appendage pathology, suspected endocarditis, valvular heart disease, especially mitral valve prolapse, prosthetic valve evaluation, electrophysiological procedures as cardioversion in atrial fibrillation, interventional cardiology procedures, and to rule out cardiac source of embolism. This will be a case-based presentation and our first case is a 67 years old male, hypertensive, having paroxysmal atrial fibrillation, who currently presented to us with history of syncope. He is afebrile, his CT head is normal and is referred to the cardiologist for a transthoracic echo which shows a rounded, well circumscribed mobile mass in the left atrium. The same mass could be very well seen in the left atrial appendage cavity on the transesophageal examination. And what according to you should be the management option? Should we offer this patient anticoagulation, left atrial appendage closure or surgical removal of thrombus? That was the discussion being carried out while evaluating these images when we realized that this is nothing but a reverberation artifact in which the artifact is placed twice the distance from transducer and a strong reflector which is the aortic wall in this case. Our next case was a 55 years old male with double vessel disease on a coronary angiogram posted for a off pump coronary artery bypass surgery when after anesthesia induction the fellow exclaimed, "Ma'am, there is an appendage thrombus, should we ask the surgeon to go on pump?" And because we had seen something like that previously also, I asked him to look in a different imaging plane, to look at the left ventricular function, to look at the left atrial appendage by zooming in and see any evidence of thrombus, to apply a color Doppler over the image at a low flow velocity of 20 centimeters per second and to see for any aliasing which would suggest a high velocity flow. Additionally, we can also apply pulse wave Doppler across the left atrial appendage to look for appendage blood flow velocities, and in this case it was quite above 60 centimeters per second, suggesting a normal left atrial appendage velocity and going against the diagnosis of thrombus. So, this was nothing else but a reverberation artifact of the warfarin ridge, which was being projected exactly twice the distance from the transducer. This case was a 50 years old male who presented to us with a complaint of non-specific chest pain and a non-diagnostic 12-lead ECG. Immediately, a transthoracic echo was performed, which showed a huge mobile mass floating inside the left atrium. A transesophageal echo was performed to localize the mass exactly when we saw that the left atrium is grossly clear, but yes, there was a cystic, thin-walled cystic structure which was being visualized here. So, we rotated our probe backwards and looked at the descending thoracic aorta, left pulmonary vein, and we could see a thick muscular walled structure with air bubbles inside it. Surprised, we performed a color Doppler examination to rule out any phasic flow within this structure at low blood flow velocities and confirmed our suspicion of hiatus hernia on a subsequent chest CT. So, even extracardiac mass could be interpreted as an intracardiac one on echo if you are not sure of how to perform it. This study, published in Italian Heart Journal, emphasized the usefulness of multiplane transesophageal echo in recognizing artifacts from left atrial thrombi. 37% of patients undergoing corrective mitral valve surgery had left atrial appendage artifact which was never found on surgical evaluation, and similarly 23% patient undergoing cardioversion had left atrial appendage artifact. Surprisingly, all of these were reverberation artifact found twice as far from transducer as from an anatomical structure, and all of them were due to warfarin ridge. None of the artifact had an attachment to left atrial appendage wall, and its consistency was non-uniform. This patient had a new onset left atrial mass post CPB. The surgeon was dead sure that he had seen nothing in the left atrial appendage before closure, and therefore we performed a 3D TE where the mass was shown to be nothing else but an inverted left atrial appendage. So, we have talked about what is not a thrombus, and now what is a left atrial appendage thrombus. This is what it would look like attached to the left atrial walls, having a smoky appearance suggesting low blood flow velocities. So, the therapeutic implications of TEE in such cases are not only TE guided cardioversion in AF, but also appendage closure and decision to convert to an on-pump CABG should a thrombus be seen. Our next case is a 65 years old male with history of fever with chills and rigors. He is morbidly obese with history of transient right arm weakness which resolved with no residual neurological deficit. He had a systolic murmur on examination. His blood cultures were sent, antibiotics started. The CT head was non-diagnostic for stroke, and because of a non-diagnostic transthoracic exam, a TEE was performed which showed a large mobile vegetation on mitral valve with severe mitral regurgitation. So, what are the therapeutic implications in this case? Should we anticoagulate this patient, continue antibiotics unobserved, or perform an urgent mitral valve surgery? And can your transesophageal echo help? Definitely yes. This seminal study published in JACC in 1991 showed whenever the size of vegetation exceeded 10 mm, the cumulative probability of embolism exceeded 50%, especially if it was a grade 3 or grade 4 vegetation, if it was at mitral location, and the initiation of medical therapy decreased the incidence of embolic events to 1/3 if initiated within first 2 weeks. Early surgery conferred a benefit in terms of reduced probability of death or systemic embolism by removing the source of embolism. Therefore, consider early surgery if there is a large vegetation, mitral location, and the vegetation is having grade 3 or 4 mobility. This was a 55 years old male who presented to us with history of fever with chills and rigors 2 years after a bioprosthetic aortic valve implantation. Now, the transthoracic echo showed just a thickened aortic root, and we can very well see a aortic root abscess being diagnosed on a transesophageal echo. And this image or loop is not here to show that this is the abscess cavity ruptured into the LVOT causing AR, but that this patient developed acute chest pain with ST elevation MI on 12-lead ECG in anterior leads and was urgently rushed for surgery. Could you guess what could be the cause of this ST elevation MI? It was nothing but the aortic abscess compressing upon the left anterior descending coronary artery. You could very well see this is the interatrial septum and this is the location of the left main artery. So, the abscess was compressing upon the artery. So, in cases of abscess involving the region of coronaries, be very sure that you proceed for an emergency surgery. Coming to acute aortic syndromes and the role of TE, I must ask, mirror, mirror on the wall, who is real amongst them all? Is this a aortic dissection flap? No. This is just a mirror image artifact where the duplicate image is produced on the highly reflective surface of aorta behind the mirror. And in this image, is this what you see, a aortic dissection flap? No, even this is a side lobe artifact, and it can be diagnosed that every point on this linear arc is exactly at the same radial distance from the transducer. So, why are we worried about these artifacts? Should we be? Yes, because the mortality associated with thoracic aortic dissection is very high and increases by 1.4% every hour the patient is untreated, with a 68% mortality within 48 hours. The good thing is that your transesophageal echo gives you an equally reliable diagnostic value comparable to helical CT and MRI. And because we had this diagnostic dilemma between a linear artifact and an intimal flap, this excellent study in chest showed that if the thickness of this intimal flap is more than 2.6 millimeter, then it's an artifact. If the subtending angle between aortic wall and the intimal flap is more than 85 degree, it is a artifact. If you can see color flow on both sides of artifact with equal blood flow velocity superimposing on the linear arc, then also it's an artifact. A true intimal flap is a very thin structure with a flow acceleration within the true lumen and no flow in the false lumen until unless there is a communication. The eye see what the mind knows. This 75 years old male patient presented to us with a hypertensive urgency and a blood pressure of 230 by 130 millimeters of mercury and diffuse chest pain radiating to back when a suspicion of acute aortic dissection was raised and a TE was performed. We could see some thickening and thickened aortic wall here, but what I want you to see here is the classic trilaminar appearance of aortic intramural hematoma. This is something that you must go in for an urgent CT and emergency surgery because of most of these intramural hematomas convert into acute aortic dissection within the next 48 to 72 hours. And now the classic aortic dissection flap prolapsing into the left ventricular outflow tract causing severe aortic regurgitation, and these images in short axis are not to show you the dissection flap but to rule out coronary involvement or coronary being present in the false lumen, which can cause a risk of myocardial infarction even with non-occlusive coronary arteries. T is also implicated in giving a good diagnosis of scallop by scallop examination in cases of mitral valve prolapse and the mechanism of mitral regurgitation. It can also give you an indication of the left atrial surface which cannot be evaluated on a transthoracic exam due to acoustic shadowing. So, in this case you can see there is a huge left atrium which needs to be evaluated, and the most common complications with the prosthetic heart valve is either thrombosis causing occlusion of the valve or infective endocarditis. So transesophageal echo will give you a good examination of the left atrial side of the valve, and in this case it diagnoses the pathology to be occlusion of one of the leaflets of this prosthetic valve. It can also be useful in recognizing a dilated coronary sinus and a persistent left superior vena cava to be the cause, and performing a TE guided coronary sinus cannulation. It could also be implicated or interpreted as recognizing a localized or regionalized effusion which has a potential to cause tamponade and could lead to hemodynamic compromise. It could also be interpreted and evaluated for PFO closures in cath lab for evaluating the adequacy of closures and to look out for any residual leaks. To evaluate this patient who presented with pulmonary artery hypertension and a dilated RARV, where the cause was found out to be a sinus venosus ASD, which is easily missed on a transthoracic exam, and to evaluate a Watchman device after left atrial appendage closure. The indications include the evaluation of unexplained hypoxemia in an ICU patient where a contrast examination could reveal a patent foramen ovale, a septic patient in ICU where excessive use of inotropes may create a hyperdynamic stiff left ventricle leading to systolic anterior motion of mitral valve causing unexplained hypotension, or a patient with known coronary artery disease who in case of shock may have developed a new regional valve motion abnormality in inferior and lateral territories, suggesting you that the RCA might be involved in these cases. The implications are many, but the time is limited, and therefore I would like to conclude by saying if you interpret your images correctly, you can never go wrong with the TE. Thank you so much.
Thank you, Dr. Neeti Doka. Now, our next presenter is Dr. Bikram Gupta. He is Associate Professor, Department of Anesthesiology and Critical Care, IMS BHU, Varanasi.
Good afternoon to everyone. At the outset, I would like to express my sincere thanks to whole organizing team of Isacon 2021 for giving me this opportunity to discuss about very important topic in such a big platform. Friend, we know that the cardiac output monitoring is very important tool for critically ill medical or surgical patient where we are expecting a lot of hemodynamic instability or lot blood loss. Definitely, it will have to optimize the vitals. It will improve the tissue oxygenation or cellular oxygenation, and that will prevent the irreversible injury or organ dysfunction, organ failure, and definitely it will improve the outcome of the critically ill patient. This tool has been used since many decades when with the introduction of this pulmonary artery catheter or Swan's-Gunn catheter. But because a lot of complication while inserting this pulmonary artery catheter, its use is very limited nowadays. Now, there is paradigm shift of invasive method of cardiac output measurement to the minimally invasive or less invasive method of the cardiac output monitoring. And that comes under the advanced cardiac output monitoring. So in the next 10 to 15 minutes, we will discuss about the advanced cardiac output monitoring techniques. So here mainly it is divided into the invasive monitor or minimally invasive monitors. So invasive, there is intermittent bolus pulmonary artery catheter, which based on the pulmonary artery catheter, which already discussed, and the continuous pulmonary artery thermodilution method. What is that? It is the modification of old equipment with the introduction of some filaments, and there is a thermal filament in the right atrium which intermittently hits the blood. So in every 30 seconds, so it will give the continuous data or relatively real-time data of the cardiac output. But still it is invasive because we are inserting the pulmonary artery catheter in the patients. So there is change in the paradigm from the invasive or pulmonary artery based catheter to the to the minimally invasive, which is based on the following principles like pulse pressure analysis, Doppler, applied field principle, bioimpedance or bioreactance. Now we will discuss each principle one by one, and what all monitors use these principles, like the calibrated devices uses this arterial waveform analysis, and examples of calibrated devices are Pico Plus, Litco Plus, EB1000 or Volume View. Non-calibrated devices like FlowTrack, Visilio or Visilio, Litco Rapid, Pram or Maxspin. This what is the difference between this calibrated and non-calibrated devices? The calibrated devices where we are using two methods to monitor, to measure this cardiac output. One is the pulse contour analysis, where the stroke volume is measured and it is again multiplied with the heart rate. It will give the cardiac output. Again, this method of the cardiac output measurement is calibrated by or revalidated by the transformer thermodialysis technique. So the calibrated devices give the more accurate data, and we can more rely on that data. Non-calibrated data, like example is the flow track or Visilio, and it is mainly based on the assumption or demographic data. It is only based on the pulse contour analysis. So look here, this is pulse contour analysis only here, both transformer thermodilution technique, transpulmonary thermodilution, as well as the pulse contour analysis. Another principle is a Doppler principle, where trans-esophageal echocardiography or transthoracic echocardiography. I will not discuss about that because already covered in the previous class. The Fick principle using the CO2 rarely used, but for the theoretical purpose it can be discussed. And then fourth one is the bioimpedance or bioreactance, that is the endotracheal bioimpedance, ECOM or BIOS and NECOM. So I will not discuss about all three principles that is give the cardiac output, like Doppler, Fick principle using CO2, and bioimpedance and bioreactance. Because the other two are not very important, and this echocardiography already discussed in the previous class. As we go from the invasive to the minimally invasive method, then accuracy is always decreased. So invasive method is more accurate, but non-invasive method is advantage is non-invasive, but accuracy is not so good like the invasive methods. Now, how this arterial waveform will analyze the cardiac output? It is what is the principle behind that? So this is the principle, that is the ventricular-arterial coupling. The arterial pulse pressure and its contour. This contour are primarily determined by the left ventricular stroke volume. What is the stroke volume of the left ventricle, and what is the impedance of the peripheral vessels. So on the basis of this, there is contour. This part is the systolic part or upstroke part. This is the downstroke part. This is the dicrotic notch. So the stroke volume can be continuously estimated by analyzing the arterial pulse waveform obtained from the arterial line, and this waveform can be affected by interaction between this stroke volume and the individual vascular compliance, impedance of the aorta, and the peripheral arterial resistance. And this so when we are measuring the cardiac output, the waveform should be always optimal and stable without any over damping or under damping. There are different types of the calibrated and uncalibrated devices which uses this arterial waveform to measure the stroke volume, but different system has the different principle. So in the Pico system, it mainly uses the systolic portion of the curve to measure the stroke volume. The another one, the Litco system, it mainly uses the pulse power analysis. What is that pulse power analysis? This method is based on the principle that change of the blood pressure about the mean is directly proportional to the stroke volume. And third one is the flow track system, that is the uncalibrated devices, and it is based on the dynamic tone technology. What is that? It measures the same waveform almost 100 times over a 20 seconds, and then it reconstruct all the datas, and then it is give the, then it will give the stroke volume. The new software of our new generation of this flow track system calibrate the data or validate data every 1 minute, so it will give the almost real-time data. What are the advantage and disadvantage of this RTL waveform analysis based cardiac output measurement? Advantage, almost gives the almost continuous data of the cardiac output, the stroke volume or stroke volume variation. And if it will be used along with the transpulmonary thermodynamic technique, then it will also tell us about the preload and the extravascular lung water. Certain disadvantage, that is still it is invasive. Optimal RTL pulse signal is required, so not useful in case of the arrhythmias, damping, or if the patient on the intra-aortic balloon pump. Now coming to the calibrated devices, that is EV1000 or volume view. The technology which used in this devices are the combination of PICO technology, that is the combination of transpulmonary thermodilution technique or RTL transpulmonary thermodilution technique and RTL waveform, that is the pulse control analysis. What is that PICO technology? It is the combination of two techniques, that is a transpulmonary thermodilution and pulse control analysis. So what is the difference between the transpulmonary and pulmonary artery thermodilution technique? The transpulmonary thermodilution technique, we are injecting the drug through injecting the cold saline through the central line, and thus this cold saline goes from the right atrium to the right ventricle, from the right ventricle through the pulmonary artery goes to the lung, and then from the lung it goes back to the right atrium, left ventricle, then through the aorta goes to the systemic circulation. And where in the systemic circulation the arterial cannula is placed, and this is the modified arterial cannula where thermistor based arterial cannula we are putting, and that name of that cannula or arterial cannula is the pulsio cap. So the injection of bolus of cold saline through the central line and thermistor sensor is based at the tip of the femoral artery catheter, that is the systemic artery. So it will goes through the whole body circulation, all the chambers of the heart, lung, as well as the systemic circulation. So because of that, its name is the transpulmonary thermodilution technique. In the pulmonary artery thermodilution technique, it is only confined to the pulmonary circulation only, so it is the pulmonary artery thermodilution technique only. So here the injection of the bolus of the cold saline in the right atrium through the pulmonary artery catheter, and thermistor sensor is present at the tip of the pulmonary artery catheter only. So look here we can see here there is this is a pulmonary thermodilution technique. Here we are injecting the drug, and that thermistor only confined to the pulmonary circulation. Here it goes all the body, and then the thermistor based arterial cannula is placed here the femoral artery. So here we are injecting, and here we are sensing the temperature change. We can see there are two types of time we can get in the two types of waveform. One is the mean transient time, and another is the downslope time. So from this time we can calculate the cardiac output by using this modified Stewart-Hamilton algorithm, and that will give a lot of data we will discuss in later slide. So when we are giving the bolus injection through the central venous, at least 3 bolus is required as a prerequisite. So if that bolus injection goes through the right atrium to right ventricle, then through the pulmonary artery to the lung, and then left atrium and left ventricle, then systemic circulation to the aorta to the systemic circulation. So as you crossing all the 4 chambers along with the lung, so it will give the different parameters like right atrium end-diastolic volume, right ventricular end-diastolic volume, left atrium end-diastolic volume, or left ventricular end-diastolic volume, pulmonary thermal volume, or intrathoracic thermal volume. So when we calculate the ejection fraction, so it will give the global ejection fraction. But if you are using the pulmonary arterial thermodilution technique, we will get only the right ventricular ejection fraction. If you are using the echocardiography, then we will get only the left ventricular ejection fraction. But look here we will get the global ejection fraction, because this bolus solution indicator is going through all the 4 chambers. So we will get the end-diastolic volume of all the 4 chambers. So this because of that we will get the global end-diastolic volume, and hence so the global ejection fraction through the transpulmonary thermodilution technique. This calibrated device also tells about whether the patient's lung is wet or dry on the basis of pulmonary vascular permeability index. What is that? It is the ratio of extravascular water to the pulmonary blood volume, and it will mainly able to identify the type of pulmonary edema, whether it is a transitive edema or exudative edema. So in case the exudative or permeability edema, there is lung inflammation, so because of the leaky capillaries. In case of the ARDS or septic lung, and there is no change in the pulmonary blood volume, so you will get this index is more than 2.5 to 3. And in case of the hydrostatic edema or transitive edema, like in case of the cardiogenic failure, in that condition there is increased pulmonary blood volume, so we will get the 2 to 2.5 value of this index, and if it is in the normal, it is less than 1. So because we are using two techniques in this calibrated devices, so we will get more data on the basis of different techniques. So if because of the thermodilution technique, we will get the cardiac output, global end-diastolic volume, intrathoracic blood volume, extravascular lung water, pulmonary vascular permeability index, cardiac function index, or global ejection fraction. And through the pulse contour parameters, we will get the pulse contour based cardiac output, arterial BP, heart rate, stroke volume. And these two parameters is very important. That is the stroke volume variation and pulse pressure variation. We will get an idea about the afterload on the basis by seeing this pulmonary vascular resistance and the index of left ventricular contractility on the basis of DPMS. So how can it will be helpful at the bedside? It will tell us about the current situation of patient on the basis of the cardiac output. We will get the global end-diastolic volume, so we have the idea about the preload of the patient. We have the idea about the afterload of the patient on the basis of systemic vascular resistance. Is the patient is fluid responsive or not on the basis of the stroke volume variation? If there is change in stroke volume, it means patient is responsive to the responses to the fluid. So more than 12% changes, we can go for the another bolus of the fluid therapy. And it also tells about that is very important information: are the lung still dry or not, whether that lung is can accommodate the another amount of fluid bolus or not on the basis of the extravascular lung water. So these are the normal value of the pico derived parameters. So look here, this is the extravascular lung water index, 3 to 7 ml per kg. More than 7 ml per kg if its lung is wet. Some studies which favors this device that and the advantage of that, the global end-diastolic volume and intrathoracic blood volume are not adversely influenced by the mechanical ventilation. And this extravascular lung water has shown to have a clear correlation to the severity of ARDS, length of ventilation days, ICU stay and mortality, and it is always superior to the assessment of lung edema by the chest X-ray, and clearly indicates that this fluid overload. This is very important slide to compare the pulmonary artery catheter based parameters on PICO or EB1000 based. Yes, cardiac output, both will tell us about the cardiac output. Regarding the adequacy of the cardiac output, yes, again, both will tell SVO2 or SCVO2 on the basis of that. Should we give the fluid? No, it has the more advantage because it will give the dynamic indices like index factor occlusion test and pulse passive Lagrangian test. Should we not give the fluid? Yes, it has the advantage because it tells about the lung permeability. Is there RV dysfunction? Here, the pulmonary artery catheter based measurement is take the advantage. It has more score compared to this method of the cardiac output calculation. And definitely, how is the left ventricle contractility? Because in this PICO and EB1000 will give the more idea because it calculates the global ejection fraction. Now coming to the uncalibrated devices, here we can see there is very important devices which we are using in our practices, that is the flow track or Vizilio. Here it integrates the multiple characteristics of the arterial pressure waveform with the patient specific demographic data. No external cardiac output calibration is required. A standard central line arterial line is connected to the disposable specific pressure of the transducer, that is the flow track transducer. And then it is connected to the Vizilio device and display the cardiac output. No center venous line is required. And if you want to use, then you can use the SCVO2 also. It is with this system, stroke volume is calculated on the basis of formula, that is stroke volume into equal to K into the pulsatility, where K is the constant that quantify the arterial resistance and the compliance. So to conclude my presentation, hemodynamic monitoring enables the early detection of changes in the patient condition. New technique provides a reasonable good result and less invasive, and this always correlate the reading or finding with the clinical picture in order to provide the best treatment options. Thank you so much. If you have any question, you can ask. Thank you so much.
Thank you, sir.
Once again.
All the presentation for today's session are over. We have 5 minutes for discussion. As there are no questions, so we conclude this session, and we thank you, Chair. We thank the chairperson and speakers for this session. Thank you again.
Thank you. Bye.
Good afternoon. Good afternoon, Dr. Gandhi. Sir, sir, can you please unmute yourself? Can you please unmute yourself? Sir, shall we start the session? Sir, shall we start? Sir, shall we start the session? Hello, Dr. Gandhi.
Yeah, please.
Yeah.
Please continue.
Good afternoon, all the delegates, and I bring greetings on behalf of Neon Laboratories, Mumbai. I'm going to talk on why hyperbaric solution of propivacane is essential. We all know that with technological advances, regional anesthesia has become safe in all age groups. It is obligatory to have safer and efficacious drug for successful outcome of regional technique. There are two chemical classes of local anesthetics, esters and amides. Currently, amide group of drugs are used most commonly. In 1957, Isacon synthesized three amides, mepivacane, bupivacaine and ropivacaine. Out of these three, only bupivacaine was used in clinical practice, but ropivacaine, being pure S enantiomer, was used for research purposes only. Aminoamides belong to family of pipeclozylidets, which are chiral compounds. That means they possess asymmetric carbon atom at the center. Chiral compounds are racemate or enantiomers, and they exist in two mirror image forms, either levo or dextrorotatory. Thus, most amide local anesthetics are racemate containing equal amount of S and R configuration. In 1979, Albright reported 6 cases of presumed accidental intravascular injection of either bupivacaine or etidocaine, which caused sudden ventricular arrhythmia and severe convulsions simultaneously. One of these cases was interestingly of caesarean section with 0.75% bupivacaine given epidurally. He published this report as an editorial on cardiac arrest in Anesthesiology Journal. Around the same time in United Kingdom, there were 5 deaths after IV regional anesthesia performed by the trainee officers. The common factors in these deaths were faulty automatic tourniquet and drug used was bupivacaine. With these events occurring all over Western world, US FDA withdrew permission for bupivacaine in obstetric cases. This sequence of events provided the impetus to develop a new safe local anesthetic. Ropivacaine was thus re-evaluated and subsequently released into clinical practice in 1996. We all know ropivacaine is almost similar to bupivacaine in chemical structure and has propyl group on the piperidine nitrogen atom, whereas bupivacaine has butyl group. The short length of carbon side chain on tertiary nitrogen atom makes ropivacaine less lipid soluble as compared to bupivacaine, and it also influences the potency of ropivacaine. It is said that ropivacaine is less toxic, but why is it so? The cardiac sodium channels favor local anesthetics in the R configuration, which results in for the increased cardiotoxicity with R enantiomers such as bupivacaine, whereas ropivacaine is a stereoselective and a pure S enantiomer. It has short length of carbon side chain on tertiary nitrogen atom, hence less lipid soluble. Due to these two factors, ropivacaine has less cardio and CNS toxicity than bupivacaine. Ropivacaine is less lipophilic, hence penetrates less into large myelinated motor fibers and has selective action on pain transmitting A delta and C fiber. It has a more selective sensory versus motor blockade, and therefore it gives a differential block. According to minimum local anesthetic concentration, ropivacaine has similar potency at higher doses and less potency at lower doses compared to bupivacaine. Overall, it is 40% less potent than bupivacaine, but in equipotent doses, when used in ratio of 1.5:1, it gives comparable block characteristic. Ropivacaine commercially available since 1996, but it came much later after a decade in India. In 2009, Neon introduced isobaric ropivacaine, Ropin, with different concentrations for various indications. However, with the constraint of caudal and cephalid spread, the use of plain ropivacaine for spinal block became limited. August Bayer himself observed the great interpatient variability in spread of plain solution, and he described it as Leeuwenhoek waywardness. It is known that most plain solutions exhibit greater variability in effect and are less predictable, so that the block may either be too low and therefore inadequate for the surgery, or excessively high causing side effects. G. Hawkins and the other colleagues, they describe hyperbaric solutions are more predictable with greater spread in the direction of gravity and less interpatient variability. There are many mechanisms of the drug spread in the CSF. These are interrelated in a very complex manner, but barosity and gravity are most important factors for the spread of the drug in the CSF space. Gravity is applied through patient position, either in supine or sitting position while the spinal being given, and in the horizontal position it is influenced by the curvature of the spine. Barosity is nothing but with a specific gravity, and these two terms are analogous with each other. Almost 100 years ago, Barker systematically studied factors affecting intrathecal spread and concluded that gravity and the curve of the vertebral column could be used to influence the spread of solution which are made hyperbaric by addition of glucose. Commercially available local anesthetic contain glucose up to 8% to make them hyperbaric. Thus, glucose-free solutions are marginally hyperbaric, produce unpredictable spread, result in inadequate distribution of block, and gravity does not encourage their spread in the supine position. As opposed to this, addition of glucose to local anesthetic increase its density, makes it hyperbaric, results in more even distribution, more rapid spread with a less variation in sensory and motor block, and gravity does help the spread of drug down the curve of lumbar spine. Considering the essentiality of hyperbaric ropivacaine, Neon initiated the mission of making hyperbaric ropivacaine. After an extensive process for patent, animal toxicity studies, and clinical phase 3 trial, marketing authorization for hyperbaric ropivacaine was obtained by Neon. The highlights of the clinical trial done by Neon is as follows. A phase 3 multicenter randomized double-blind parallel group comparative clinical study to evaluate efficacy and safety of hyperbaric ropivacaine with that of 0.5% bupivacaine in 218 subjects at 10 centers all over India. There are 2 patients who did not achieve sensory or motor blockade in bupivacaine group in this particular study. The maximum peak level of the sensory block achieved in the patient, in maximum patient, it was above T10 and ranging between T9 to T4 in both the groups. The efficacy parameters like sensory block up to T10, maximum sensory block, onset of motor blocks and regression of the block, all these time slot in both the groups were statistically comparable in both the groups, suggesting that the block characteristics are comparable with ropivacaine and bupivacaine. The summary of the safety profile is as follows. The overall 24 events occurred, out of which 9 were in ropivacaine and 15 were in bupivacaine. All these adverse events were mild in nature and did not warrant any active management, suggestive of safe profile of ropivacaine. 7.5 mg per ml dextrose and the efficacy parameters were also statistically comparable in both the groups. Thus, in this phase 3 clinical trial, 0.75% hyperbaric ropivacaine has shown comparable efficacy and better safety profile in comparison with 0.5% hyperbaric bupivacaine when used by spinal route. Neon brings 0.75% hyperbaric ropivacaine as ropine heavy 0.75%, a less cardiotoxic drug, hence safe molecule. 0.75% is equipotent with 0.5% bupivacaine with comparable efficacy of block characteristic. It holds a promise of predictable and reliable spinal block. So, we look forward to your valuable feedback on this new arrival from Neon Pharma. So, and we request all the esteemed members of this gathering to bless our new molecule. Thank you very much.
Thank you. Any questions on this topic, please? The audience can ask the questions if they have any difficulty. Thank you very much, all of you, for the patient listening, and we do look forward to your feedback on this new molecule. And if any kind of a this thing literature search or any kind of a this thing assistance is required, please free to call on us at Neon Laboratories. Thank you very much.
Good afternoon, everyone.
you.